I'm visible. Okay, that's fine. Thank you. morning, Dr. Karnadas.
Medical College.
Okay. The participants.
I'm yet to see the slides.
Yeah. Yeah. Anand, have you already?
Sir, can we start, sir?
Yeah, yeah, we should.
Slides are running, sir.
Still not running.
Yes. Now, sir.
Yeah, now it's okay. Okay. So can we begin our question answer session? Dr. Ketan, nice concept. In
Thank
fact,
you, sir.
this was need of the day because a lot of many patients were on anticoagulants. Uh, for how many? I mean, what is the duration of anticoagulation that you have been following up?
Yeah.
And number two, uh, I mean, many of them had NOSC. So I believe there was no need of getting INR done, right?
Yeah.
So, uh, um,
So, can I
that was the
just give you a brief outline quickly about it, sir? So, in
yeah,
fact, what we have seen that in spite of patients who were given thromboprophylaxis during hospitalization, we had seen the patients were coming subsequently with the complications of thrombotic episode, so whether in the form of a DVT or a sudden pulmonary embolism, because they were being given only during the stay of the hospitalization. And that was the idea, that we should go ahead and study what is there. And here what we found, that consensus is, of course, the minimum 2 weeks, and there were groups of people who said even up to 6 weeks. So that is beyond 1 month also. So probably the D dimer would be the one factor which will tell. Unless the T dimer comes back to normal, we need to give a thromboprophylaxis for these patients, not only just during
So
hospitalizations.
how frequently did you do a D dimer?
No, sir. Here it was just a overall the real world experience which we have taken from the people. So people were free to do it as per their discretion. But what we found in our practice, and if those were found to have been elevated, maybe we do it after another 2 weeks, and to see until the D dimer comes back to normal, we have continued giving them thromboprophylaxis to avoid the complications of the obviously long-term problems of the COVID-19, sir.
Okay. Okay.
And this was the probably, sir, the larger what we found out in the Indian consensus, probably during the peak of the season, when we had got the largest data, taken it from the all strata, from a tertiary care center to even a primary care center, from a metro cities to even the tier D cities also, and people who were the senior professors to write for those who were into immediately into the practice. So we
I
could
believe
get.
we are going to publish this, right?
Yes,
This
sir.
is quite a good one. Yeah.
Absolutely, sir. Thank you so much, sir. Uh,
Thank you.
Sir, Dr. Karunadas has any queries, sir? I
Ketan, did these physicians have experience in treating COVID?
Yes, sir. So we had selected those ones
Experience
who,
in treating COVID
yes, sir.
patients?
So
How many COVID patients they had treated?
so all these doctors who had taken it into, so in their interview, that was the first question. Those who were already into practice, then only those who had taken it. So maybe few might be treating 2 or 3 per day, and few may be treating those who are in the government setup, maybe 20, 30, or 50 also. So it was only those who were taken into it, sir.
Thank you.
Thank you, sir.
Great.
Thank you.
So we can move on to Dr. Anuradha's e-paper, I mean e-poster, and her talk is on trends and outcomes of acute coronary syndrome in COVID-19 pandemic, experience from a tertiary care center.
Yes, madam, you're on.
And Dr. Anuradha is from Vizag, Apollo Hospital. Yeah. Yeah. It was a nice study. Anuradha, how many of your patient had those presented with ACS had COVID positive?
Sir, good morning, sir. Thank you very much, sir. Sir, initially during first 3 months, we did not check any patients for COVID-19 because our hospital has not that facility during that time. So first group, they were not tested, sir. In the second group, yes, sir. There are almost 12 cases were positive, sir.
And you could thrombolyze only one patient in that, I mean, STEMI group, right? In
Yes,
2000.
yes,
And
sir. Yes,
so,
sir.
okay. Uh, Dr. Karuna, anything
What is the
you want to
median? Yeah, yeah. What is the median length of stay of these patients?
Yes, sir. 5.8 plus or minus 3.2, sir.
Why did you choose because we started lockdown in March 22nd.
Yes, sir. Yes,
Would it have been better if you had chosen from that day onwards? Because initially,
yes,
maximum patients you have in March. Probably
yes,
that
sir.
was 22nd.
Yes, sir.
Was it
Yes, sir.
like that?
Most of the patients contributed in the month of March, sir.
Okay.
Yes, sir. From that reference, in the month we have
Yeah.
cases
And
of
I would like to
113.
point out yeah, that is right. And one of your slides says that your study is up to September 30 and another one up to August 31.
No, sir.
Did you
August
notice that?
31st. Sir, August 31st only, sir. Sorry, sir. That was the
No,
mistake.
first slide.
Well,
Okay. There is a factual error in the first slide. Okay. How did you do the statistical analysis? Nothing is
uh,
mentioned about that.
yes,
What
sir.
tests you
SPSS
used?
20 only, sir. SPSS to SPSS, sir.
No, what test for doing the statistical analysis? SPSS just gives you that
Yes, sir.
numbers. They have to
Yes, sir.
put into certain tests.
Yes, sir. Yes, sir.
What test did
Chi-square
you
test, sir.
use?
Chi-square test, sir.
Okay.
did your center participate in the I mean ACS registry done by CSI?
No, sir. No,
Okay,
sir.
you should have. Okay,
Yes, sir. A lot of people have to be convinced for that.
yeah,
Thank you, sir.
welcome.
Okay. Thank you.
Thank you very much, sir.
Thank you. So
Sir, we can move to the next speaker.
yeah, sure. We shouldn't wait.
Yeah.
Okay, sir.
Yes, sure.
So the third is by Pradeep Mate.
No, sir.
Uh,
It's by Dr. Mahesh Abhyankar.
okay, Dr. Mahesh is there. Dr. Mahesh Abhyankar, good morning. So your slide is, I mean, presentation is on challenges and practice pattern of dyslipidemia management in India during COVID-19 pandemic, a cross-sectional survey. Okay, this is it.
sir.
Good morning, Dr. Mahesh. So, how many? I mean, of your patients, what was the percentage of patients who left statins during this period?
Actually, the statin discontinuation, as per the opinion, is around 10 to 20% of the patients, around and 20 to 30% of the patients. Overall, 54% of the doctors opine that the statin was discontinued is around 20 to 30%.
Big number. Dr. Karna, yeah. You're mute, I believe. Dr. Karna is mute. Yeah.
Actually, if you look at all the studies, patients were reluctant to come to doctors during the COVID season. So how could you get this follow-up that
This
they
actually,
attain their goals or not?
the study was actually done in July and August, where actually first that March, April, and May, all the 3 months have gone, and the patients started coming to the doctors, and the investigation facilities were slightly opened up at that time. So the lipid checks were done by the doctors, and on the basis of that, actually, the opinion was given by the clinicians.
What was the goal you asked for, the clinicians? I mean, what did you say that such and such LDL level is a goal? What did you ask for?
We have not gone for
You
a
said
very
many
high.
were out of goals.
Yeah, the goal actually, the LDL goal was kept at 100 only, based upon the and the previous records which are available with the doctor. And it is not like less than 50 or less than 70. A very high goals we are not kept, but it is less than 100 we mentioned in the goal. For those who are already on statins for at least minimum for 1 year.
What I asked was, did you keep a standard goal for all doctors, or the doctors referred to their old records and said that, okay, this patient has gone out of control?
See, the standard
Did you
100
get
goal
me?
was given to the doctors, because otherwise there will not be uniformity across the opinion. Yeah.
And you finally concluded that rosuvastatin is probably slightly better. Is it related to the COVID situation or in general?
It was related to the in terms of COVID situation. The opinion was asked because of the comorbidities, where the diabetes, ACS comorbidities, and these are the comorbidities where the doctor, and even stroke, where they suggested that the statin, in terms of statin usage, rosuvastatin might have done some, because the anti-inflammatory action also.
Okay.
That question was there, that anti-inflammatory action is relevant to this particular COVID or not. That was positive on it.
Okay, thank you.
Right.
Thank
Shall we move on?
So, yeah. So, our next presenter is Dr. Shahud Azaz Kakru, and his talk is on clinical angiographic profile and immediate outcome of COVID-19 patients presenting as ACS, an observational study. So, Good morning, Dr. Ajay.
Good morning.
So, uh, uh, how many of your patients were positive, COVID positive?
Sir, 25%, sir. 5.8% of the all patients who presented with ACS to our hospital.
Okay. So, you have not mentioned about D-dimer in those patients. Do you think it was not required or something?
D-dimer, actually, sir, all of these patients, we managed in emergency only, sir. So,
Okay.
on the emergency basis, because of the financial constraints also, and only one patient out of them had DVT, who had signs of DVT. So, we did the scan for Doppler for that patient. Otherwise, we did not do the inflammatory markers.
Okay. Dr. Karna? Yeah.
What was the main time of presentation? You just said outside window period.
Mean time of presentation in the STEMI group was 6 days, sir, whereas in the NSTEMI group it was around
Dr.
10 days.
Shahud?
Yes, sir. Hello? Am I audible, sir?
Yeah, you are. I believe Dr. Karna is listening
STEMI
you.
group? STEMI group?
STEMI group had a main presentation of, sir, around 6 days, sir, and NSTEMI group had 10 days.
Yeah, you are audible.
So basically there was a delayed presentation, sir.
What was
Only
the angiogram finding?
angiogram finding was single vessel disease in of the 5 patients we did, sir, angiogram, sir, who had persistent chest pain. And that one patient had single vessel disease, 3 patients had double vessel disease, and 1 patient had TVD, sir, which went for urgent coronary artery bypass surgery, sir. And in the those single vessel and double vessel disease, in the 3 patients, PTCA was done, sir, but in 1 patient, PTCA was attempted, but it was not successful.
Okay.
Yes, so we can move on to, and I believe your center also participated in ACS registry done by CSI.
Yes, sir.
Yeah, that's good.
But we started a bit late, sir, because in Hyderabad it was a non-COVID hospital during initial months, sir.
Okay.
So from May onwards, sir, we started admitting. Once our department, cardiology department, was the first department to get affected with COVID in Hyderabad, sir. Our whole department got infected. So finally, they started COVID also here, sir. Subsequently.
Okay. All the best. So you have another talk also. I mean presentation also.
Yes, sir.
Yeah. Okay.
Thank you, sir.
Next is Dr.
Sir, Dr.
Karthik
Karthik
Yadav.
Jadhav is not here, is not joining, sir.
Okay. So we can
So,
move on to the next one. Dr. Jan, Akshay Jan.
Yes, sir.
so 1 second, sir.
Yeah.
Good morning, sir.
Yeah. His poster is on retrospective analysis of acute coronary syndrome profile before and after COVID-19 pandemic
Yes,
began. Single center observationally in a tertiary care center in Mumbai Metropole.
yes.
Okay.
Good morning, everyone. I am Dr. Akshat Jain, a senior resident from Grand Government Medical College in JSR JJ Group of Hospitals. My presentation topic is retrospective analysis of acute
You need
coronary.
not
So,
Okay,
No,
talk
no,
on
no,
that
you're not present.
okay,
after question.
Need not
okay.
present.
Dr. Karuna, you have to ask.
Nice paper, Dr. Akshat Ajay.
Thank you, sir.
How many patients were actually COVID positive?
Sir, in the COVID-19 group, there were total 14 patients, 10% of the study group who were positive. Although we cannot utilize them for the follow-up, because once the patient came COVID positive, we used to transfer after 24 hours to the COVID hospital. Our hospital per se was a non-COVID center.
Okay. Did you follow them up, about their mortality or something? Any telephonic conversation or data collection?
Yes, sir. It was just a group of our hospitals, the St. John's Hospital, and which was already associated with our hospital. Of those 10, 2 patients died, and we included that data of mortality in our study.
What is the main cause of mortality in your patients in the COVID era? Cardiac failure, arrhythmia, or
Sir,
what was
most commonly what we have seen was refractory heart failure and refractory cardiogenic shock. That was the most common cause, followed by arrhythmia. Most of the patients were coming late, sir, for the presentation. Mean duration was 7 hours more in the COVID-19 group as compared to previous times. And secondly, sir, we were going with pharmaco-invasive approach in the COVID time. We were waiting for the RT-PCR reports to come instead of directly taking the patient to the cath lab. In spite of different yojanas available for the patients, but due to COVID report, they have to wait for at least 16 to 24 hours before they could be taken to cath lab.
So you expected pharmacoinvasive approach to be inferior to the direct PCI approach?
I did not. That was not our expectations, but what we have seen that late presentation combined with pharmacoinvasive approach has given more mortality. We had 17.1% mortality in COVID-19 group as compared to only 7.3% in pre-COVID-19 group. So there was significant increase in mortality. The p-value was also less than 0.01.
You chose the pre-COVID period, no? Would
Yes.
it not have been better to choose a 2019 February to July and compare it to February to July 2020?
Yes, sir,
Because
that could have been better to start the study from March and compare the similar months.
yeah, similar months in the last year. That would have been slightly better, I feel.
Yes.
Okay, thank you.
Welcome. Thank you, sir.
So next, I believe, will be Dr. Anshul.
Morning,
Right?
sir. Yes, sir.
Yeah. So your talk is on the COVID-19 pandemic and decrease in acute ACS presentations in Western Rajasthan, a single center retrospective observational study, and you are from Jodhpur.
Yes, sir.
Right. Okay.
Good morning, respected teachers and dear colleagues.
You need not, talk on
Okay,
that.
sir.
Just
Okay.
we'll go
No,
through
no
the.
presentation. No
Yes, sir. Sir, basically, we did this study. It was a retrospective.
We'll just ask you once the question session, answer session starts.
Yes.
Then we'll ask certain questions
Yes.
that you'll be answering, right?
Yeah,
Okay,
yeah.
Let
Okay,
us
sir.
first.
Okay, thank
Yeah.
you.
Thank you, sir.
Can you just tell me, because I did not understand from the slides, what are you looking at? Initially, you said you are going to compare 2019 data with 2020 data. Then you started comparing between the months of 2020. So what are you doing? What were you looking at?
Sir, we were looking why the total admissions, number of patients, number of procedures was decreased during the COVID period from March to May, sir, between April and May, sir, basically, and we compared it to show that there was absolute decrease in the number of admissions and the procedures as compared to this year and previous year also, and because the non-communicable diseases like STEMI and non-STEMI are they have no change during this pandemic also, because they have the same number on as they are occurring at that same rate, but there was absolute decrease in this number, and as we see that there was decrease by 70% and 65% in CCU admissions. So we were trying to find out the cause behind decreased presentations of ACS. Patients were not reaching the tertiary care centers because of lockdown period, because of no non-availability of communicable communications, and public transport was not there, and all the fear was there, sir. The fear of catching the corona infection. That
Okay,
our
okay.
hospital was COVID
Okay,
dedicated
I get
center
it.
at that time. Yes, sir.
One more thing. In May, all your coronary angiogram patients went for plasty. If you look, all the patients were
Yes,
taken
sir.
up for PTCA in May.
Yes, sir. All of them.
Any explanation for that?
Sir, all of them were having a STEMI
What
or
were
non.
the findings?
Sir, only 16 and 19 angioplasties were done between April and May period, sir. In the
No
month of.
thrombolysis, no pharmacoinvasive, nothing.
Yes, sir. We have done. We have performed thrombolysis also. Initially, we did the thrombolysis, but there was no primary PCI was done between April and May, and the number of patients were very less. And sir, all of them were having culprit lesion also. So, and there was no angiography or angiography of stable ischemic heart disease patient, because all of them were having MI. Mostly they were having STEMI, sir, and some of them were having non-STMI.
Okay, okay.
Thank you. Thank you. Nice.
Thank you, sir.
Okay, thank you.
Thank you, sir.
Next is Dr. Gurve's presentation on active surveillance with telemedicine in patients on anticoagulation during the national lockdown, COVID-19 phase and comparison with pre-COVID-19 phase. Okay. So we had a similar talk earlier also.
Okay, thank you.
Good morning.
Which period you chose as the pre-COVID period?
So pre-COVID, we chose as November to December 2019. We had two reasons for that because most of our patients they come for follow-up after 3 months, 6 months, or 1 year. So we didn't want a repetition of the same patients in both the groups. So we took November, December as the pre-COVID, and March, April as the COVID period.
Good.
How did you actually do this? By phone call?
Sir, we used phone calls and WhatsApp because some of these patients they are from rural areas. They are unable to understand the technical terms on phone calls. So we some patients we also used video calling through WhatsApp, and we also had a Facebook account made during this period in the initial days when the lockdown was there. So we distributed that Facebook link to all these numbers, and they could also contact us through that Facebook. And we had dedicated 2 hours per day by rotation of all the consultants. If anybody wants to talk specifically on some issues, they could call at that time also. Otherwise, we had three nursing sisters and two interns who used to call these patients, and they made sure that in both the groups the patients are not same.
Okay, okay.
Uh, Gurvesh, you had a few patients on NOSC also, right?
Yes, sir.
How was the complication rate between the two, between NOSC and VKS?
Yes, sir. Actually, we had around 15% patients in the pre-COVID phase and around 16% who were on NOACs. The reason for these patients being less on NOACs is the non-availability of antidote immediately, and it's very costly, sir. And if we although the comparison cannot be made because of that significant difference in the numbers, but I just try to calculate that the incidence of major bleeding events or thromboembolic events, uh, the patients who were NOACs had lesser number of thromboembolic events, but although not significant, a tendency towards significance for the major bleeding events, although the numbers were very less.
Oh, nice idea. Okay. Uh, Again, I think, thank you. It was nicely done. Very good practical approach.
Thank you.
So we have a second slide from Dr. Azaz on clinical angiographic profile and exercise stress test of myocardial bridging patients working in coal mines, an observational study. Okay. Uh, Dr. Azaz, was there any specific reason that you chose coal mine workers for this study? You're not audible.
You are not audible.
Yeah.
Sir,
No.
just plug out your headphones, sir.
Sir, of all the angiograms, sir, we did in last 1 year, sir, of all the patients, we found a trend that in coal mine workers, the incidence of myocardial bridging was more than the general population. Because every day we used to do the coal mine workers, one or two used to have myocardial bridging. The general population had less number of patients who had myocardial bridging, sir. So that's why we taken the study retrospectively for last 1 year, sir. In that we seen 527 coronary angiograms of singer in this coal mine workers patients, and we seen that around 25 patients, that is 4.7%, turned out to be myocardial who had significant myocardial bridging.
Do you have any explanation for this? Is it
Actually,
due to the left ventricular hypertrophy?
Yes, sir. Actually, sir, this coal mine workers, it is basically a high labor job, sir. It presses an additional cardiac stress, sir. And second, sir, because they are working in the coal mines and with decreased oxygen levels, sir, that may also play a role, sir. And third, that because of the high labor job, there may be LV hypertrophy and increased cardiac stress, which may cause the endothelial dysfunction, which are the possible causes in this population.
Your group 2 patients had myocardial bridge and coronary artery disease, but TMT were more positive in group 1.
Yes, sir.
Any explanation for that?
Sir, actually, because the coronary artery disease in the group 2 patients, and it was minimal coronary artery disease. None of our patients had significant coronary artery disease. All who had the coronary artery disease had in the same vessel, and it was non-significant, sir, non-critical CAD. However, the factor profile between the two patients, it went consistent with the coronary artery disease. The coronary artery disease had more incidence of diabetes, smoking, so they had more prevalence in that. With a significant p-value.
Do you think that this bridge is congenital or acquired as part of LV hypertrophy? What's your
Sir,
concept?
it is a likely it is an acquired condition only because we are seeing more frequent myocardial bridging in the coal mine workers than the general population. General angiograms we are doing for chronic stable angina or unstable angina, sir. But myocardial bridging predominantly we see in the coal mine workers. Sir. It needs further evaluation, sir, for this studies.
You're right. You're right. Thank you.
Thank you.
So, okay, sorry.
Shall we move on?
Uh, we are with Dr. Reddy's presentation on
Yes.
assessment of left ventricular function. Yeah, by myocardial strain imaging. Okay, and cancer patient before and after chemotherapy. Yeah. Good morning, Dr. Reddy. It was a nice study, and it is a well-known fact. In fact, what's new that you got in your study?
So in our setup, we are not routinely doing myocardial strain imaging, sir. We are doing only routine 2D echo, sir, so that
Okay.
we do strain for all the patients who are undergoing chemotherapy, sir.
Mhm. Dr. Karna, anything more? You're mute. Yeah.
In the criteria, you
Yes,
said,
sir.
can I hear you? Can you hear me, sir?
Yes,
Yes,
sir.
sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
Okay. Okay. Ejection fraction more than 55% and ejection fraction less than 50% you have mentioned. Don't you have values in between? Where did you put them?
Sir, usually we have taken people who have more than 55%.
Did you?
Hello,
As
sir.
normal.
Yes, sir. More than 55% people only we are taking into the studies.
Yeah, I can hear you. I can hear you. Okay, right. You only did twice, is it not so?
Yes, sir.
Did you do in between the chemotherapy?
No, sir.
Only at the beginning and at the end, is it not so?
Yes, sir. Yes, sir.
Don't you think it is ideal to do in between so that, as you suggested, we can stop or modify the chemotherapy?
Yes, sir. We can do, but my study is to do before and after chemotherapies, so that we can detect more patients who have LV dysfunction.
Is it more time consuming?
Yes, sir.
Is it more time consuming
Yes,
than
sir.
looking at
Definitely.
the regular ejection
Yes, sir.
fraction?
Yes, sir. Time consuming, sir. Because images and all will not be clear, so it will take some more time to
In the
get the images.
average time, how much you take?
Average time in 20 to 30 minutes.
I mean,
Did you look
you're
at the
you're doing automated one, or you are taking the three views separately? I mean,
So automated one is this. We can adjust the markings, sir, based on our.
okay. Yeah, Dr. Karna, you're asking something.
that's all, sir.
Well, yeah, we have finished. Yeah. Thank you, Dr. Reddy.
Thank you, sir.
No. Finished.
I think uh, the last is Dr. Pinkesh Parmar.
Sir, before
Uh,
that, we are
okay.
going to
Ashish.
Ashish Gota.
Yeah. Incidence, association, and outcomes of perioperative myocardial injury in patient undergoing non-cardiac surgery in a tertiary care center. A study from Northeast. Welcome. Yeah.
Good
Okay.
morning, sir.
Yeah, good morning, Dr. Ashish. Don't you believe that 28 plus percent of myocardial injury incidents in these patients were quite high?
Sir, in the previous studies also, even in the POISE study, they have found up to 36% incidence. So this depends upon the type study population, then the study design and the biomarkers selected. So in previous studies also they have found varying results, and in my studies I found around 28%.
How many of your patients were on beta blockers
Uh,
perioperatively?
Perioperatively, around 30% of my patients were on beta blockers.
Dr. Karuna, anything?
You said the death of 10 patients in 43 among post
Yes, sir.
perioperative myocardial injury, no?
Yes, sir.
But 6 died due to sepsis.
Yes, sir.
So the main cause is sepsis.
Sir,
Don't you think so?
sir, perioperative
So how can you
myocardial.
conclude that it is due to perimyocardial injury?
Sir, sepsis also is one of the cause of myocardial injury in previous studies also. Spontaneous MI is less common, but definitely 40 to 60% of the population is due to non-cardiac causes, like sepsis is one of the important causes. Then other causes like PT, stroke, AKI, all these can lead to myocardial injuries.
So can you conclude that it is the myocardial injury that leads to death?
Sir, this requires more RCTs to conclusively prove, but myocardial injury is definitely associated with increased mortality, then hospital stay and the cost of treatment.
You did not show any data on the age and sex of patients, but you concluded that increasing age and male sex has a correlation. How did you do that?
Sir, actually, I didn't because I have shown only pictorial form. I didn't, but otherwise, mean age of my patients were 65 in PMI group, and non-PMI group it was 55. And in male PMI group, male patients were 65 and female patients were 35%.
Okay, okay, good.
Okay. Thank you, Dr.
Dr. Satish?
Thank you, sir.
Yeah, we have finished. I think we are going with the last presentation by Dr. Pinkesh on clinical profile of patients with severe pulmonary arterial hypertension. Okay. Yeah, Dr. Pinke's very
Yeah, good
simple
morning, sir.
question. Good morning. How did you decide that these are acute cases and you excluded them?
Sir, the cases of like acute pulmonary embolism or some we had patients of myocarditis which had recovered. So these cases we have excluded from the study and we have not followed them up. And the chronic cases which remained in severe pulmonary artery hypertension on echocardiography, then we have followed them up for 1 year, sir.
Okay, so Dr. Karuna.
I could not find any cause, I could not find any case of LV dysfunction.
Sir, most of the cases were of valvular heart disease and of the congenital heart disease. Sir, there are cases of LV dysfunction. The total, sir, cases of in sir, there were cases of LV dysfunction. We have also done coronary angiogram, and 6 patients were having a coronary artery disease also. And
Where is it included?
sir, well, actually, I did not bifurcate them. In valvular heart disease, total 103 patient also includes the cases of other causes of left heart failure leading to right PAH, sir.
How did you find about the mortality? How did you follow up?
Sir, we were following these patients every around 1 or 2 monthly according to the disease, and with telephonic talk also. Some patients with the respiratory disease, they were not following directly with us. They were following with the respiratory department, and we had following them up with the telephonic talk, sir.
But there is some disparity in the mortality data, is it not so? If you take the total number, it is only 672. If you add up the numbers, it comes only to 672. That is only 70% of your total patients. So did you not get the data from 30%?
No, sir. We have got data from all the patients. Actually, we had divided the patients into 2 groups. Those having a pulmonary artery, the PA pressure more than 90, and then the PA pressure less than 90, sir. And when are adding the 2 groups, then the total number will be, sir, the same. In more than 90 group, 456 patient, and less than 90, 508 patients. So total number is 964, sir.
Okay.
Yes, sir.
Okay, thank you.
Good.
So with more than 90 pulmonary artery pressure, the mortality was higher, sir. But it was not significant in left heart disease patient, as it was also left heart disease itself is a confounder leading to mortality in such patients, sir.
Okay.
Still, Dr. Karthik Jadhav has not, been attending.
Joined. No.
Yes,
So
sir. Yes,
will
sir.
mark it absent or what? How to mark it? Or we can mark other things without the question answer session?
Sir,
Dr.
I think we will mark the other things. We will
Okay.
mark the other things and put 0 for the question answer session.
Okay. Okay, so thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Shall we leave the session?
Thank you very much, sir. Thanks a lot.
Sir, you are online, sir.
Okay. So are we ready to go?
Yes, sir.
Okay. Okay. Good morning to everybody here in this session, and this is going to be a very, very interesting structural and peripheral intervention session in the CSI 2020, which is the online meeting first time. So I'm sure we are learning a little bit here as well. But today the session is a very, very educative session on these issues of valvular heart disease interventions and aortic interventions. And along with me, my co-chair is Dr. George Joseph. He is one of the, the finest exponents in the, the aortic interventions. And along with Dr. George, we have Dr. Biju Lal, who is going to be as a chair in this session. So I will quickly move on to the sessions because it is a very tight program, 7 minutes of presentation for each participant. So please stick to your time, and we will be having just 1 minute of discussion, maybe one or two questions, and that's it. So that's the program which has been given by CSI. So we'll move to the first presenter, which is Dr. Ravinder Rao on TAVR in bicuspid aortic valve. So Ravinder.
Sir, Dr. Ravindra is not there, sir. He is not connected.
Okay, so we'll move quickly to Dr. Manik. He is already there. I can see him. So, Dr. Manik, can you start your presentation on valve and valve tower on optimizing outcomes? You can't hear Dr. Manik.
You have to unmute yourself, Manik.
Sir, sir, unmute, sir, please.
Hi. Am I audible now, sir?
Yes, yes.
Okay, sir. I would quickly start, sir. Okay, so my topic is valve and valve TAVR optimizing outcomes. I would quickly try to describe it in 5 headings: understanding the surgical bioprosthetic valve, understanding the transcatheter valve, understanding the principles of valve and valve TAVR, and a great help is valve and valve app by Dr. Bapat, coronary obstruction and valve and valve TAVR, which is sorted out by Chimney and Basilica, hemodynamics and TAVR, which is related to the choice of valve and fan fracture. Let me go to the, yeah. So understanding the structure, you can see that there is A, which is basically the swing ring, and B is basically the surgical post with a circular frame down, and C is the valve leaflets. Now, surgical valves can be typically divided into 3 groups: Group A, B, and C, done by Dr. Bapat. The Group A says that you have something of this sort, in which you have the swing ring, which is slightly higher than your valve frame. Then you have type B, in which you can see the swing ring as a marker. Either it is intra as well as supraannular. You can see it as a marker. This is an intraannular valve, and this is supraannular valve. And this is again Group A, in which you can see the intraannular, in which there are 2 levels, and supraannular, in which there is 1 single level. So, and then coming to Group C, in which you have no markers at the circular frame. It's just stent posts which are marked by dots, which is just like a mosaic valve, and then a completely radiolucent valve. So this is how, and then you have stentless valves. You can see Toronto SPV route, freestyle valve, and you can see Freedom Solo valve. Now, in these valves, there are 2 techniques. One is subcoronary technique, and one is with the aortic root replacement. The subcoronary technique will have higher chances of obstruction, while the root, because the coronaries are being implanted higher, should have lesser chances. Now, also we have to understand the dimensions. We have almost, like, I would say, 4 dimensions. The external is the swing ring diameter, but the number which we get on the valve is basically the outer diameter, which is called as a mounting diameter. Outer to this is the external ring, which is swing ring. Then you have internal diameter, which is called as ID of the stent frame. And then you have true ID, which would be subtracting the valve leaflets and other tissues which are there in between. Also, regarding the height, this is a complete profile height. and this is the degree which protrudes into the annulus. So this is typically for intraannular. For supraannular, you can presume that aortic as well as the profile height is just the same. This is again talking about the true ID. So if it is a a porcine valve, you can subtract 2. For this valve, you can subtract 1. And if the leaflets are being sutured outside, then the true ID is equal to the stent ID, which is true for trifecta and mitral flow valves. Now, understanding the transcatheter valve, this is again a self-expanding supraannular valve. You can see the skirt is almost like 1.5 diamonds, and the typical level is like 13 millimeters. This is portico valve, which is intraannular. You can see it is slightly lower, and the cells are larger. This is accurate neo, and then you have sapien. And this is out of market now. So sizing of THV, depth of THV, typically sizing of THV, I would say whatever is the true internal ID, you will have to increase it by 1 or 2. If the valve is very stenotic, you can just go with 1. Regarding the depth of the implant, the anchoring basically happens at the swing ring. You can see the balloon inflated, and the narrowest portion is at the swing ring. So basically, swing ring is the neo-annulus, and you anchor at neo-annulus. So typically 3 to 4 millimeters below the neo-annulus. So for intra-annular valve, you will like to align it exactly at the lower point of the stent frame, while in supra-annular, you will like to probably go 3 to 4 millimeters down. Then the second thing is regarding the leaflet coverage. You also want to make sure that the degenerative bioprosthetic valve is completely covered. This would be especially true for sapien valve because it is a short frame valve. And then the function of THV leaflets, especially for supraannular leaflets, you want that height should be superior so that your leaflets open well. Leaflets are starting at 13, and most of the frames are something like 14, 15. So you have an opportunity that the leaflets open very well. Of course, all this taken together, understanding this valve, understanding the THV, and understanding the principles, everything is being very clearly demonstrated and illustrated sweetly in Valve and Valve app by Dr. Bapat, which would also give us some illustrations. Now coming to the risk of now these are something which are fine optimizations. So the coronary obstruction and valve TAVR, these are the risk factors: low lying coronary ostia, low STJ, low sinus height, low coronary sinus of Valsalva, previous root repair, supraannular position of the bioprosthetic valve, high leaflet profile, extending sealing cuff, and high implantation. Now, what do you see on CT scan? Of course, the coronary heights would be important, the sinus of Valsalva diameter, and then you also calculate this very important VTC distance, that is virtual THV to coronary ostia distance. Less than 3 would be high risk, 3 to 6 is intermediate, and more than 6 would be low risk. So what if you still need to go ahead and the VTC is less, and probably you think that the coronary obstruction is going to happen? You would have to put a wire inside the concerned artery, and you'll have to probably take a stent with the help of a guiding support. And at the end, you decide whether you want to deploy the stent or no. You can withdraw the stent and then deploy it. This is how it was done for a Sapien XT valve. Now coming to basilica, this is vivid classification, which is recently published by Dr. Tang. You can see type 1, in which the leaflets, in which the coronary ostia are higher than the leaflet, the frame. So you are not bothered, whatever it is, your coronaries are protected. Type 2 is when it is like below the level of sinotubular junction, the top is sinotubular junction. If they're wide sinuses, there's no problem. If they're effaced sinuses, then you need to think. Now coming to type 3, in which the valve frame is extending above the STJ, and then if it is wide, no problem. If it is effaced, means both STJ as well as sinuses are effaced, it's a problem. If it is a narrow STJ, then also it's a problem. The number for narrow STJ, like less than 2.5 would be critical, and 2.5 to 3.5 would be borderline. Now, this is a small chart which is given for basilica. Again, considering the leaflets, if they are extending above, there is no problem, go for conventional TAVI. If they are lower, you see whether they are above or below the STJ. If they are above the level of STJ, you see the VTC distance, and then you see the VT, virtual transcatheter valve deployment to the STJ distance. And as we discussed, we classify in 2A, 2B, 3A, 2A, and 3B. Typically, 3A would be safe, as we discussed. 2A would be safe. B, and C on this side would be requiring something. Now, depending upon the skill set, you can either go for basilica or you can go for chimney stenting. Now, regarding the hemodynamics part, which is again Achilles, we all know that supraannular valves are going to give a better
Can I
hemodynamic outcome.
interrupt, Manik? Actually, you
Okay,
have
sir.
already crossed that 7 minutes time, so
I,
you have.
I will stop, sir. I will stop, sir. So, valve and valve fracture and supraannular valves are a treatment of choice, sir. Thank you, sir.
Thank you, Manik.
Thank you, sir.
Dr. George, could you invite the second speaker? And in between, if there is any question from my co-chair, Dr. Bijulal, if he's here. Otherwise, I think it was a great presentation by Dr. Manik.
Thank you,
And
sir.
valve is a new, very, very, new way of treating bioprosthetic valve, heart valve failures. Thank you, Manik.
Thank you, sir. Thank you, sir.
Your mic is muted, George. George's mic is muted.
Yes, can
Yes,
you
sir,
hear
you're
me?
unmuted.
Yeah, my pleasure to invite Dr. Gopal Murugan, pioneer in many of these valve interventions. And without further ado, the stage is yours.
Good morning, everyone, and respects to Dr. PC, Dr. George Joseph, and Manik Chopra, the chairs and the experts. My task is to talk 8 minutes on transcatheter mitral valve replacement. I will try and whiz through some slides and the journey in our country. To put a mitral valve in currently, it's a valve in valve procedure. We don't have any native TMVR technologies currently available in India. And the way to get the mitral valve in its position, there are these possible 4 routes. And the majority have been attempted here in India. And now the standard of care has changed to a minimalistic transvenous transeptal, which Dr. PC introduced a year or two before. This is one of the very early journeys. This is back in 2012 when there was no TMVR through a transvenous approach. Majority was largely only through a transapical approach. You can see here a 4D echo showing severe mitral stenosis of a bioprosthetic valve and had severe stenosis. This was the very early stages where patients can only have a transapical procedure. So for this procedure, for the first time, we planned to attempt doing a transvenous transeptal using the available TAVI devices, which were designed for a retrograde transaortic approach. So the CT volume was taken, 3D print was made, and after 3D print was made, after in vivo testing with the delivery system, we decided to take it on the patient on compassionate basis. As a result, we did a transvenous transeptal. This was the very first in the world, and we hadn't attempted, nobody had. And we managed to do a VA loop because of lack of confidence whether the system will track. But we managed to deploy a valve, and it turned out to be useful for the patient. And the hemodynamics changed immediately from a severe mitral stenosis to a respectable mean gradient of 5. And the anatomy was very pleasing and the patient did very well. And after a year, we published it also. This was the world's first evolution of a transvenous transeptal mitral valve in valve. And since then, this has now been the standard of care. In India, the journey has been very stormy because we didn't have devices. And it started only in 2017 when a deserving patient who was admitted with cardiogenic shock because of dysfunctional mitral had no other options. So we decided to use a transapical system. And in the interest of time, I will just feed this very, very quickly. The technology is fairly straightforward. Working alongside a surgeon, we did a transapical puncture with a double purse string, crimped a valve onto a balloon, and just deployed it. This is not through a dedicated delivery system, just a normal ZMED balloon and a valve crimped in. And the patient was an extremist, so did this on a compassionate basis, and the patient did very well. And he continues to be now the current longest living TMVR in India, being the first TMVR now with a 3-year follow-up, and this was published also. Subsequently, we had other cases also referred, but not all can have a transapical or a transeptal approach because we didn't have the catheters, and this patient had a severe LV impairment. So we could not take the risk of a transapical approach, losing a bit of ventricle. So this patient had a transjugular transeptal TMVR, fairly cumbersome way, but I will not go into this in detail for the interest of time. But essentially, we delivered the valve through a transjugular transeptal after creating a double AV loop to try and have extra wires to allow us to facilitate the valve through the transeptal approach. But we did manage to deliver the valve, and the patient did well and continues to do well. This is nearly 2 years down the line. The only first TMVR, which is native transcatheter mitral valve replacement for native mitral valve disease, was a MAC procedure, where this patient had severe mitral annular calcification. So we decided to palliate him with a transapical TMVR using a TAVI device, using the mitral annular calcification as a landing zone. And we did some planning with 3D printing because we didn't have confidence that whether it will land or not. And after being happy on bench testing, we deployed a valve on within the MAC, and this was procedurally successful. The patient only lived, however, only for 40 days and subsequently died due to peritonitis. And the worldwide evidence for TMVR in MAC is 50% die in less than a year. So that's the cohort of patients we are having to deal with. But subsequently, this has progressed in a big way. Now the standard of care is very easy. It's a transvenous transeptal procedure. The procedure usually takes only an hour maximum, and the patient leaves only with a venous puncture, and very rarely they need any arterial access at all. And this has superseded all other previous cumbersome pathways to deliver a valve in the mitral position. Currently, the only FDA approved technology was there an error? Sorry, there was an error, my fault, or perhaps my system's fault. Please bear with me.
No problem.
So
Okay,
what
so
happened, sir?
maybe you can just speak if it is not coming. Gopal, you can just do the conclusion.
Dr. Gopala Murugan?
Okay, we are back in. I hope you can see me now. Am I back in?
Yeah.
Sir, now we can see your slide, sir.
Am I back in? Am I audible? Am I
Yes, sir.
visible?
Yes, sir.
Can anyone tell me if I'm audible and visible?
Yes, you are audible.
Yes, sir.
You are audible. And your slides are there, so please carry on.
Okay, great. Sorry, I lost you. My fault. So the only now FDA approved device is a Sapien device, which is currently available in India, and this is now the standard of care. And our small experience includes 17 TMVRs to date. 16 were a valve in valve, and 1 TMVR in MAC. 2 were transapical, and 14 valve in valve. This is largely through a single team multicentric approach. The procedural success defined by being able to deploy a valve in position was 100%. Procedural mortality was 0. 2 in-hospital mortality, one due to peritonitis and 1 due to E. coli septicemia. We had 1 valve thrombosis 4 weeks later, treated with thrombolytics. And the longest follow-up to date in our country is 3 years, who's the first TMVR in the country. This is largely due through a single team multi-centric approach, which allows us to provide homogeneous outcomes with homogeneous protocols. Acknowledgements to our collaborators and contributors to the technology. But this is just to give you a quick snapshot of the current TMVR therapies in development. You can see a huge list. Majority are research, some CE marked, and 1 or 2 FDA approved. But the promising technologies, which is most likely going to be available in our country, are mitral repair and replacements. These technologies seem promising, But again, we shall await because we are way away from other countries. I think the eventual true TMVR technologies that we will end up having is Evoke and Sapien 3. And Sapien M3 is essentially a dock, which is again deployed trans aortic retrograde, and then a transeptal, essentially a Sapien valve within that dock to provide mitral valve function. So, which is fairly makes a lot of sense, and we're all very familiar with the Sapien technology. Thank you.
Thank you, Dr. Gopal. That's a fantastic overview of transcatheter mitral valve replacement. You mentioned that the only situation where you would do a native valve is mitral annular calcification. Would you also consider it in mitral stenosis? You know, if you have a calcific mitral stenosis.
I think we the to be able to deploy a valve safely, as you know, sir, is to have a secure landing zone. And unless we have a secure annular calcification extending at least over 180 degree, I think the ability to have confidence to be able to deploy a valve there is going to be very small. If they have mitral stenosis largely from leaflet tip calcification, it is unlikely it's going to hold in place, because if it gives way, then it's going to embolize one way or the other. I think the annulus will be the most stable area. And again, I'm not sure this is going to last long. Even TMVR in MAC, although cases have been done, it is just more palliation, where the patient has no other option, which explains why most patients don't do well at all in the long run. So I think it's more palliation. So I hope I'm answering your question.
Yeah. So I think this technology of TMVR is really very very predictable, very, I must say, user friendly, and now, as you already mentioned, Gopal, we are able to finish cases within less than 1 hour, and the patients are discharged in a day's time. So it is quite and it works very well. The gradients remain very predictable in many of these patients. Even we have implanted 23 size valves, 23 sapiens in this mitral, because many of our patients had 25 size of the native bio PHP valves. So it works out quite reasonably well, and they just are on mostly on aspirin alone. And those patients who are on AF, we typically continue also giving them NOACs or anticoagulants. But our experience of about similar about 20-25 cases have been quite positive, and there has been no failures as such. So thank you, Gopal. Very, very nice.
Thank you.
Thank you. I think if we'll move on to the next talk by Dr. Praveen Chandra, Alternative Access for TAVR.
Thank you, Dr. George. So we will start I'll start this presentation on alternative access. And this is basically, as you all know, that the default approach for TAVR today worldwide is femoral access. And it is preferred, and it is done in more than 90% cases as of today. But it is not possible always, because the femoral arteries, if they are less than 5 millimeters, if they have heavy calcification, or if there is a occlusion of the aorta, sometimes even the aorta is occluded, and there is a tortuosity in the arteries, then it is not possible. So in our series of now about 240 cases, we have about most of them are femoral cases, but we had transfemoral, non-transfemoral cases using transcaval approach, trans-subclavian approach, and transcarotid approach. So these are the approaches we are doing these days, and mostly we have done these two, and now we have also started doing transcaval, which also seems to be very, very promising and very easy also, I must say. If you do the right steps, it works out quite well. So in transcarotid access, generally we prefer left more than the right, and the patient should not have any recent CVA, no disease in carotids, and of course the carotid should also be more than 5 millimeters, and the contralateral carotid should have no significant disease. And this access is a slightly open access, I must say, not like it's not a big surgery. A vascular surgeon has to open the access and give it to you. For the subclavian access, we have done both open and percutaneous, and generally we go from the left side, and the subclavian also must be more than 5 millimeters, undiseased, and no significant calcium, because there is a bend which we have to cross. For transcaval, it is from the inferior vena cava, And in these patients where there is no subclavian carotid or femoral access, or there is no arterial access, then we go from the IVC going into the aorta. So that is the difficult access, but there are some more difficult access which happened in COVID lockdown time, where we had to do a case which was far away, 200, 1200 kilometers away, and we had to do that case. So that was a difficult access too. So these are the valves which are being used. So any valve can be used for non-transfemoral access. It is not a choice of the valve which matters here. And as I already told you that if there is no good access, we should also consider SAVR in these patients. If not, then of course we can try one of these access points. And why we are discussing this so much? Because access site complications are the most common complications of transfemoral TAVR. And let me show you one of the representative cases which we did. This is a patient who has a severe calcification in the aorta, which we see on the CT. So the CT is the first red light which comes in saying that this cannot be done through transfemoral. And in this patient, when we saw the CT, we saw that both sides are not good. They are all below 5. So in this patient, we started looking at the subclavian and the carotids. And in the carotids, we found some plaquing. The femorals are small. So what do we do? So here we do a trans subclavian approach. And in these patients, this patient is a balloon expandable valve, which we are using a 26 millimeters, same wire, everything is the same. And you can see that the valve is implanted quite nicely. And since these balloon expandable valves have a flex sheath, we can really deflect these valves very easily into the proper position. The second approach is the transcarotid approach, and in this patient, why it was done? Because the femorals were small, the subclavians were not good, they were diseased and calcified. So we chose the carotid, and among the carotid, the left subcarotid was the most straightforward and clean vessel. So we took and this is done under the MAC, and an IRS monitoring is done continuously in these patients. And this is the approach. You can see a small opening, and the vascular surgeon gives you the carotid artery. He's exposed the artery, and then we can puncture it with a needle and go ahead with the same way as we do for the other approaches. And from the right side, right radial, we had to put the pigtail because there was no access from the aorta. So you can see even the pigtail is not going. So we had to put a wire there to guide our valve positioning. And then we took the help of the echo, transthoracic echo, to position the valve. And in this case, we are using a self-expanding valve, which is the evolute valve. So any valves can be done anywhere. Here you can see there is no pigtail. It is only the wire. And we are doing it with the help of a echo guidance, and also that is a transthoracic. So in these cases, in these carotid access patients, this is a quite a safe approach, I must say. We have done a few cases now, and it is very fast, doesn't take too much time, and the dissection is very small. In 5 minutes, you are into the carotid arteries. The third case is a transcaval access. Why it was done? Because this is a young patient, and this is a Larsen syndrome, which is a multiple deformities of the skeleton, and surgery was not possible. Looking at the arteries, we thought we can do a TAVR femoral, but we found that arteries are very, very small, 3.8, 4.2. So we decided that go from a non-transfemoral approach. Even the femoral and carotids were not suitable. They were very small, 4.4. Then we decided to go from a transcaval approach. So we entered from the IVC. And why IVC? Because there is an advantage here, the pathophysiological advantage, that if something ruptures, it will go straight into the IVC, not into the peritoneal space, because that is a higher pressure than the IVC. So the planning is done through the CT examination, and in CT we find which place will be the best to puncture, where is nearest and there are no branches from the IVC into the aorta. And then we do a fluoroscopic correlation and take the needle, which is the back end of a oven 4 needle, and we connect it to the cautery, as you can see here. And with this cautery, quickly we go inside, puncture from the IVC into the aorta, and then go straight inside, and this access is achieved. And in this patient, we could achieve this access. This was a slow coronary, in the low coronary height also. So we implanted a stent, we put a guide liner and a stent inside, so that in case the left main starts getting affected, we can do a implantation of the stent. So we did, it was a very difficult case. So we also took a wire to guide the buddy wire to guide the valve. And after the pre-dilatation, we dilated this. Once the valve was dilated, we could position this valve. You can see it's a balloon expandable valve. And it appeared that there may be some narrowing at the of coronaries. So we implanted the stent also to make a chimney there. And this was a 4 millimeter stent, which was brought out and implanted as a chimney to this valve. So this is a transcaval approach. Rest everything remains same. And when we bring it out, we try to finish it with a PD occluder. But in this case, the PD occluder jumped out. So we put a stent graft here in the aorta, as you can see, which is a specialty of our friend Dr. George. But we did it here, and we got a good outcome. Fantastic, no leak, nothing. So these are the approaches which we do, and this is the simple algorithm. If the size and calcification and tortuosity, these three things are not according to our plan, then we go for a transcaval approach or a subclavian and a carotid approach. This is a patient where we did in an intense, the country was in full lockdown, no flights. So we had to go in PPE kits to do this case, and we were successful in at least doing it. So transfemoral access is the gold standard. Carotid and subclavian access is safe, easy, and invasive, less invasive than transapical TVR, which is almost gone now. CT scan assessment is vital in selecting the right case. Switch before it is too late. So we do the planning much, much before in hand. And transfemoral access is a viable alternative with very good results. However, we need a good heart team to do all these things. A vascular surgeon and a good anesthesia team, and then it works out quite well. Thank you very much. So I will.
Thank you, Dr. Praveen. Just one question. When you do that transcaval puncture with the O14 wire, you are touching it with a cautery, or what do you?
Yeah, we touch it with a cautery. At the back end, we just touch it and then, it immediately goes in within a few seconds.
And then you pull the wire down, or you push it up with the snare?
So we catch it with a snare and then push it up, push it up.
Okay, excellent presentation and of all the options. And
thank you.
I think we can move on to the next talk. I can see Dr. Sengotuvelu is ready. He is one of the big operators in South India regarding these valve replacement procedures and valve repairs. And I will invite him to present his talk on demystifying the mitra clip. Dr. Sengotuvelu.
Thank you, Dr. George, and it's a pleasure to present this today. So my talk would be demystifying mitral clip. So, can you see my slides?
Yes.
Okay. So we know that surgery has been the cornerstone for management of mitral regurgitation. One second, I'm sorry. Okay. So surgery has been the cornerstone for management of symptomatic severe mitral regurgitation. But 50% of patients with severe MR are not referred for surgery just because of the high risk for surgery and severe LV dysfunction. Again, many of them, up to 62%, are kept on medical management and are dead within 5 years, particularly this functional MR, secondary to severe LV dysfunction. So,
what happened?
My slides are not moving, I'm sorry.
Don't worry, you can
I'm really sorry.
Again.
No.
Sir, please click down arrow for change your slide, sir.
Okay, down slide. Let me try that. I just close my presentation quickly and go again. Just give me a second.
Sir, share your slide, sir, first.
Yeah.
Please.
Yeah.
And put on slideshow, sir.
Yeah. Okay.
Now it's moving, sir.
So, if you look at the guidelines, ACC guidelines, a 2017 expert consensus document suggested MRB solely treated with surgery. But whereas a 2020 update expands the treatment of severe MR, both the primary and the secondary, to transcatheter mitral valve therapy. This is a significant update, which again improves other options for treating these severe MR other than surgery. So we have to understand both the spectrum of mitral regurgitation includes both the primary and the secondary MR. We know that primary MR is where there is structural abnormality of the leaflets or valvular apparatus or the cardia, the pulmonary muscle. Secondary MR is related to severe LV dysfunction due to incomplete coaptation. The valve is structurally normal. So now we have the option of treating these severe MR with both etiologies using the mitral clip. So the concept is H2H repair, where both in degenerative as well as in functional, it facilitates proper leaflet coaptation, as you can see in this animation, thereby creating a kind of tissue bridge and double orifice, so that there is reduction in mitral regurgitation. So talking about the Mitra clip research from Abbott, this is what it looks like. It looks more complex, but as such, you can see this is a stabilizer to keep the guide catheter and the clip delivery system, which is this is the guide catheter, the steerable guide catheter, and the clip delivery system is inserted through the guide catheter. You can see the clip, clip arm. These are the grippers, and currently this is FDA approved and CE marked, and recently got approved by Indian DCGI. So initially we had been doing these cases with the special access license, but with the availability now, with the availability and on the shelves, it's now easier to do these procedures. So with the new data, recent data, I would like just mention the co-op trial for where it clear is a very landmark trial, which actually showed the benefit of mitral clip as compared to medical therapy alone in reducing the hospitalization and the mortality in patients with symptomatic severe mitral regurgitation with heart failure. So the prerequisite for doing the procedure is initially screening with transthoracic echo and clinical assessment, followed by TEE, which is very critical before doing the procedure. It just not to confirm the severity and location, but also finds suitability for mitral clip. So for a primary mitral regurgitation, we have to look at the flail width and the flail gap, and for the secondary mitral regurgitation, the coaptation depth and the length are taken into account. So these criteria are very important to select the patients to get adequate and good results with the mitral clip. Procedural outline: the procedure is done mainly using fluoroscopy and transesophageal echo. So the major guidance is by transesophageal echo, and transseptal puncture is performed, and a posterior and superior location is chosen, and particularly it has to be we have to make sure there is sufficient height so the mitral clip reaches the coaptation. It has sufficient length so that the leaflet the clip can reach the leaflets. So steering and positioning of the mitral clip device into the LV, and then there is grasping of leaflets. Once we grasp the leaflet insertion assessment is done. So we can check whether there is a reduction in mitral regurgitation. And once we are satisfied, the clip can be deployed, and then the system can be removed. And additional clips can be placed as many as required, 3 or 4, depending on the need. So the advantage of this this procedure is precise placement control. We can reposition if required. The clip can be taken out and repositioned before deployment, and allows multiple tissue grafts before release, and making sure adequate amount of tissue is grasped and significantly MR is reduced, facilitates optimal MR reduction. And we can also remove if we are not deciding not to remove the clip. So the steerable delivery catheter allows to change the orientation of the clip. So T is very important, and we have to have some views which are very important are bicommissural views, the LVOT views, and NFOS surgeon's view, 3D view, which are very helpful. So the device is advanced into LV, initially positioned above the mitral valve and having the correct orientation, then advanced into the left ventricle. While pulling back the catheter, the mitral valve leaflets are grasped, and once optimal grasping has been done, the clip is closed, creating a double orifice. Also, one can monitor the LA pressure and the V wave to just guide the a significant reduction in MR during the procedure. And we also can look at the gradients and decide to deploy more clips if there is no significant mitral stenosis. So currently new generation mitral clips are available, the Mitra clip NTR and the Mitra XTR, again, which have longer arms for easier grasping and more rotation length, as you can see in these pictures. So we show our initial experience, a few cases we did before the approval, and we have lined up few cases now. Our experience is one of the patients were a 79-year-old man who had severe mitral regurgitation. It's a classical flail P2 segment with a severe MR with a regurgitant volume of 67 ml, normal LV function, and normal coronaries. So the important aspect is to get a good septal puncture, again guided by TE. So get a superior and superior puncture. And as you can see, it's again important to look at the ones before puncturing, make sure you have sufficient length and so this is again through the advancing through the IVC. This is the guide catheter, the steerable guide catheter, which is advanced, and then it's inserted into the advanced into the through the septum into the LA. As you can see, a pigtail catheter is in the pulmonary vein just to monitor the pressures. And now the introduction of the clip delivery system through the guide catheter. So this is called straddling, where we can position the clip delivery system on the guide catheter. And once it's straddled, now again guided by TE, the clip delivery system is advanced into the LA and positioned above the mitral valve. So just it is positioned above the mitral valve orientation, and then inserted to grasp the leaflets. So once we grasp sufficient leaflet, we can check whether we have adequate amount of reduction in MR. So here we are closing the clip and making sure there is significant reduction in MR. Once we have assured that, then we can deploy the clip. The clip is released. So these are our initial cases, and now both these etiology, primary and secondary MR, can be treated with mitral clip. When treating secondary MR, it's important to select the proper patients and making sure whether CRT or other therapies are already done and whether it's going to be beneficial, because it's an expensive therapy. The degree of residual post-procedure MR is associated with poor outcomes. Again, one has to realize that the new generation clips are now more helpful to treat more complex pathologies. And now there are randomized trials going on with Pascal from Edwards versus mitral clip in both the pathologies, DMR and functional MR. So to conclude, the recent guidelines have updated to include transcatheter therapies in the guidelines. The mitral clip should be performed after heart rhythm discussion in experienced centers, and it's now available in India and approved for use. Our initial experience has shown good results. It is indicated in both functional and secondary and primary and secondary MR. Thank you for your listening.
Thank you, Dr. Singatwale. I think this was a fantastic presentation on MitraClip, which is I think, the latest technology for treatment of severe mitral regurgitation. And you have been also on the forefront of treating these patients with MitraClip. So congratulations to you and your team. And I must tell you that this XTR is a very good clip as well. So we did recently one XTR also, and with one clip only we could completely treat the MR, which is a degenerative mitral regurgitation. So I think if there is any question from Dr. George, otherwise we can move to the next presentation. No?
I think excellent presentation. That's all.
Yeah. So now I will like to invite Dr. John Joes on another very, very exciting new technology, which is pulmonary valve implantation, transcatheter. And Dr. Joes is a fantastic structural heart interventionist now, I know, and he does a lot of these TAVI procedures, and I'm sure MitraClip also. So Dr. Joes, please.
Thank you, Dr. Chandra, and good morning to you all. So today I'm going to deviate from my usual talks on TAVI, and I'm going to speak on transcatheter pulmonary valve implantation. what are the basic steps, and how to do this procedure safely. So my talk is going to be based on our chapter for this year's CSI update, also on TPVI. Now we know that about 20% of congenital heart disease patients have involvement of RVOT or the pulmonary valve, with many of them undergoing surgical repairs in their early childhood. And RVOT dysfunction in the form of stenosis or regurgitation is very common in adulthood. Repeat surgical procedures are associated with increasing risk. This forms the basis of introduction of transcatheter pulmonary valve technology. Now, looking at the patients for TPVI, they fall into one of these three broad categories. They can be patients with dysfunctional RV to pulmonary artery conduit, or a dysfunctional surgical bioprosthetic valve, or those with transannular patch repairs or native valve dysfunction. So majority of these patients are actually tetralogy of fallow patients, and about 85% of them are actually patients who had a patch repair where the RVOT is large and transcatheter procedures can be quite challenging. So regarding the current indications for TPVI, they include symptomatic patients with significant RVOT obstruction or with significant PR. And in case of asymptomatic patients, if they have one of these parameters which I've listed here. Contraindications include conduit or RVOT size, which is outside the size range for current available devices, evidence of coronary compression on balloon testing, and in case of unsuitable vascular access. For procedure planning, CT and MRI are quite useful. They give useful information regarding anatomy and dimensions in order to assess patient suitability. We also do right heart catheterization and angiography. Most of these patients also have tachycardias arising from the RVOT region. So it's good to do an EP study and ablation before valve implantation procedure. So the procedure can be done under general or local anesthesia through the transfemoral or the transjugular route. Key steps are pre-dilatation and pre-stenting. Pre-dilatation is mainly done for valvuloplasty purpose. You can do sizing of the valve by balloon sizing, and you also need to exclude coronary and aortic root compression. This is very important in case of conduit. So use of an anchoring covered stent reduces the risk of conduit rupture and avoids paravalvular leaks. Also provides scaffolding and easy valve entry. And following valve implantation, if there is a residual gradient, you need to do post-dilatation. And here are some examples of coronary compression using balloon interrogation test. Most of these compressions happen on the left side. So these are the valves that are currently available for TPVI. Melody valve has size limitations. Harmony and Pulsar are currently under development. There are no difference in procedure planning or in the steps between the conduit and non-conduit, except that RVOT patients, patch repaired patients, they tend to have larger dimensions, and they often require valves which are large in diameters, for example, my valve or the venous P valve. So regarding complications, they are usually rare, but can be serious. For example, you can have conduit rupture or coronary artery compression, which occurs in about 2% of patients. Stent fracture and endocarditis occur more commonly with Melody valves during follow-up. And this is one example of Melody valve stent fracture. So recently we have 10-year data of the Melody valve ID study that was presented in a SKY meeting. And the results suggest that there is a freedom from surgical reintervention and endocarditis about 80% at 10 years. So I want to show you some cases of TPV done at our center. The first case that of a 54-year-old female who had a ICR in the past at the age of 9 years. Now she came with complaints of NYHA class 3 shortness of breath. She's got a low stature and low body weight. Clinically and echocardiographically, she has findings of free PR. These are her investigation findings: ECG, broad QRS. On CT scan sagittal section, you can see the RVOT dimension is about 30 millimeters. There's no clear landing zone. You can see calcification on the outer curvature of the RVOT region. So the RVOT morphology on MRI scan seems to be suitable for TPVI. Again, the MRI parameters fit the criteria for TPVI. So in general, patients with tubular configuration is suitable, but if you have a tapering configuration of the distal RVOT or the PA, then they're not good candidates for TPVI. So here is the angiography of the patient. We usually take angiography in the lateral view and the RU cranial view. You can see there's a significant free PR. So the balloon compression testing showed no occlusion or compression of the coronaries or the aortic root, and the waist of the balloon measured about 30 millimeters in dimension. So because this was a large native patch repair RVOT, we decided to pre-stent. Initially, we attempted to take the stent from the femoral root, but this was quite challenging and because of the calcification of the wire bias, and we switched over to the transjugular route. Here we took a 14 French sheath, and we took a 32 Andra balloon, of which the Andra XXL stent was crimped, and the valve was implanted. So, sorry, the stent was implanted, and this is the angiographic result after pre-stenting. So then we gave a trial period about 6 weeks. We want to make sure that stent is in place. At the end of 6 weeks, we brought the patient back, and then we completed the valve implantation procedure. We chose a MyValve device because this is a 32 mm RVOT dimension. Again, we took the valve through the transjugular route. So now we found difficulty in tracking the valve into the pre-stent. This is because, again, because of the wire bias and calcification on the outer curvature. So you may wonder that what about the transfemoral route? Now the problem with this transfemoral route is that there's quite a bit of curvature, especially in this projection. But also there's an anteroposterior curvature also, which you see on the lateral projection. So if you take a transcatheter valve from a femoral approach, it's going to be even more challenging. And to take a 32 mm valve, you need a 24 sheath, which is currently not available in India. So to overcome this problem, we took a small balloon from the femoral root. We kept it inflated within the pre-stent, and then we were able to take the MyValve device into the pre-stented Andra stent. So this is the valve deployment. Valve deployment was done at a rapid pacing. It was done very, very slow. And this is where we place the valve just distal to the pre-stent. This is because it's very easy to pull the valve down, but if the valve migrates downwards, it's very difficult to push it back into the target position. So the final result, there's no paravalvular leak. Gradients are less than 10 millimeter mercury, and this is the final appearance on X-ray. Patient is doing well at 3 months follow-up. And this is, in fact, the first case report of a large patch repaired RVOT getting treated with a balloon expandable valve of this size dimension. Second case is that of a patient with DORV. He had come to us with shortness of breath, currently in NYHA class 3, also had a hypoplastic left pulmonary artery and hypoplastic left lung, which is confirmed on CT scan. Again, ECG shows QRS widening, significant dilatation of the RV and the right atrium on MRI scan. Here is a CT scan of the patient. You can see the patch, a bit of area of narrowing on the CT scan. So in this case, we decided to take the venous P valve. Again, angiogram showing severe PRs, a bit of an area of narrowing. You can also see appreciate the patch here. So again, balloon interrogation, no coronary compression, waist measured about 24 millimeters. We had a 32 by 30 venous valve, so we wanted to upsize this to 28 mm. We used an Acura balloon to upsize it to 28 mm dimension. And this is a venous P valve. It has got this 2 sets of markers, which helps you in valve deployment. And the procedure was completed in a fluoro time of about 30 minutes. So venous P is a self-expanding valve. The valve is deployed by just unsheathing the catheter. And the final result, no PR. This patient is doing quite well at 1 year follow-up. Is another patient with conduit.
Dr. Jose, I think we are already past time, so maybe you
Sure.
can conclude.
Yeah. So this is just the last slide. The patient with conduit and melody valve. The advantage of using melody valve is that if you have a tight stenosed valve, the valve will still function as opposed to a sapien valve, which requires a good circular position for valve to function. So that concludes my presentation. Thank you all.
Thank you, Dr. Jose. I think this is fantastic to see three types of valves in pulmonary artery position, and for those patients typically who were already operated before. and they are now presenting with these stenosis and regurgitation. So with this, I think we can probably move to the next presentation by Dr. Shetty, which is on LA appendage occlusion. And Dr. Ranjan is a very, very, a huge expert, I must say, in LA appendage closure devices, both Watchman and implants. So please go ahead, Dr. Shetty. Your mic is muted.
Chandra, and thank you CSI for giving me this opportunity. I will be presenting the case of amulet implantation, just one case. So as all of you are aware, LAA is something which is probably needed to some of our patients, because atrial fibrillation is a very, very common condition, and there are lots of patients who may not tolerate anticoagulation. Uh, we use TADVA score to understand who needs anticoagulation. Some of them tolerate newer drugs, and some of them do not tolerate. The rationale here is that in non-valvular AF, most of the clot actually comes from one area, which is appendage. So if you can safely exclude this, that would reduce the chance of stroke without increasing any risk on bleeding. So it's very ideally suited for people who either cannot take anticoagulation or who do not want to take anticoagulation. Unfortunately, LA is very complex as far as anatomy is concerned. You have different, different shapes and different sizes, and these are some of the names which are given, but it's much more complex than this. But fortunately, in current era, whatever device you use, you are still able to close around 98.5% of the cases. So you don't need to keep more than one device in your shelf. Whatever device you have, you can still do it. Imaging becomes extremely important. So it's a TE guided procedure, and based on the type of device you want to use, your measurement changes. The measurement which I've shown here is more for Watchman, but if you want to do it for ACP or amulet, you're going to measure more of neck rather than the body. So for same appendage, when you want to use different devices, you do get different number, and different calculation is being used. So if this is how LA appears, and we need to see it in transesophageal echo, rule out clot in the beginning, and make sure there is no clot before you do the first puncture. So if you are using ACP or amulet, then the measurement is more at this area. uh, Typically these have a lobule and they have a disc, so we need to come 10 millimeter inside, measure this area, and upsize the device by 2 to 3 millimeter. Today I'll be talking a little bit about amulet device, which is the next generation device. ACP has been there for India for some time, whereas amulet has been there now for maybe around a year. It's if you compare to ACP, it looks almost the same, but device is little more softer. It has more stabilizing wires, more hooks to hold the LAA. It does allow little bit upsizing as far as the procedure is concerned, and it comes preloaded. This is how the device looks, and once it endothelizes, all that patient needs is a single antiplatelet. When we deploy the device, it's important to have this shape where the device has to be slightly compressed, the disc has to be in a good shape, and there should be a good separation. If you have too much compression, it looks like strawberry. That's not an ideal position. And if you have too less, the embolization risk will be higher. So I'll just run through the case, which is a 78-year-old CKD AF patient who had recurrent syncope, had intracranial bleed with OAC, so could not tolerate any OAC. This is the most important. I think today we would have realized that the septal puncture becomes extremely important for this procedure. The puncture, you can see the tenting in this image. The puncture should actually be infero-posterior. So in bicable view, you want to be little below, but you still want to be in the softer part of intraatrial septum, and this is how LA appears. Once we have punctured, we typically go to upper pulmonary vein, and that's where we exchange all the catheters. And through that catheter, the 14 French catheter is usually used for larger side amulate. For smaller size, you could use 10 or 13 French catheter. And this is the device which is preloaded DR'd, and it is taken into the upper pulmonary vein. And once in upper pulmonary vein, you make this round spherical shape, and then pull the device completely down to LA. So you're in the appendage and you make a small round shape, and the whole system is now pulled down. As you do that, you need to look at the echo. So if you look at the echo, you realize you're almost at the neck of left atrial appendage, and you know that this is the position where you want to start. If you're doing a Watchman, you tend to go very deep in to deploy the device. But if you're using ACP amulate, you don't need to go very deep in. So for a beginner who is starting a appendage program, probably this will be a better device. And then you start unsheathing the device as shown here. Initially it is that spherical, then it forms a triangle shape. This is little specific to amulate. ACP does not form a triangle shape. Once you know you have formed the triangle, you can position it and understand exactly the point where you want to deploy the device. Two key important point is anti-clockwise torque on the sheath as you do it, and unsheathing, not unscrewing here, unsheathing the device. As you bring it down and as you keep seeing T, you realize that your position is exactly where you want, and the device looks very well compressed. And at this point, you unsheath the disc. And then you look at points whether the device is in ideally position. If you see this image, you realize that the disc is now tire shaped. There is some compression which you see. You see a good separation from disc and the lobule. The disc itself is concave shaped. And in TE, it becomes very important to look at TE. Circumflex marks the ostium of LA. At least 2/3 of your device should be inside circumflex. At this time, you decrease the gain and make sure there is no peri-device leak. So too much upsize is not allowed in ACP, unlike Watchman. So upsize is typically into 2 to 3 millimeter. Once you're sure that position is good and stability is present, you need to give a slight tug. That's when you release the device. And the post device typically for ACP, and this is how it looks in echo, it looks very good. Disc is compressed, the lobule is compressed, and disc is completely covering. And once it endothelizes, LA is actually excluded. Just antiplatelets are enough post ACP and amulate device. Like all procedure, there are complications which are possible. So we need to look out. Pericardial effusion is the most common complication. And post depends on the, depending on the precondition, we decide the post therapy. Most of the time it is just antiplatelets. Thank you. Thank you for patient.
Yeah, Dr. George.
Yeah.
You make it look so easy, Ranjan.
Yeah.
It's very alluring the way you present it. But I'm sure I've seen you do this, and there are a lot of points which you need to be aware of to make it work so well. But it's definitely opening a new vista for these patients with AF who can't tolerate anticoagulants. Great work. And
Yeah, it's a
Thank you, Doctor.
fantastic presentation by Dr. Shetty, and I think this amulet is a very user-friendly device. However, on the contrary, I have done all my cases are Watchman only, so
Yes.
I started with Watchman and
Yeah.
stuck to Watchman. So, and that also works quite fine if
Extremely
we
well.
take
Yes.
precautions, and
Yes.
there's been no perforation or any effusion in these patients. So thank you very much, Dr.
Yes.
Ranjan. And we
Thank
move
you.
on to Dr. George Joseph,
Yes.
who is, I think, one of the finest I can call for the aneurysm management, thoracoabdominal aneurysms, and various other aortic procedures. So I'll invite him to start his presentation on thoracoabdominal aneurysms and endovascular management. George.
Thank you, Praveen. I'll be presenting our experience with endovascular repair of thoracoabdominal aneurysms. I must start out saying that this is a very morbid group of patients, and any kind of treatment, whether it's open surgery, hybrid, or purely endovascular, carries significant risk. And we classify these thoracoabdominal aneurysms into 5 types, and I'll run you through these 5 as we go through the talk. And the first type, this is our experience. We have done 56 cases in the last 7 years, and we have treated all the 5 types. But the commonest type is the extent 5, which is lower thoracic and upper abdominal aorta. So we'll start with extent 1, TAA, which starts from the left subclavian and goes down to the suprarenal abdominal aorta. And this is an example of such a case. What you're seeing is the luminogram, but actually if you look at the CT, there is quite a lot of thrombus around this lumen. And the odd thing in this case is that the celiac artery is not there. It's actually separate hepatic and splenic arteries, and one kidney is missing. So you don't see one renal artery at all. So it's very important to save that other renal artery. And so we made a plan to make 4 fenestrations in an endograft, 2 for the splenic and hepatic separately, and then the SMA and the renal. So this is how the graft looked. 4 fenestrations, and we have partially constrained it so that when we deploy it, there is room to work outside the graft. And this was the completion angiogram. You can see we have cannulated all the 4 fenestrations into the 4 target arteries, and we have excluded the aneurysm. And this is the follow-up CT angiogram showing that the aneurysm remains excluded at follow-up, and all the 4 fenestrations are flowing well without distortion of the fenestration stents. Extent 2 is the most extensive thoracoabdominal aneurysm. Starts at the left subclavian and goes down all the way to the aortic bifurcation. And here's an example of that. And this patient not only had this extensive aneurysm, there was also an occluded superior mesenteric, stenosed celiac, and stenosed right renal, and a large IMA, which was taking over the role of the superior mesenteric and celiac arteries. So we needed to preserve this IMA because it's very important for bowel supply. So that's the IMA. So we have to end our endograft just above the IMA. Fortunately, at that point, there was a landing zone. And the aneurysm was quite large, 9 into 7 centimeters, a lot of thrombus in it. And this is our endograft. We have 3 fenestrations for the 2 renals and the celiac artery. The SMA, as I said, is occluded. And this was after we deployed it, we started right up just beyond the left subclavian, and you come down all the way to the IMA level. And you can see we have preserved the 2 renals and the celiac artery. We put covered stents into those 3 fenestrations. And that's the follow-up CT angiogram showing patency of the 3 fenestrations. IMA is also flowing, and the aneurysm is excluded. Type 3 or extent 3 starts from the lower thoracic aorta and involves the entire abdominal aorta. And here we used a different technique, a sandwich technique, because this patient actually had only one renal artery flowing, and all the other vessels were occluded. And there was a large IMA, of course, which was supplying the GI tract. So we had to preserve that one renal artery, and we used a sandwich technique. Now this aneurysm had already ruptured, so we wanted a simple technique. So sandwich was good for that. So on top, we deployed a Valiant endograft, and into that we deployed an Endurant aortic tube. And between these 2 endografts, we have a sandwich stent going into that right renal artery. And that sandwich stent is a covered V12 with a bare metal self-expanding epic stent within it to give it some more radial strength. And that was the follow-up CT angiogram showing patency of that right renal artery, exclusion of the aneurysm, and we have also spared the inferior mesenteric artery, which is the sole supply to the GI tract. Extent 4 TA involves the entire abdominal aorta. Here's an example. This patient had 2 right renal arteries, 1 left, and celiac SMA. So we have to save 5 arteries. So we have 5 fenestrations, 2 right renal fenestrations, and that's the constrained graft at the bottom. And this is the result we got. The 2 renal fenestrations, we actually found it easier to crisscross to enter the target arteries. So this was the immediate result. And this patient developed type 2 endoleak subsequently. You can see the contrast flowing through the sac. So we entered the sac with a long needle, paraspinal needle, and put glue into the tract. And so this is a cast of that endoleak tract that you're seeing in black color. And this is the follow-up CT showing that the aneurysm is excluded and the fenestrations are all patent. And we also have another example of acutely presenting extent for aneurysm. This we treated with another technique called the octopus technique. We chose that because of this extreme tortuosity and small size of the iliac arteries, so regular endographs would not go in, whereas the endurant endograft, which is smaller by 2 or 4 French, will go. So this is the way the octopus works. You have a bifurcated graft. Into the short limb, you have 3 covered stents going into the visceral arteries. If you have a fourth, you can sandwich it. And then you put another bifurcated into the long limb. So this was the result we got. This is what the octopus looks like in real life. Into the short limb, you can see covered stents going into the celiac, SMA, and the left renal. And there was no right renal, fortunately, so that we did not have to do the sandwich technique. That's the follow-up CT angiogram showing a good result, excluded aneurysm and patent branches. Now, the last type is the type 5, which starts from the lower thoracic and ends in the upper abdominal aorta. And in this case, we had a large aneurysm, like you can see over here, and 2 right renal arteries. So here we thought, instead of making 2 separate fenestrations, we'll periscope one of them and fenestrate for the other. So that's what we did. We have 4 fenestrations. And for the lower renal, we have this periscope stent ready to go after we deploy the aortic endograft. So we deployed the aortic endograft, cannulated the fenestrations, and also deployed this periscope into the right renal artery. And that's the follow-up image that you see with all these vessels flowing. Now, there are significant complications. Like I said, this is a very morbid group. Many of these are surgical rejects. We are also going through a learning curve. So we had 14% early mortality and a 10% follow-up mortality, which adds up to a significant 24%. There are also all kinds of other complications, but these we were able to manage by endovascular or surgical means. And there was one paraplegia which was fortunately not very significant. So in conclusion, using physician modified and off the shelf endographs, it is feasible and effective to treat thoracoabdominal aneurysms. There is a long learning curve involved, and with current techniques, very complex cases can be dealt with successfully. Very important to have surveillance and follow-up interventions may be required in some of these cases to get a long-term success. Thank you for your attention.
Thank you, George. I think I cannot ask you any questions because I'm so fascinated looking at these pictures, and I'm wondering whether I will be ever be able to handle any such kind of situation. I don't think I will be able to. So, thanks a lot for these very complicated cases, very morbid patients, and I'm sure you are going to really perform many such procedures in more complex patients. So with this, I think we can move on to the last presentation of this
Dr.
session because.
Dr. Arun Madan is not presenting, sir.
Oh, right,
So
right.
there is time for discussion, sir.
Okay, okay. So I think the first, of course, I will ask Dr. George that who are those patients where you say no? Are there any patients where you say no? Because it appears that you can treat everything.
Yeah, so there are some situations where endovascular is not going to work. That is, uh, one is multiple renal arteries. I showed you some cases where there were 2 right renals which were almost equal size, but there are some who have bilateral 2 or 3 renal arteries. That makes it, and along with that, some renal dysfunction. So if you knock off any of these, you are looking at dialysis. And technically also it becomes extremely difficult. But then there are no other options for some of these patients. Surgically to revascularize 4 or 5 renal arteries also is extremely difficult. So you got to look at the patient individually. Now, if the patient is young, otherwise not many comorbidities, you may give it a go. But the older patients, you may say, think of conservative. Then the other big thing is aortic tortuosity and calcification. If there's a lot of aortic tortuosity, it's very difficult to land your fenestrations correctly, however much you may plan it, because the tortuosity biases the endograft towards the curves, and you may struggle the whole day to get an important side branch. And then the last is access. Many of these patients have very bad access. We have used conduits in some of them, but conduits are also pretty morbid, that we have found. So bad access, and the other thing is patients who are already in a pretty bad shape with other things like cerebrovascular disease, all that. So you got to take each case individually. There is no blanket rule for these conditions, and generally, younger the patient, less the comorbidities, more likely you can do this.
So, but when the patients are younger, so do you also start thinking of a surgical approach rather than an endovascular approach in these
True.
patients?
See, actually, a lot of these patients can't afford what we're doing, and so by default they have to go for surgery. Uh, but most of our patients are actually either surgical rejects or they are totally opposed to surgery. Because the surgery for these are major surgery. You got to do a thoracotomy and a abdominal incision, and there's a lot of morbidity, and typically they stay almost a month in hospital. So it's not at all a easy procedure, and the risk of paraplegia is higher with surgery. So surgery is an option, definitely, but very few surgeons are confident to take on major thoracoabdominal aneurysms in our country. Of course, we have examples like Joseph Coselli in the US with 1,000 and more patients with a lot of experience, but we don't have Joseph Cosellis in all countries, and especially in India.
In some cases, there have been, use of hybrid, technique in these, like, the surgeons do some part and we do the thoracic part.
Yeah,
So
hybrid actually is good for the arch. Aortic arch hybrid is something that works with low morbidity, because you can do the revascularization fully outside the chest. You don't need a thoracotomy for, let's say, a left subclavian, left carotid, and carotid bypass. So you can, with very low morbidity, debranch the aorta. Whereas in the abdominal segment, if you're going to debranch the renals, SMA, celiac, that is as morbid as an open repair. So you might as well do an open repair if you're going in for hybrid versus open.
Okay. Thank you. Dr. Shetty, you want to ask something?
Yeah, yes, sir. I was asking about MFM, sir. That MFM stent, if it is
Yeah.
once it is available, would it be a good alternative to this?
No, actually, MFM has disappointed. It has not shown good long-term benefits, and the latest Society of Vascular Surgery guidelines have actually put it as class 3. That means it is actually harmful. So the theory behind it is very elegant, and it looks fantastic. You just deploy that and you come out. But unfortunately, it hasn't worked, and today it's a class 3 indication.
Thank you. So now the last part of this session was on sorry, type B aortic dissection. So since Dr. Madan is not here, let me just ask you a few random questions on that, so that people can get some flavor on what should be done for type B aortic dissection, and how about managing false lumen, about conservatively following these. So what is your algorithm for type B aortic dissection as of today?
So type B aortic dissections can be classified immediately into acute, subacute, and chronic. And acute is less than 2 weeks, subacute is 2 weeks to 2 months or 6 weeks, and chronic is beyond that. So if you get a type B dissection, the first thing is it complicated? If it's complicated, whatever the stage, acute, subacute, or chronic, you got to do something about it. So what are the complications? One is ischemia. So you may have ischemia of the visceral vessels, the renals, the lower limbs. So you may have to deal with that ischemia. You may not need to do an endovascular aortic endografting. You may just put a stent into the renal or a stent into the iliac to restore flow immediately. So that is one. So deal with complications. Or if the complication is threatened rupture or a contained rupture, then you have to do a full repair. So complicated dissections at any stage need to be treated. The other thing is, if it's not complicated, then try to get out of the acute phase with conservative management. So the acute phase generally is not advisable to intervene. Subacute is the best phase, and that is 2 weeks down the line. Chronic is not so good because the flap tends to become hard, and then when you put the endograft may not expand, and the aorta will distort considerably if you wait few years. So there was this INSTEAD trial which looked at conservative versus endovascular management of non-complicated type B dissections. At 2 years, it looked like they're both the same, or maybe conservative is better. But when they went down to 5 years, that is the INSTEAD Excel trial, they found that a lot of crossovers were taking place from conservative to endovascular because the conservative group was developing growth of the false lumen. So type B dissection is not a static condition. It is a progressive condition. It needs long-term monitoring, which may not be very feasible in India. So err on the side of treating rather than not treating. And they say that the total aortic diameter more than 4 centimeters is an indication to treat an uncomplicated type B dissection. Now, when you treat a type B dissection, basically you have to start above the point where the dissection starts. So if it's starting at the left subclavian, the simplest is to start from distal to the left common carotid. So that is called a zone 2 repair. And in that situation, it's always important to preserve flow into the left subclavian artery. So if you're not familiar with fenestrations and chimneys, better to get a surgeon to bypass left carotid to left subclavian so that you preserve flow into the left subclavian, which is an important source of spinal cord blood supply. So I don't sacrifice the left subclavian at all. I always salvage it either by a fenestration. Earlier on, we used to get bypasses done. So that is the starting point, and the rule is do not oversize significantly in dissections. Maximum oversizing should be 5%. If you oversize significantly, you may get a problem known as retrograde type A dissection, which is a real disaster. You know, the aorta dissects backwards into the ascending aorta, and when it reaches the near the heart, three bad things can happen. It may burst into the pericardial space and cause tamponade and sudden death. It may go and obstruct the coronary arteries, or it may cause aortic regurgitation. So all these, once you get retrograde type A, the survival rate is very low. Mortality is almost 40% in these conditions. So what are the cases that have a risk for retrograde type A? One is oversizing your endograft. Second is ascending aorta that's already reached 4 centimeters in diameter. So these ascending aortas are diseased. So when it's crossed 4, either get the ascending aorta surgically replaced, or what we are doing now is we're lining the entire ascending with the endograft as well. And the third group, which has risk for retrograde type A, is the genetic aortic diseases like Marfan syndrome, Lewis-Dietz, and all those. So in those situations also, you must think of a surgical option because of this risk of retrograde type A. So that's the top end. The lower end, you must end above the celiac artery. Obviously, you don't want to knock that off, but you may find a significant backward leak into the false lumen from below. Especially if there are patent intercostal arteries, and that may keep the false lumen patent and prevent the aorta from the false lumen from thrombosing and shrinking. So in that situation, we put something called candy plug in the false lumen to close off the lower end of the false lumen. And then you must follow up the abdominal segment. Not all abdominal segments remain status quo. Some of them grow. And in a few cases, we have done a fenestrated abdominal repair, taking the repair all the way to the iliac arteries when the false lumen is growing in the abdominal aorta. So that is in a very nutshell is the treatment of type B dissection.
That was very educative as well. So thank you very much. And I think we are at the end of this session. And we thank all the speakers. And Dr. George, you may just sum off the session.
Yeah, I think this was a very educational session, and I learned a lot from the structural group because I don't do structural anymore. And it was fascinating to see how this field is advancing and how many new options are coming up. And the heartening thing is right here in India, we are now doing a lot of this work in a very excellent fashion and getting good results. So I think the future is very bright. The only thing is the cost is usually forbidding for most of our patients. So if we could get the costs down, maybe larger numbers will achieve that. Or if we have Indian valves coming up, and there are all, my valve is already there. So I think lower costs, more experience, and more acceptability will lead to a revolution in this field.
All right, thank you, and we shall move on to the next session.
Thanks. Thank you, everybody.
Thank you.
Bye.
Our next session will be Ask Mr. Watson, and Dr. Raju George is there as a chair for the session. Over to you, sir.
Hello, good morning, everybody. Can you hear me? Am I audible?
Yes, sir.
You
Yes,
are
sir.
audible.
Yes.
Our time starts at 11:30, and first topic is Darshan Jala, famous 5 apps for every cardiologist.
I think we have 5 more minutes to go.
Then, what should I do? Yeah, let me
Please wait
introduce
till
the speakers.
11:30.
Let's say hello to each other.
Yeah.
Okay. Sir, what's your name, sir? Your Darshan Jala. Yeah, thank you. How many chairs are there? The chairpersons? Have I got any colleagues? Chair or experts?
Not joined yet, sir. They will join, sir. They have informed that they will join.
Oh, okay. Yeah. That's, yeah. Thank you. Yeah,
Silacar, India's #1 CCB in management of hypertension. Myotan CN. Bisotab.
Let me start the proceedings, sir.
Shall we start?
Yes, sir.
Good morning, everybody. Today we have got two sessions now. From 11:30 to 12:06. First one is a discussion on by three persons, three expert persons, Darshan Jala, Tiny Nair, and Dr. Karthik Tumala. The second one is a debate actually. The debate is actually on wearable disease with the pill in the pocket and approach for low risk atrial fibrillation. It's a wonderful session and excellent speakers. And shall I call the first person, Darshan Jala, for giving a wonderful session on famous 5 apps for every cardiologist.
Thank you, Dr. Raju, and good morning, friends, chairpersons, and I thank CSI for giving me this opportunity to present this. My interpretation of this topic was that
Sir, go to your
these
slides, sir. Share screen.
yes, yeah. Can I see? Can you see my
Yes, sir.
slides?
Yes, sir. You can, sir.
So my interpretation of the topic was that these are 5 famous apps for cardiologists and cardiology apps. So I'm not going to discuss non-cardiology apps, which I'm sure every cardiologist is interested in other things other than cardiology, like finance or maybe hobbies or music and things like that. But I'm going to talk only on useful cardiology apps for a cardiologist. So let's talk of the first one, that is Up to Date. Now, this is a perfect app, not only for a cardiologist, but for every single practicing physician. It was developed in 1992 by two people in somebody's house. And it started with nephrology, but if you look at the menu that is offered today is phenomenal. Everything under the sun is covered. Up to Date lives up to its topic. It is up to date and it is updated almost, I believe, every two or 3 days. So state of the art information is given by experts in the field on a very friendly platform. You can search everything that you want, and this is how the app goes. You have first the outline available to you, then from the outline you can go into the topic, and then introduction and the components of whatever disease that you are looking at, then the treatment, and then how to monitor, and finally society links are also provided. So you have absolute up-to-date information on anything that you want. Let it be COVID, let it be cardiomyopathy, let it be anything, it doesn't matter. You still have absolutely and one single platform, downloadable in Android or the iOS platforms. The only downside is that it's a paid app, but I think it is worth paying for it. The second app that I'm trying to highlight is what is actually, there are two apps, is EchoCalc and PeteZ. Now, EchoCalc was donated free as an app to the British Society of Echocardiography by Dr. Alan Harkness. It contains all the normal values of TTE, prosthetic and aortic mitral valves, which is very important because it is a ready reference. If you get a person with a little higher trans mitral gradient or a trans aortic gradient, you can quickly look up the normal values for this, and you don't have to remember everything. Again, it's a free app and it's available on Android and iPhone platforms. And to elaborate it, this is how the app looks like. It gives you all the LV size, function, normal parameters for diastolic function, then LV mass, then RV size, aortic dimensions, left atrium, everything. It also has a topic on dobutamine stress echo as to how to interpret, how to calculate the dose, how to calculate the various parameters in dobutamine stress echo. So this is how the app looks like. The second is, of course, more of an interest to the pediatric cardiologist. This is PeteZ. Now, the most important thing is that apart from the echo things, it also gives you various things on gestational age, fetal echocardiography, how to calculate body surface area, what are the normal blood pressure measurements in a child, and what are the other various parameters. You can also calculate those. You can calculate the various growth parameters. And of course, it gives you an idea about the Z scores, which is important for determining the normal size of chambers in pediatrics. So another free app which is available on iOS and Android platforms, and a very useful app, especially if you're doing pediatric cardiology and fetal echocardiography. Then we come to an app which I call the Swiss Army knife of electrophysiology. It has everything, and this is EP Mobile. I use this extensively, and it was developed by Dr. David Mann, who is an American electrophysiologist, and it is targeted to give you proper electrophysiology information in a very concise and friendly manner. So, just to elaborate a few points about this, it gives you not only information, but it also tells you how to do various maneuvers like parahesian pacing, how to interpret parahesian pacing, what happens when you place the RV apex where the RV base, how to interpret this, versus how to distinguish between accessory pathway or an AV node conduction. It gives you drug dose calculators. It has a warfarin clinic. It gives you all the available atrial fibrillation, defibrillation risk scores and the bleeding scores. And it gives you information, latest information on hypertrophic cardiomyopathy. It gives you allow how to calculate the risk of sudden cardiac death in HCM, etc. And the most important part for students is how to locate WPW pathway. It gives you all the three various algorithms which are there. Then long QT diagnosis, Brugada diagnosis, ARVC risk calculator. So it's a one single app which will satisfy all your electrophysiology needs. Again, it is updated frequently, and it's available both. It's a free app available in Android and iOS platforms. This is how the app looks like. It has these calculators, diagnosis, reference, and tools, and risk scores. And when you enter into this is how it simply tells you how to calculate this. Like this is an example for ARVD scoring algorithm as to which is a high risk ARVD. So it is a beautiful app. And I think if you are even doing basic electrophysiology, or even if you're just seeing ECGs, this is a good app to have on your mobile. Another app which is slightly duplication of the previous few apps, but is a good interest to a general cardiologist, is called Calculate by QXMD. Now, this is a general purpose calculator which is useful in general practice, internal medicine, cardiology, surgery, everything, the entire gamut of medical specialties. What you want is there in this. It gives you information on how to calculate body surface area, oxygen consumption, and various other information that you would like. For example, how to interpret blood gas, how to calculate uh, the various creatinine clearances, etc. It's a free app available on Android and iOS platforms. Another important one, if you are working more extensively into the intensive care units, it will give you how to correct hyponatremia, how to correct various electrolyte disturbances, acid-base balances, and it's based on a unique question flow. So you have to answer questions and then arrive at a proper answer, and then it will give you the guidance as to how to go about with that particular problem. And this is how the interface looks like. It has these questions which you keep answering, and then you get the interpretation, and then it gives you the management as to how to go about with this. One of the useful pocket guideline is ESC pocket guidelines. These are, of course, we are aware that ESC upgrades their guidelines very frequently, and this is the mobile version of the guidelines. And recent inclusions are adult congenital heart disease, AF, aortic diseases. A very important thing is cardio-oncology, which is an emerging field, pregnancy-related heart disease, CVD prevention, chronic coronary syndromes, as they have been now renamed, acute pulmonary hypertension, and last one is pericardial diseases. Is a very dedicated folder-based approach, direct links to ESC Congress sessions, which is important, so that if you need more detailed information on a particular topic, you will be linked to directly to the lecture, which formed the basis of this guidelines. It's of course available free of charge and is available on Android and iOS platforms. This is how the interface looks like. So you have these DAPT, VHD, STEMI, you have all these scores and the interpretations as to how to go about in these various conditions. And this is how the dashboard looks like. And then it gives you, and it links you to the proper ESC lecture. One more app that I use regularly is the JBS3 risk score calculator. Now, this is a score which gives you lifetime coronary artery disease risk or atherosclerotic disease risk. And it is important. I use this. There are many calculators like the ACC, AHA calculator, etc. But I like this one because there are almost 15% of patients who are Indians. And you can choose the ethnicity in this calculator and you will get relevant data for India. Of course, these are Indians situated abroad, but still, nevertheless, it has Indian data. And this is a very important app. You can use this app to for example, you are trying to convince a patient to use statins and the patient is not getting convinced. You can display this heart risk and tell him that if you don't take statins, this is your lifespan. If you start statins, this is the additional life that you can get added into it. And this, I find it very useful to display it to the patient when there is a reluctance on starting primary prevention therapies. So not only does give you numbers, but it also gives you a way to put across your idea of primary prevention. It's a very useful app and very easy. It's downloadable on an iOS or an Android phone, and you can immediately flash by putting the age, ethnicity, the total cholesterol, HDL cholesterol, blood pressure, and you can get the heart risk. It gives you, of course, gives you lifetime risk. It does not give you 10-year risk, but still, I think it's a very useful app. The last app that I would like to display is from a website called the cardiologyapps.com. Now, this is mainly of interest to the interventionists. It is developed by the Mount Sinai Hospital, Dr. Samin Sharma, this group. And it gives you, it's a basket of apps. And you can, the one that I sometimes use is called the Bifurcate, which gives you an information on how to tackle bifurcations. It gives you how to tackle whether it is left main or non-left main. Then into that, then it asks you various questions. Then it discusses the various options available to you as to you should do a mini crush or a DK crush, and it gives you a step-by-step technique as to how to go about if you're doing a DK crush. And it also compares it with various other modalities like QLOT, V-stent, provisional stenting, etc. So this is Bifurcate Aid. There are many others in the same cardiology apps, and that is like it's a calcific aid, then it gives you an information on IVUS, then OCT, and various other things. So this is a basket of apps, which is extremely useful to have it on your mobile if you are doing an interventional case. So in short, these are the few apps which I recommend. Up to date is a must. EchoCalc if you are doing echo regularly. If you're a pediatric cardiologist, PEDZ. If you are doing any form of electrophysiology, including just simple ECGs, EP Mobile is a useful app. General purpose calculations, especially in the intensive care, QXMD. ESC pocket guidelines are, of course, for all of us. For primary prevention, risk calculation, and convincing the patients, JBS3 risk calculators, and specifically for the interventionist, the cardiologyapps.com basket of useful apps. Thank you very much.
Thanks, Dr. Jala. Excellent presentation. Good morning, everybody. And I would just like to add one more, Dr. Jala, only because this app has been developed by our own person from KEM, Dr. Vinayak Bapat, who is now an expert on TAVI. He's got a valve app which is been used by all of us for calculating the exact valve size in bioprosthetic valve when you want to go for a tower. Just because, that's also
Valve in Valve. It's called Valve in Valve by Dr. Vinayak Bapat. Yes.
So yeah, very, very excellent lecture. I hope everybody looks at it later on also, because not everybody probably is attending this. And the next we move on to an excellent speaker, Dr. Tiny Nair, and he is going to speak to us on artificial intelligence and the cardiologist. Dr. Tiny, please.
Dr. Tiny Nair, good
thank
morning.
you. Yeah, thank you. Thank you. I'll just share my screen. Give me
I'm Dr. Kar from Kolkata.
Oh.
Yeah, Dr. Kar, welcome.
Yes.
Yeah. Long time.
Yes.
Yeah. Is my slide visible and am I audible?
Yes, sir. Yes, sir.
Yes.
Thank you. So we would talk about artificial intelligence in cardiology. Now, we have our own way, our own conceptual way of assessing intelligence. And that, as you can see in this picture, is this. But the problem is this is mainly data driven. This is mainly data driven. Now, the problem of data driven assessment of intelligence is this. You know, the Alexa device sitting on your kitchen sink is far more intelligent than any of us here if you consider data. Ask anything, you know, right from height of the Everest, Mount Everest, or the last 10 presidents of the US, you get an answer in a jiffy. So getting data is not intelligence. That is the first thing to understand. In fact, if you look at knowledge and those dots being data, so now we are bombarded with huge amount of data, but that does not really transfer into intelligence. What is important is this, that we need to connect the data with a line. And unless we connect the data by our experience, the data becomes useless. But even that is not enough. Understand that if we connect the knowledge with experience, and suddenly we start seeing a big picture. For example, connect those green, see a pattern emerging on. Connect those mauve dots and you see a pattern emerging on. And that is what is the big picture. And that is what actually, in true sense, intelligence is all about. It is not just knowledge and database. Now, with that, there's a beautiful article on artificial intelligence and the cardiologist, what you need to know for 2020. And that talks about, of course, we know that in interventional cardiology, we have the convolutional neurological network that has come in. And we have users, for example, the smartwatch gives us all kinds of arrhythmias. We talk about in cardiovascular imaging. Today, artificial intelligence gives us all the images and everything all together. But we are not talking about that. We are talking about something beyond all this, right? Something beyond all this. So first thing is sensors. Sensors have changed the way we look at science today, right? From the glucose sensor or a simple heart rate sensor or an arrhythmia sensor, we have today gone into a different arena altogether. For example, the wearable biosensors in healthcare came in Nature Biotechnology Journal last year, and that gives a beautiful picture. Look at that. Okay, right from your eyeglasses, which is intelligent, to your smart contact lens, picks up all the data. So sensors. There are a huge lot of wearable sensors. For example, you have the watch, you have the band, you have the bangles, you have the rings, everything. And of course, you have a huge amount of patch-based sensors. For example, you have nano patches and a lot of patches. So all the sensors put in the data in. But more important is, today, even those sensors don't need a power because your movement generates power. So you don't need power for the sensors. And not just that, all that sensor data goes into a huge computing power that all of us hold in our hand today without understanding that the cell phone today is extremely powerful in processing all the sensor data that comes in. So we have a system, we have the sensors there, it is powered by our motion, and we have a huge analytical power engine with us. Okay, right. So now pause for a moment and think about it. This is one of our patients of heart failure. This gentleman, he's a 55-year-old man. And this gentleman was complaining of some occasional palpitation. We did a 72-hour Holter and found nothing, right? So he's on heart failure therapy. He's fine. He got a gift from his daughter, which is an Apple smartwatch, right? Okay. And then one night he suddenly said, the doctor, I was feeling that I have some palpitation, and I checked it out and recorded it, and see, my heart rate has gone to 145. So we said, okay, since you recorded, let us go back and get that ECG, you know. The Apple Watch gives you that EKG at that point of time, that is 145, heart rate jumping up. And we found that 1 minute before, the ECG was normal. And during that period of palpitation, he had atrial fibrillation, AFib. So Apple smartwatch has picked up AFib, which we did not pick up somehow by a 72-hour Holter monitor. Okay, right. And of course, we gave him therapy and all that. So you'd say, oh my God, very beautiful, and this is smart. But understand, this smart is smart, but not intelligent. That is what we are talking about. The watch is smart, but not intelligent. For example, it did not inform automatically his GP, or did not inform me that the patient had an AFib. He had to come and show us all that. Point number two, it did not even warn his wife, who was sleeping next to him, that your husband has a problem, right? It didn't even remind me to consider anticoagulation. Suppose I am a doctor who is not updated on anticoagulation. I might have missed AFib and say nothing doing. Okay, right? It didn't remind me to start anticoagulation. The smartwatch did not even tell me that on the day before AFib, this gentleman had online ordered alcohol. Right? Right. The data is there. It's just for the system to assess. And of course, it also didn't tell me that his keyboard typing speed had changed since that day of AFib. Does it mean that he had a minor stroke or a TIA? We don't know. But you see, the opportunities are huge. So this is smart, but not intelligent. What we are talking about is much deeper level. For example, when we started talking about artificial intelligence, it was engineering a machine which is fast and can handle big data. So which means, we put an algorithm. Okay, you diagnose AFib. And the system does it very fast using huge amount of data. And that was what we are looking at. But from there, we have gone to machine learning, where it is not algorithm anymore. So if the machine finds that there's something wrong in the algorithm, it changes the algorithm or creates a different algorithm itself. So from algorithm-driven, fast-paced, huge data, we are transferred to somewhere where the algorithm is being generated by the machine. And finally, we have gone one more step down, what we call as deep learning. We'll get into that in a moment's time. So from algorithm-driven artificial intelligence, we have gone to experience-driven machine learning, where the algorithm itself is corrected by the machine experience. And from there, we have gone beyond. What is beyond? And that is deep learning. You see deep learning, artificial intelligence, periphery, then machine learning, and deep learning is far inside. It is a subset of machine learning. What is it? What is it? It's new. So understand that. It's exactly like our neuron in the brain. So we have those neuronal cells there in the center. You have those dendrites. And of course, you have the axon. So dendrites collect all the information, comes to neuron, and gets out through the axon, right? And that is exactly that is replicated in the newer computing, whereby we have all the data coming in, like the dendrites, goes to the neuron, and then comes out to the axon, right? But what is unique is not that. What is unique is like a neuron. See, that is a unit information. And that used to always communicate with one unit in the next layer. Today, that one unit communicates with all three. And that three communicates with, again, all those four. So as we go from input to output, the hidden layers, analyze each one of the subset, communicates with every kind of nerve cell or the data analytics. And so we have a huge power there. And this is what it is. If you show that whole system a huge array of faces, it quickly goes through input layer, goes through hidden layers, and then you get an output. But then in every layer you see that one single element talks to every element in the next layer. And that is what is unique. Now, this is what we should understand. If you look at the amount of data, huge data is coming in, and you look at performance. Okay, machine learning, after a certain amount of data, would go flat. Okay, but deep learning will not go flat. So deep learning is what is the thing to come in cardiology. And how does it work? This is interesting and important to note. If you have an input image, let's say CT or an MR image, what we used to always intuitively do is expand it to see the details. But here in deep learning, what we do is we take an area and then we reduce it. We reduce it to a small pixel, what we call as matrix. And that small matrix is reduced in size and put as a dot. And you similarly collect hundreds of dots from hundreds of these areas interrogated in the image. And that is what is called as convolution activation, convolution. And those convoluted images, again, you see, what you do is those convoluted images are pooled together. You see the layers, and then you get a pooled feature map. And from that, again, you do convolution. From that, you take a spot and reduce it further to a very small element. Convolution again. And from that convoluted image, you again get a pooling. So convolution pooling, and finally you get a vectorized map, which gives you much clear concept between physiology and pathology. Now, you would say, okay, it's all complex, but does it really work? It does. For example, the concept is, you take an ECG. This is sinus rhythm, right? And from a sinus rhythm ECG, you are trying to predict, will this patient develop AFib? We are not talking about standards like maybe a short PR interval or a prolonged QT interval. But looking at an ECG, can we predict that this patient will develop AFib? What they did is they calculated every single point in the ECG and again put them into a convolutional layer and then did a pooling, then did another convolutional layer and finally came out with the data. And did it work? Yes, it did. August 1, 2019, Lancet came out with the data of artificial intelligence enabled ECG trying to predict AFib during sinus rhythm. So ECG is sinus. The system tried to predict, will they develop AF in the future? And you see 1,80,000 patients, 649,000 ECG in sinus rhythm, 8.4% had AFib. And you see the blue and the red, very clearly the predictability of the AI was very high in trying to predict who will develop AF from a simple 12-lead ECG that you and I can't do. So only if you have a deep learning in C2, this can happen. So what are we looking at? We're looking at something unique. Okay, so face recognition. So looking at the face today, it is tried that can we predict early heart failure or AFib? See, it is fantastic. So patient sitting in your OPD, a camera scans their face and artificial intelligence tells that the third person on the second row has a high risk of developing heart failure. You would certainly send him for an echo and maybe a BNP and see whether it works out. That is the importance of deep learning. So at the end of all this talk, where are we? So we always say that we are looking at loss of humanity or that human touch. Once computation comes in, artificial intelligence comes in. So a time will come when instead of saying the psychiatrist, you would see there's a cell phone there. My name is Siri. How may I help you? I mean, we are all scared about that, right? And if you are thinking that artificial intelligence will take away empathy and sympathy and that human touch, hold on for a moment. Hold on for a moment. Hold on for a moment. Papers are coming out as to why not artificial sympathy. Understand that sympathy and empathy comes from three things. One, of course, it can be algorithm driven. Okay, what your parents taught you. Second thing is the data that you know. You see a diagnosis of bad cancer, you know that, oh my God, this patient is going to have only about a couple of months to live. So you start to empathize and sympathize with him. And the third is a personal perspective or an experience. Oh my God, I had once experience that I had a tumor, how bad I felt. So it comes from three elements. Perspective of our own feeling. Second thing is the data, and third thing how we are taught. Why can't you do that with a computer, especially that we are talking about deep learning? And yes, it can be done. It can be done. For example, they said that you can incorporate all that and the system starts thinking exactly like a human being thinks. And how do we react? How do patients know that I'm also feeling for you? That is by our facial expression and our voice. That is what you are seeing on the other side of the Zoom when I talk, right? So they are today trying to create voice and expression exactly determined by what the deep neural network learns. And that is, yes, it is coming. So finally, at the end, are you concerned about the increase in artificial intelligence? Are you concerned about the increase in artificial intelligence? The answer is no, no. But I'm concerned about the decrease in real intelligence. And finally, everyone asks this question. Would we lose our job because of artificial intelligence? Would all the cardiologists lose job because of artificial intelligence? I don't believe that. But there is going to be a change of role. The amount of shift from algorithm-driven big data analysis to something whereby the machine experiences and alters the algorithm by itself depending on the data and the perspective and suggests new ways to interact with the patient. Probably our role is going to change. And I believe that artificial intelligence for cardiologists is going to be for the better. Thank you for your time and attention.
Thank you, Tiny. Thank you. Thank you.
Hello, sir. The next speaker is not there. So we can start the discussion.
Dr. Kar Saab, you can start the discussion. You are muted, Dr. Kar.
Can I ask the first question?
Oh, sure.
To Dr. Darshan Jala, the 5 famous apps. My first question is up to date is the first one, 1992 production. Up to date was your first choice, but it's a paid app. Is it affordable to the layman or the cardiologist, usual cardiologist? But it's the cost of the up to date installation, up to date app.
Yes, yes, yeah. It's little expensive. It's about 7 to 8 thousand rupees a month, a year. So I don't think it is very expensive. But our concept of paying for something is a little. We don't still accept it, but for the value of the app, I think it is definitely worth it. And the advantage of this is that you can share it between two different people. So you can have two devices, you and your colleague or whoever, whatever, junior. So you can share it. I think it definitely comes out to be a little quite economical for this.
So in the department, one by HOD may purchase it. The PGs
Yes,
may share it.
you can
How
have
many?
multiple user also. That also turns out to be cheaper.
And I think for a
Now, what's your
cardiologist,
opinion regarding MD?
for a
MD
cardiologist,
calc.
7,000 to the
MD
8,000 is
Calc is quite similar to QXMD. So yes, that is also a good app. But I think both are replaceable. The QXMD or the MD Calc, both are replaceable.
No, I think one thing is that, like you said, this is a very good, up to date. Of course, all of us use. But the problem of up to date is meant for you, me, and people like us who are in academics, right? Let's say a GP or a consultant wants to learn something about anything. If he opens up to date, he will be confused and close it and run away. Right? When we prepare for a seminar like this, okay, up to date is our best friend. It is not good for people who, that is, of course, one side. And the other side, we always keep one downloaded is the Medscape, because Medscape has a public site whereby people can easily see. A lot of people would come and say, oh, I have hypertension, sir, so I was eating some homeo medicine, or I have some joint pain, I'm eating Ayurveda, right? So Medscape advantage is that we tell that if there is any problem, search Medscape. So Medscape, if you go to a disease, it'll say this is not a disease to be treated by you. It's not a disease where you need to, it is a disease where you need to go to the hospital. So that way, for patients' understanding, it's good that they keep a Medscape public version in their mobile.
Tiny.
Yeah.
Hello, Tiny. Can you hear me, Tiny?
Yes,
sir. Yes,
I
sir.
can hear
Please.
you.
Yes. Now the thing is that about the artificial intelligence, I'm rather
Yeah.
amazed by your lecture about the artificial intelligence. But it is true that this artificial intelligence cannot supersede the true human intelligence. Only it can complement the true human intelligence.
See,
Artificial
it all depends on how
learning.
you are defining intelligence. See, intelligence has so many things, not just knowledge, not just experience, not just empathy, sympathy, strategy. For example, see, you might be thinking about how you are planning to do the next CSI and is your strategy, what is wrong in this Zoom and all that. Obviously, a machine does not have a strategy to think. Okay, a machine doesn't dream, right? Today, I might go and say, oh, I should become like Dr. Ashok Kaur, right? But the machine doesn't do that. So there's a distinction between machine and human in whatever way we make. But we can make it as intelligent as another human, which would serve us for our good. Everybody today agrees that so-called the Hollywood movie thinks that one day suddenly robots take over our home and say you go home and you go to the jungle to humans. That will not happen. That's all story. But artificial intelligence is one of the best thing I think that can happen to us. Get rid of all our useless jobs and give us a clue in which line to go. Will it supersede us? Never.
Now, that's something. It will just complement the true human intelligence.
Exactly.
Yeah, one thing I would like to know is, as you rightly said, we always get that. Is there no downside to these apps? Like you were saying about some, Dr. Tiny, you were saying about an app for the people, patients to know what
Yeah.
my patient
Obviously, see,
just
obviously the
answer my
problem.
question. The patient whom I get are officers and all. They download things and come with you, and they eat your head with this, that I have got this, I've got that, and they read everything, and then it creates more harm than benefit, I feel so sometimes.
The worst app that has damaged every social thing is WhatsApp, right? It's an app.
Yeah.
WhatsApp is what? So they will come and say, Doctor Sahab, I have heard that in WhatsApp you have given me this medicine, this is bad, this liver, kidney, and all that and all that. We are all stuck. So I think they have to go to the right app to get the right answer. And that is extremely important, like you said.
But I fully agree with Dr. Kane. Yeah, these some people are creating problems for us. and they are just creating headaches day and night for the doctors like us.
So
People will
I think
come back.
Dr. Kane,
there should be an
Dr.
app to tell us what is the right app and how to use the app.
Dr. Kane, the problem is not with the apps, it is the problem with the humans.
No. We are humans.
Whether the apps are there or not, the humans are there who will always going to give you trouble. So,
but we are dealing with humans. The apps are there to benefit us.
so forget the apps. It is the humans who are troubling you.
Yes,
There are a lot of people who would come to your clinic with a huge bundle of printout. So suppose you are given a diagnosis of okay, class 2 effort intolerance or something. Doctor, I found this amount of data, Google search, and put it on your table. What do? See, he still thinks that he is teaching you, right? He
Yes.
doesn't know that Professor Ashok Kaur is a chairperson in one of the top sessions in India. He is trying to say, sir, do you know that some blood pressure medicine can cause ED? He is trying to teach you, right? We can't help it.
Sometimes it helps, huh? Sometimes it helps because sometimes they come out with something which you have missed out, or that's
correct.
So many apps, Dr. Jhala. So how do I decide like what to do and which one to use when? So you require one app for echo, one app for measurement, one app for something else. So are we going to be an ape man or app man?
The way you decided your specialty, you decide your app. No? If you are an interventionist, go for the interventional app. The other things, the other experts can look after it. Don't worry.
See, one of the thing I think it is very much less used in India by the cardiologist is Twitter. Okay, right. We see all kinds of groups in WhatsApp, and people all go search, mail search, everything. But somehow Twitter has penetration of Twitter is far less. In fact, if you are in Twitter, you would be the first person to get any new data from JAMA, JCC, or whatever, even without any subscription. The first data comes out is from Twitter, right? For example, if you sit in ACC or an AHA, the first data that comes out of any session is by Twitter, where you can add your opinion. And so I think Twitter is very, very secure. Twitter is very important, whereby you get a lot of data from Twitter. In fact, Twitter gives most important graphs whereby you can take a screenshot and maybe 2 hours later you can present and show the data in a meeting. So I think Twitter is very important. And if you know the hashtags, if you know how to search Twitter, then I think it is an excellent tool for all cardiologists.
Yeah, this I agree, because now all these conferences, TCT, PCR, everything goes on Twitter rather than in the main hall. People are all the time on the Twitter learning and discussing and the whole thing on the Twitter. Yeah.
True. And if you are in, for example, if you are in heart failure, you can always put hashtag heart failure. Or if you have, say, atrial fibrillation, you can put hashtag AFib. If you put hashtag AFib and search, one, you will get all the data available today in literature that is connected with AFib. And second thing, you will also get people who are working on the top level in AFib, right, in one shot. So I think it's a very strong
one with
platform.
the presenter. Like suppose somebody presents, you can be on 1:1 with that presenter within no time after the presentation is over. Is that correct? On Twitter, they respond on Twitter to your queries or to your discussion. It's easier. Yeah. So what do we do now that we have? Are there any other questions or discussion points, sir?
Oh, shall we go to the next topic?
Yes.
Time is up.
No, but let me
debate topic.
Which I want to say.
Debate topic.
We have time till 12:25, sir.
To chair this session. In fact, I was very unhappy. I said, "Ye kya hai? Mere ko nahi, I am not interested in this." But let me tell you, this was the most interesting session I found. Let me confess that I found this session very important. And let me thank Dr. Tiny and Dr. Darshan Jhala to opening up so many avenues to us, how you can look at different things in cardiology. And let's move on to the next. Dr. Kar, can you invite the next speaker or whatever?
Yes, we have got a debate session now. And debate session, the topic of the debate session is wearable devices pill in pocket, approach for low risk atrial fibrillation. Will it obviate the need for regular medication? I think it is a interesting topic. What is the role of wearable devices in detecting paroxysmal AF, and whether it can be tackled just by tablet from the pocket? Now we have got two speakers, for and against. For Dr. Ashish Nabar. Dr. Ashish Nabar is going to speak for the motion. Dr. Nabar, please.
Yeah, am I audible, Dr. Kar?
Yes, yes.
Great. So, thanks very much, Dr. Mohanan, and good morning to all of you. It's good that we are having this debate. It's very current because, as you heard in the last two presentations, wearable device is something that we spoke about. AF was also alluded to, and pill in pocket is something that probably I would add here. Now, this year, the first issue of the European Heart Journal on digital health came. So you can understand how important digital health has become because of the availability of these wearable sensors. And me and my opponent, Dr. Pandurangi, are equally aware that wearable ECG recording atrial fibrillation, the number of publications in the last 2 years has shot up significantly. So there is no discussion that whatever we conclude, we must debate on this. We are talking of subclinical AF. What is subclinical AF? It is the atrial fibrillation, paroxysmal episodes, which are asymptomatic and then which are only recorded by the devices. These could be implantable device as an ICD or a pacemaker, or these could be wearable devices like the patches that are seen here. And these episodes have not been documented on a ECG previously. So that's what is subclinical AF. And when you discuss in the realms of a device, you call it as atrial high rate episode. So this is what we are discussing. And coming to the wearable devices, there are at least two ways in which the wearable devices document AF. So for example, they record a single lead ECG, and at times they would record by photoplethysmography, what is called as a tachogram, and this tachogram then is equivalent to an ECG. So basically, this is what the recordings are, and let's see. And the way it goes about recording the AFib is it just plots the RR, compares it to the previous RR and creates a picture like this. So if all the points of the plot of RR to its previous RR are concentrated, we are dealing with the sinus rhythm, and if they are spread out like this, the irregularity of the RR interval is imaged, and then this is atrial fibrillation, the diagnosis. So this is a pretty accurate way to detect if quickly within 30 seconds, more than 250 beats, and with a very high fidelity. So subclinical AF as diagnosed by the wearable device is here to stay, whether we use it for screening new AF episodes or new patients with AF, or whether we use it in managing AF. Detecting subclinical AF by a wearable device is going to be here. And in fact, it is going to be exponential because these devices are available directly to the consumer. The only caution here is that there are a lot of uninterpretable rhythms that get recorded almost 30-40% of the time, and a health professional should always be involved before we recommend any decision based on what is recorded. For the purpose of this presentation, I will not deal with doing rhythm control with a pill in pocket approach. All of you are aware already that high doses of lecanemab or propofenone can be used to terminate an AF episode. So this pill in pocket part I will leave for now, and the rest of the presentation will concentrate on the use of oral anticoagulation, whether you can use it on an intermittent basis. So for example, when the subclinical AF is recorded, a patient who has a cryptogenic stroke, there is actually no discussion about oral anticoagulation. They do all require oral anticoagulation. If the AF is recorded as a part of a ICD or a pacemaker, uh, then once again, these patients are usually having a high CHADS score, and therefore they again will be in the realms of oral anticoagulation. The difficulty is when you screen AF in population, what do you do with the short asymptomatic episodes that you may record by this device? Now, do they have a stroke risk, and should we anticoagulate them is the real question. Now, if you look at this number of studies in patients who have had cryptogenic stroke, you see that almost 10 to 20% or sometimes more have been found to have a subclinical AF when the wearable devices were used to record these asymptomatic episodes. So there is a certain association of a stroke risk in patients who have subclinical AF. However, the current practice is a little dismal. There is a lot of inertia to use this information of subclinical AF whatever be the duration of AF that is recorded, it does not convert so easily into prescribing anticoagulation. You can see that even when the AF subclinical AF episode goes over hours, less than 1/4 of them get anticoagulation, and the decision is delayed by almost a month in everybody. And this turns out to be despite the fact that people who are prescribed anticoagulation do much better in terms of their stroke incidence than people who are not prescribed. So this variation is something that is disturbing, and probably that's because the guidelines have no definite answers. And let us understand, can we do something differently? So what one needs to understand in terms of stroke risk of subclinical AF is the duration matters, the burden matters, and the density matters. So for example, here I am showing you two cartoons wherein you can see that the stroke risk rises substantially when the AF episode lasts for more than 24 hours. Whereas if you compare here, you can see that the people who have AF for 24 hours or here say 5 hours are definitely more at risk than people who have the episodes lasting a few minutes. So therefore, if the AF duration is longer in hours, then the anticoagulation aspect comes in play. Similarly, AF burden. What is AF burden? Is the number of hours that somebody is in AF in a particular day. Now that is to be understood in the following way: is that somebody who has a AF which is a high AF burden to start with, these people are more likely to have a or a higher burden in days to come, months to come. And if the AF burden is combined with a CHA2DS2-VASc score, they are more likely to be in the red. So higher CHA2DS2-VASc score and higher burden are definitely the people who need anticoagulation. There is not much studied in terms of how density works. If the density is sparse, that is the AF episodes are distributed over a good number of days, then probably it's easy to record. But if the AF density is in a few days, then probably these people are more likely to get stroke risk. But this is something that is uncertain. Now, what punched hole in this concept of higher AF duration, burden, and density being a marker for stroke risk is the fact that almost 70% of the patients did not have AF when the stroke occurred, or even did not have did not have AF in the 1 month preceding the stroke. So therefore, the lack of this temporal relationship tried to punch hole in this concept of whether AF is a stroke marker for risk. There is a different way to look at it. AF may not be causal, but AF certainly is a marker for stroke. Means that the environment in which AF exists, and this is something equivalent to a CHAT score. So CHAT score is more important, whatever be the clinical type of AF. That AF is probably a risk marker. So if an AF exists in a milieu of high CHAT score, these patients probably are at risk. So one may not count the duration and the burden, but the presence of AF is probably a stroke risk. So this is very simple, that when you have the subclinical AF, which are shorter episodes or less long during episodes with low CHAD score, these probably are still in the green. But when you have longer episodes of subclinical AF with a higher CHAD score of more than 2 or 3, their stroke risk comes in the red. It probably rises to more than 2 per year, 2% per year, and therefore they become candidates for anticoagulation. Having said that, some patients with AF who have a higher burden and who have a higher CHA2DS2-VASc score are at risk of AF. We are essentially talking here of paroxysmal AF, and therefore wondering whether we can achieve a balance of stroke prevention versus the possibility of bleeding on anticoagulation. And that's what is important. That's what is the concern of this presentation. Now, although we didn't have AF episodes happening in a month prior to the stroke, what was seen from this publication by Dr. Turakia is that at least for the 5 to 10 days following an episode of AF, these people seem to be at a higher risk of stroke. So they are at a higher risk. You all know that AF terminates leaving some kind of atrial myopathy or some kind of atrial stunning. And therefore, in the times following AF, 5 to 10 day period, let's say, these people are at a higher risk of stroke. So what the authors, Dr. Turakia, proposed in this trial or a pilot study is that if somebody has a subclinical AF which lasts for more than 1 hour duration, can we give a anticoagulation? And if it doesn't have AF in the next 30 days, can we withdraw the anticoagulation? So this is intermittent anticoagulation. Instead of prescribing oral anticoagulation for all the time in patients with paroxysmal AF, can we prescribe an oral anticoagulation? And this publication limited its conclusion to saying that by doing this, we are saving the cost, but could not make definite arguments in terms of reducing the stroke risk or decreasing the bleeding risk. There was another publication which
Can you please conclude,
stand,
sir?
sure, stand the test of time because they used more of VK antagonists. And now with the availability of NOACs, we probably have a different thing. So I'll make a modest conclusion that with the availability of NOAC, we have a alternative to prescribe that in terms of intermittent anticoagulation, then continuous anticoagulation. It is settled beyond doubt that subclinical AF is a stroke risk. We will detect more subclinical AF with wearable devices. Duration and burden combined with CHA2DS score is the way to decide the need of anticoagulation. But with NOAC, we might be probably able to give intermittent anticoagulation and reduce the bleeding as well as the stroke risk. Thank you very much for your patience.
Thank you, Dr. Navar. I think our next
We'll be
speaker.
having a pre-recorded presentation from Dr. Ullas.
Oh, acha, okay.
Okay, sir.
Okay, Dr. Ullas Pandurangi.
Sir, can we start the playback, sir?
Hello, everyone. It's my privilege to participate in this debate and argue that wearable devices which detect subclinical AF should not be a guide to recommend pill in the pocket strategy for those patients with low risk for stroke.
Can see your slide.
The logic of giving anticoagulants when there is an episode of AF and thereby reducing adverse events as compared to the daily consumption strategy is very good. However, the methods of detection of subclinical AF are not simple nor easy. And you have already considered that this patient is at low risk for stroke. Then why do you give a pill at all? Pill coming from the pocket or a bottle seems to be illogical to me. Sorry, Ashish. Some more comments regarding wearable devices. The detection of AF must be accurate. The device must be comfortable if worn most part of the day and preferably all 24 hours. Compliance with respect to wearing the monitoring device and taking pill on SOS basis has to be really high.
Hello, sir.
The only wearable device which has been shown so far of any clinical relevance is an Apple Watch, which is expensive, and there are some cheaper but not really tested watches. Even with the Apple Watch, there are several limitations. The information about the rhythm is obtained from single lead ECG based on plethysmography and deep learning algorithm. Both of them have severe limitations. And it's fun to wear an Apple Watch as long as the person is in sinus rhythm. But once he gets an abnormal rhythm, and then if the person knows that it could be AF, most likely he will be stricken by panic. So it becomes a huge exercise. It becomes such a responsibility for the physician to educate the patient how to take up that particular episode. We got to be educating the patient about not getting panicky or not simply popping up a pill or when to pop up a pill, etc. And most important thing, the Apple Watch study is a proof of concept study regarding only the AF detection. We should not extrapolate the Apple Watch study to recommend pill in the pocket anticoagulation therapy for a subclinical AF detected by watch. There's a serious debate which is going on for long, and that is whether AF is a direct cause of atrial fibrillation or AF is just the risk marker for stroke. Most of us believe that the atrial fibrillation is the direct cause for stroke because we believe atrial fibrillation predisposes to thrombus formation in left atrium, and that embolizes, resulting in stroke. Many believe that's not the case. they consider atrial fibrillation is just the marker of the risk. And their argument or their hypothesis is mainly based on the fact that the AF is so very weakly correlated with the stroke from the temporal relationship point of view. There are two more serious issues when one recommends a variable device to detect subclinical atrial fibrillation episodes. One, the device accuracy. The variable device has to be very accurate, because if there was a false positive data transmission that the patient or the person has had for a long time atrial fibrillation, and which was actually because of an artifact, and if the physician writes an anticoagulation, then the person is potentially predisposed to suffer a life-threatening events such as bleeding. So the device which is worn for the subclinical atrial fibrillation has to be very accurate if the purpose is to start pill in the pocket strategy. We also do not know the wearable devices, how long should be worn per day. Ideally, the wearable devices should be worn by the person all throughout the day, all throughout the week, all throughout the year, which is very difficult. We got to be knowing how long per day, or say for example which week of the day the person has to wear. These are all unresolved issues, and seems to me that it is very difficult to achieve an optimal duration of monitoring by these wearable devices. So far, the scientific data is in favor of either start or don't start oral anticoagulation in subclinical AF based on the risk factors. And if you start, please recommend continuous therapy and not intermittent therapy or pill in the pocket strategy. The recommendation as of now is to take oral anticoagulation every day or don't take at all. Finally, I would like to emphasize that there is no published data so far worthy of any attention to recommend pill in the pocket anticoagulation based on the detection of the subclinical atrial fibrillation episodes by wearable devices. I think it is wise to wait. The only one indication for pill in the pocket strategy, according to me, is that patient who has paroxysmal AF, who has a low chance VAS score, and who has undergone ablation or an antiarrhythmic drug therapy, and then you have thought that he is remaining in the sinus rhythm. And then there are occasions for atrial fibrillation episodes. But even in such patient, it has to be an implantable device and not a wearable device, according to the data that is available. And hence, I again reiterate, wearable devices are not for initiating some dangerous drugs like oral anticoagulation for subclinical EAF, which could be just an artifact based on the wearable device data transmission. Thank you.
Personal absence of or physical absence of Dr. Pandurangi, I would say something that is valuable as a take-home message. So certainly subclinical AF should be understood as a marker of stroke risk. That is for sure, and it should not be negated as something not important. Give importance to a subclinical AF or a silent AF as it is called when the episodes are lasting for more than certain hours. Those which are short episodes, which are often documented in the devices as atrial high rhythm episodes, many times there is a lot of artifacts in that. So be vigilant to evaluate those episodes yourself and not make an indication only based on those episodes. Wearable device, yes, they are being able to record with a high fidelity, but still because of the motion artifacts and the contact of the watch with the wrist and things like that, sometimes you record a lot of uninterpretable rhythms, and particularly when you do it for screening, or some of the consumers when they own the Apple Watch often come to you an anxiety that they probably have a AFib. It then you need to evaluate them. So there is a definite role of a physician to evaluate these episodes, and not for the patient to directly decide to take a anticoagulation, or for that matter any medication. So it's important that these episodes get evaluated by the physician. And of course the algorithms are good, the sensitivity specificity is high, but the basic recording has to be appropriate for those algorithms to work. And once you have the AF recorded, probably it's more value to also look at the chat score. So if you have a true AF episode which is for hours, if the chat score is certainly high, then recurrent AF probably, which is paroxysmal, uh, maybe in future. I agree with Dr. Pandurangi that today you don't have all the data in science to recommend this intermittent anticoagulation method or the pill in pocket approach. But once you have a surety in a patient who is known to have AF, that the recording is good, that the diagnosis of AF is correct, that the durations can be correctly recorded, then it may be foreseeable that you, just like you prescribe a rhythm control medication with its corollaries on a pill in pocket manner, you may be able to prescribe NOACs, certainly not the vitamin K antagonists because they take long time to act and wane off, but the NOACs which act very fast and disappear very fast once you stop dosing, there could be a potential. But at this point in time, there is nothing in the guidelines that tell you to do this.
I think, I think Dr. Pandurangi is
I'm not around.
Oh, Ullas is there.
Dr. Pandurangi.
Conveniently made not to get into that, okay?
I know you have teeth and claws.
I'm a serious person. You made a conspiracy here. You talk to me.
No.
No, all yours. Floor is yours.
Very happy that you are present in person. I was about to say that you cannot have a fight unless both the fighters are present in one.
No. When the fighter is a cheater, what you will do?
No. All is fair and allowed in.
All is fair in the debates.
You have to prove. So your job becomes all the more difficult and stronger to prove that the other person is not doing a good job.
So at least you know.
Very nice debate. I would say.
Come, Ullas, give a fight.
I have understood, and I can conclude with my level of understanding of your subject is that we need more data, and this is an early part of our understanding of this silent AF. And as data gets collected and our algorithms get refined, we will probably have a much more better way of dealing with it. I hope both of you will agree with that.
Absolutely.
Both are winners. Dr. Kar, you agree?
Yes, definitely.
I am more winner. I am more winner.
Nobody is winner. Both of them are winners.
More winner. Ashish, good to see you.
Okay, thank you.
Pleasure.
Why did it start early, man? Why the whole thing began early?
Because one speaker was not there, so we started
Because we wanted to give you more time. We wanted to give you more time.
Okay, good. Bye-bye.
Bye-bye. Thank you.
Dr. Raju, can you conclude? Dr. Raju, sir.
This is another patient or one in the CCU3?
We can't hear you. You are on mute.
Yeah. After the debate, we agree that the paroxysmal atrial fibrillation.
स्नेहा, मैं 2 मिनट में फोन करूँ. एक मेरा वो चलता CSI मीटिंग में सेशन. I'll call you back immediately.
Yeah, I shall repeat. In case of paroxysmal atrial fibrillation, the low chart score and who are undergone ablation or were on angiorhythmic therapy, if they develop any symptomatic, we may give the pill in the pockets. And which pill regarding that? That's the other issue. That is not part of the debate. So we'll conclude with this. This is exactly what Dr. Ullas Pandurangi told in the last slide. That paroxysmal atrial fibrillation may be useful. The low score and for on treatments.
So thank you very much, all the chairpersons and all the speakers. Very, very excellent job. Very good session. We learned a lot. And thanks to the organizers. So can you
thanks.
Thanks.
So I'd like to thank the organizers, especially Dr. P.P. Mohan and Dr. Sibu, who are my close friends. Thank you so much for arranging in a very good manner this conference.
Next, we have a luncheon session from Hall Samarmati at 12:45. And in this hall, we'll start at 1:15. Thank you.
Silacar, India's #1 CCB in management of hypertension. Myotan CN. Bisotab.
The telescope guide extension catheter pushes past the ordinary, delivering the performance you want for your complex clinical practice. With a thoughtful, deliberate design, Telescope GEC features a coil-reinforced, hydrophilic-coated distal segment contributing to superior deliverability, and a solid round push wire that maximizes force transmitted along the catheter for superior pushability. Our soft TrueFlex tip is made of a soft polymer melted and shaped to precise dimensions, responsively deflecting and providing flexibility. Smooth Pass technology includes 3 components that work together to smoothly channel stents, balloons, and other devices. A tapered distal push wire section, transitioning from a solid round proximal push wire for flexibility. A polymer on-ramp that maintains superior deliverability and channels devices. And the entry port, contributing to smooth device entry and delivery. As PCI evolves, we're delivering the GEC performance you want for your complex clinical practice. Telescope GEC, an extension of you.
Silacar, India's #1 CCB in management of hypertension. Myotan CN. Bisotab.
The telescope guide extension catheter pushes past the ordinary, delivering the performance you want for your complex clinical practice. With a thoughtful, deliberate design, Telescope GEC features a coil-reinforced, hydrophilic-coated distal segment contributing to superior deliverability, and a solid round push wire that maximizes force transmitted along the catheter for superior pushability. Our soft TrueFlex tip is made of a soft polymer melted and shaped to precise dimensions, responsively deflecting and providing flexibility. Smooth Pass technology includes 3 components that work together to smoothly channel stents, balloons, and other devices. A tapered distal push wire section, transitioning from a solid round proximal push wire for flexibility. A polymer on-ramp that maintains superior deliverability and channels devices. And the entry port, contributing to smooth device entry and delivery. As PCI evolves, we're delivering the GEC performance you want for your complex clinical practice. Telescope GEC, an extension of you.
No, sir. No, sir. No, sir. The presenter.
Sir, all the presenters, Anandya, sir. So all the presenters would do it by themselves, sir. So we have another 5 minutes to go, sir. Sir, it's Mr. Anand Peter, sir. Yes, sir. Yes, sir. We will tell you, sir. We'll give you the prompt. They will do it from the Cochin studio. They will prompt you from the Cochin studio, sir. Yes, sir. Absolutely, sir. I will put a message also, sir. Done, sir. There is a timer that is running for the speakers. There is a warning buzzer 1 minute before end of time and a buzzer at the end of time. Yes, sir. We run it, sir. We run it, sir. Sir. Sir, we'll start exactly at 1:15. Another 3 minutes to go. Dr. Satish, is there any way that your internet could improve a bit? We're getting a very jerky picture from your end. Your voice is sounding good.
think,
Sir, we now start live, sir. Coach Studio can take over.
yeah. Hello.
Please start.
Yeah, I am Dr. George Thail, a senior consultant cardiologist from Lourdes Hospital, Kochi. I am supposed to chair the session along with two co-chair chairs, but unfortunately they are not available. So I am the only single chairperson, and hopefully all the others panelists as well as the speakers will bear with me. We are going to have an excellent session on heart failure. Heart failure is a scenario in cardiology which is never researched or explained adequately. And the topic is fine-tuning of heart failure care. Heart failure remains a severe cardiovascular disease with increasing prevalence of high morbidity and mortality. There is an unmet need to improve the prognosis and reduce the socioeconomic impact of heart failure management. In addition to the pharmacological regimens and interventions, lifestyle measures may help to achieve goals. And we have actually four topics. The first one will be kidney and heart, how to overcome the diuretic resistance in heart failure. And that topic will be discussed by Dr. V.K. Chopra. And we know that the therapeutic approaches to combat the diuretic resistance include restriction of fluid and sodium intake, use of AC inhibitors, changes of route and timing of diuretic therapy, and the use of diuretic combinations. The pathophysiological mechanisms of diuretic resistance include high salt intake that exceeds the acute diuretic-induced salt loss, hyponatremia, hypokalemia, as well as hypochloremic metabolic alkalosis, etc. I am not going to give a talk on this topic, and Dr. Chopra is very much here to highlight on this topic. Over to you, sir. And the podium is yours. You can talk.
Okay, so my brief is how to overcome diuretic resistance, and thank you, Chairperson, for having introduced that already. Now, what is diuretic resistance? It is defined as failure to achieve therapeutically desired reduction in edema, even when a maximal dose of diuretic is employed. Its incidence is between 25 to 30%, depending upon the disease severity. Now, this is the most practical definition, but less clinically applicable definitions also include persistent congestion despite adequate and escalating doses of diuretic with more than 80 milligrams of furosemide per day, amount of sodium excreted as a percentage of filtered load less than 0.2%, and failure to excrete at least 90 millimoles of sodium within 72 hours of a 160 milligram oral furosemide dose, which is given twice daily. Obviously, the first one is the one which is going to be most clinically relevant. The causes of diuretic resistance are multiple. The congestive heart failure, renal insufficiency, nephrotic syndrome, liver cirrhosis, and use of NSAIDs. I'll only be briefly discussing about the first two due to paucity of time. Now, as far as congestive heart failure is concerned, we know that patients with congestive heart failure get gut edema. There is also renal insufficiency, which we'll come to a little bit later. And this edema results reduced rate of drug absorption of diuretics given orally, delayed time to achieve threshold dose, and that contributes to diuretic resistance. If we talk about the renal factors, renal insufficiency leads on to low GFR and renal blood flow. There is low proximal tubular secretion, insufficient intratubular concentration of diuretics, leading on to decreased excess of diuretics to the site of action, and that again goes on to diuretic resistance. There is a braking phenomena which is important, and that is a physiological response to volume reduction caused by diuretics, which is the volume reduction. When it occurs with diuretics, it leads on to increased sodium resorption in the proximal tubules, increased renin release, and progressive decline in the extent of natriuresis because of activation of renin and angiotensin aldosterone axis. At the macular densa level, there is loop diuretics inhibit chloride transport through a co-transporter in macular densa cells. And again, that leads on to increase renin release, RAS activation, and increase sodium absorption. And at distal nephron level, loop diuretics increase sodium and chloride load delivered to the distal nephron. And there's a compensatory distal tubular hypertrophy, and that results in increased local aldosterone secretion. So you can see there are multiple mechanisms which are involved at renal level. So if you all look at all this in a cartoon, on the left side is pathophysiology, reduced cardiac output and increased central venous pressure. There is edema of the intestines, which causes reduced absorption of diuretics, reduced plasma albumin. There is reduced renal blood flow, reduced GFR, increased RAS and SNS activation, and they lead on to reduced filtration, proximal sodium absorption. Then there are organic acids like blood urea nitrogen, which competitively bind to organic anion transporters, reducing the availability of diuretics in the tubules. There is albumin urea, and filtered albumin binds to furosemide, reducing its availability, and the breaking phenomena and RAS activation, which I've already discussed. So, what do we do? As the chairperson has said, we need to have judicious dietary and fluid restrictions. However, if there's an extremely low sodium diet, that can also have worse outcomes. Since the diuretic level, furosemide levels in the renal tubules become less, so we need to reduce loop diuretic free intervals by giving more frequent doses, and also sequential blockage of sodium absorption, which occurs when we combine loop diuretics with thiazides. Most commonly, it is metolazone which is used. The role of ACE inhibitors and aldosterone antagonists has already been mentioned. Of course, one has to watch for electrolyte imbalance. There has been a lot of controversy about intermittent bolus or continuous infusion. Some of the trials did not show any long-term benefit, and the meta-analysis showed no difference in mortality or hospitalization, but there was symptom relief, increase in urine output, and weight loss. And practically speaking, this is something which is still practiced. Hypertonic saline solution infusion has also been tried. Diuretic resistance is related to upregulation of sodium resorption in distal convoluted tubules due to hyponatremia and hypochloremia. And hypertonic saline along with loop diuretics has been tried, and it has shown improvement in urine output and sodium excretion. Dose response curves shifts to the left. However, there are conflicting reports in acute heart failure. Tolvaptan was approved to correct euvolemic or hypervolemic hyponatremia and heart failure, cirrhosis, and syndrome of inappropriate areate secretion. Free water clearance is increased, symptoms improve. However, no effect has been shown on long-term mortality and in subsequent hospitalizations. So its role remains debatable. One needs to use it cautiously. SGLT2 inhibitors, among their multiple actions, this is another uh, mechanism which is now being utilized. We know that they result in osmotic diuresis, and they have renal and cardioprotective effects which are extremely powerful. Probably the renal protective effects are even more powerful, as we have seen in the multiple trials. The diuretic effect, however, is transient, and effect on diuretic resistance is not yet known. But in a trial, when empagliflozin was used 3 hours before bumetanide, it potentiated diuresis with increased fluid loss. Sodium loss occurs only in the first 3 days, as we saw in DAPA-HF, that it is initial diuresis, but over a long term, the mean dose of diuretics did not change. So these are the pathways involved in diuretic resistance. On the left hand, you can see that there is decreased diuretic absorption. So you use IV diuretics. There's a breaking phenomena, so you increase loop diuretics, tubular compensatory readaptation, increased frequency of diuretics, and SGLT2 inhibitors have been tried. sequential nephron blockade I have mentioned. There is poor kidney sensing of chloride and sodium, hypertonic saline and lysine have been tried, and post-diuresis sodium retention, for which continuous diuretic infusion and Vaptans have been tried. Concluding, therefore, in heart failure, compensatory neurohormonal activation leads to fluid overload, increased morbidity and mortality. Diuretics still remain the cornerstone. Larger and more frequent IV boluses doses should be tried. The frequency needs to be increased. And many times, if you are stuck, we need to put them on infusion. We should not forget about ultrafiltration, because at that time, ultrafiltration can break the cycle, and a person who's diuretic resistant can start responding to diuresis. Combination of thiazides and aldosterone antagonists along with ACE inhibitors is extremely useful. Use of hypertonic saline is still controversial, but it is promising in certain selected cases, depending upon the mechanism that I have already mentioned. Vaptans have been beneficial, but on long term, they have not shown any mortality benefit. SGLT inhibitors may prove to be useful. Thank you very much.
A very lucid presentation, Dr. V.K. Chopra. Thank you very much. I think we will have all the discussions we have kept for at the end of the three topics as per the schedule. So we will have discussion after the third talk, I think. The next topic will be vaccination in heart failure. It's a very interesting topic, especially in the COVID era. I think we have seen from Wuhan and all that the viral infection has caused also the myocardial injury with subsequent myocarditis and heart failure, which was cause of about 40 to 50% of the mortality what we have observed during the COVID infection initially. Among the precipitating factors of heart failure worsening, respiratory infections play a leading role. The underlying pathogenic organisms of respiratory infections are predominantly influenza viruses and pneumococcal bacteria. Now, influenza vaccination is an effective measure to reduce all-cause mortality during seasonal influenza epidemics. The high-risk population include mostly elderly with significant comorbidities. And it is shown that patients with established cardiovascular disease may benefit from anti-influenza vaccination. And we know also about the streptococcal, the pneumococcal infection vaccination. These are all now coming very prevalent nowadays. To highlight this topic, we have Dr. Vidyut Jain, whose biodata I'm sorry I cannot introduce Dr. Vidyut Jain only by name. I switch on to Dr. Vidyut Jain for highlighting the topic vaccination in heart failure. Over to you, Dr. Jain.
Hello, am I audible? And
yeah, very much.
Yes, sir.
Very
Yes, sir.
much.
Respected chairperson and panelists, thank you very much for asking me to share some of the views in the vaccination in the heart failure. We know heart failure is a common and severe cardiovascular disorder with increasing prevalence and high morbidity. Despite all possible best medical intervention, surgical and device management, mortality remains high and respiratory infections are common, is often exacerbate heart failure. Why? Alveolar edema reduces microbial clearance by blocking them in alveolar bed between air and lung tissue and thus increases microstasis. Well, we do know that it's 3 to 7 times more common pneumococcal pneumonia in heart failure patient. And similarly, flu infections offer more than, in first 6-7 days, you have 6 times higher chance of getting into myocardial problem. So, well, respiratory infection effects are what on the CV. There's a rise in the pro-inflammatory cytokine. There's an upregulation in the expression of cell adhesion molecule, which leads to endothelial damage and thrombotic event. Increased transmigration of inflammatory macrophage in the vascular intima enhances atherosclerotic process. And activation of sphingomyelinase pathway, which triggers cell apoptosis, increases myocardial collagen content and LV dilatation and LV dysfunction. And sometimes even this influenza vaccine promotes pneumococcal to become pathogenic. They are normal commensal in the nasal, but it interferes with the protective activity of the mucociliary system, promote invasion of respiratory epithelium through neuraminidase, which are precipitated by the influenza, and sometimes immunosuppressive pulmonary phenotype persistence because of the RNA infection. So influenza also worsens the heart failure by direct myocardial dysfunction or accelerating atherosclerosis or myocarditis, or sometimes dysfunction of endothelium and sympathetic overactivation. And now recently recognized, it blocks the bradykinin 2 receptor associated signaling pathway which protects cardiovascular system. So in nutshell, both the things are likely to worsen. The vaccination against respiratory infection in particular has definitely been seen, particularly in paradigm heart failure trial, where the 19% reduction in the all-cause mortality, particularly in the vaccinated group. Similarly, in flu cut study, it was also found the event rate was 6.2% as compared to 9.7% in the vaccinated group. So how pneumococcal vaccine helps? There's an inhibition of the oxidation, thus retard atherogenesis. It complete binding site to the antioxidized LDL-AB, and antibodies may neutralize the pro-inflammatory cascade in plaque induced by oxidized LDL. So, well, when there's we give influenza vaccination, there's a mild stimulation, activation and adaptive mechanism, and good homeostasis. While influenza infection, if occurs, there's a massive stimulation and adaptive mechanisms are deficient and can lead to cardiotoxicity. We do know influenza vaccination can given in time can reduce the heart failure precipitation, reduces the arrhythmia, hypotension. So this is how it works. We know if we have got influenza vaccine on one hand, pneumococcal vaccine on the other hand, we definitely help the patient of heart failure because there are many multiple pathways which are being taken care. Fatty stick formation is less, leukocyte intimal migration is less, alteration in the signaling is not impaired, so there is a good inotropy being maintained, and this is how both the vaccine can be given. And there have been central randomized controlled trial which has shown the effect of the vaccination cardiovascular diseases. FluVac, FluCAD, a trial by Wayne Herman and Flutomil. All have shown there is definitely reduction in the heart failure hospitalization. However, there was no big difference in the heart failure death, but the heart failure death, we know there's multifactorial. It's not only infection. So we have to accept it. And it has also been tried and seen in three heart failure investigators have published in 2017. There was definitely significantly late hospitalization from the person who were vaccinated. And it was around 66% in the vaccinated and 92% in the one who had undergone non-vaccinated. Paradigm heart failure, we know 21% reduction was definitely found in the patient who were vaccinated, and there was all-cause mortality and hospitalization was less. We have seen various trials, not one or two, which has shown definitely there's a reduction in the all-cause mortality with the flu vaccine, and particularly paradigm also has also shown that. And the trial which are coming up also is showing, even in one of the Danish study which you will see. So what are these vaccines? Pneumococcal vaccines are of two types, whether PPV or PCV. PPV definitely has got 23 strains which are definitely can be taken care. But IgM antibodies are developed here without the assistance of T cell. However, in PCV vaccine, there's a local nasal action also. It's more potent, and you don't need T cell. You have a T cell assistance, and there's a memory of the vaccination which would last for a longer period. These are the vaccination which are already approved. Whether in the viral, there are all many, and pneumococcal, there's a Pneumovax or Previnar 13, which I think most of our colleagues are already practicing in their real life, and these patients are benefited. These are the various organizations, like with the Heart Failure Society of America, American College of Cardiology, AHA, ESC, they all recommend one should be getting influenza and pneumococcal vaccine, particularly in an age group of heart failure, they will definitely benefit. And this is an invested trial which was done in 2009 that has shown high dose trivalent influenza vaccine versus standard quadrivalent vaccine in the cardiovascular patient. Well, again here there was no difference in the mortality, but particularly hospitalization rate was reduced, and the extra influenza strain present in the standard vaccine might have offset the benefit of higher dose. But standard practice that appropriate dose of inactivated influenza vaccine clinical benefit of flu vaccine is definitely beyond the age of 60 years. High dose is needed because these patients are immune compromised. However, in patients who are less likely to get infection or younger age group, you can go under low dose. Similarly, vaccination influenza, when it was seen in the one of the Danish study, where the patients were followed for 3.7 years and 1,34,000, there was 18% reduced risk of death of cardiovascular causes. We know that all patients may benefit due to antigenic drift, which permit virus to escape immunity through various exposure. But recent research is ongoing and possibly will get better result. So one more thing, influenza vaccination has to be timed well to generate protection and has to be repeated annually to reduce the heart failure hospitalization. Pneumococcal vaccine, we know a single dose of PVC-13 during their lifetime. But if patient is beyond 65 years, he should also receive PPS V3 because, and if we are giving both, there should be difference of the 8 weeks. In Capita trial, which has been tried in the past, around 85,000 patients, we found that the difference was phenomenal. In the future direction, need for good clinical trial, more effective vaccine, good anti-immunomodulatory effect, and vaccine adherence. So in summary, heart failure management is complicated by respiratory infection due to pneumonia, influenza, and high morbidity and heart mortality. Vaccines for both pneumococcal and influenza vaccines are effective to reduce heart failure hospitalization. And most importantly, vaccines are low-cost intervention for secondary prevention of heart failure. Guidelines are consensual to recommend influenza and pneumococcal vaccine in heart failure. But still, we are far from equipoised clinical practice. We all agree, in paradigm heart failure trial, in Asia, there are only 2% were vaccinated as compared to Europe, where 67% were vaccinated. The randomized controlled trials are needed, particularly for pneumococcal. However, we have good data on the influenza, but in general, the practice of vaccination in heart failure patient would definitely reduce their heart failure hospitalization rate and possibly mortality also. Thank you very much.
Thank you, Dr. Jain, for the excellent presentation. We know that in the US for a long time, they are giving flu shots in September, October time before the starting of winter season, especially in elderly people. And it has been shown that it reduces the incidence of heart failure to a great extent, morbidity and mortality from cardiovascular death. To a great extent in patients who are elderly in US, they are doing the flu, giving the flu shots. Now we are going on to the next talk, that is the treatment of iron deficiency in heart failure, ironing of the evidence. And it has been always a topic of discussion, and in clinical scenario, we may not be giving adequate importance to that. Iron deficiency anemia is widely present in the patients with heart failure, with an estimated prevalence of almost more than 50% in ambulatory patients. It is an independent predictor of worse functional capacity and survival. And the risk factors for iron deficiency include female sex, advanced heart failure, high levels of N-terminal pro-B type natriuretic peptide, and C-reactive protein. And are we adequately addressing this issue to all patients who are getting admitted with refractory heart failure, chronic heart failure? How far are we, or how commonly are we doing the serum ferritin and transferrin in order to optimize the treatment? And we know through many guidelines that it is nowadays enormously important to address this issue to optimize the better outcome of patients with heart failure. To highlight all these issues, we have Dr. Anup George. And I'm sorry that I cannot introduce his biodata. Anup George is with us to highlight this topic. Over to you, Dr. Anup George.
Thank you, Dr. Chairperson. The topic given to me today is iron deficiency in heart failure. The prevalence of iron deficiency is around 30% in stable and 50% in hospitalized patients, whether it is heart failure with reduced ejection fraction or preserved ejection fraction. Anemia, as defined as hemoglobin less than 13 in males and less than 20 in females, doubled the relative risk of death in heart failure patients. Now, the association between anemia and mortality is not linear. In fact, a large meta-analysis that was done in 150,000 patients showed that it was indeed a J-shaped curve with the lowest mortality between 13 to 16 gram per deciliter range of hemoglobin. Now, the jury is still not out whether anemia is a mediator or a marker of heart failure severity. Now, this cartoon here shows the various etiological factors causing anemia in heart failure. As we all know, heart failure is a pro-inflammatory state, and it causes release of cytokines such as interferons, tumor necrosis factors, interleukin-6, which results in a chronic inflammatory state, which negatively affects erythropoietin synthesis and erythropoiesis. The cardiac output is less in heart failure, which affects the renal blood flow, causing peritubular hypoxia, causing increase in hypoxia-inducing factor, which stimulates erythropoietin synthesis and erythropoiesis. But the medications that we use, which is one of the cornerstones, that is angiotensin receptor blockers or ACE inhibitors, negatively affects this mechanism and subdues this erythropoiesis process. Gastric edema, which is a part of heart failure, malabsorption causing decreased satiety, anorexia, and malabsorption can cause absolute iron deficiency, resulting in anemia. Fluid retention through hemodilution can again result in anemia. Now, how do you diagnose iron deficiency in heart failure? For a healthy subject, ferritin less than 30 or a transferrin saturation less than 16% denotes iron deficiency. But in heart failure, since it's a pro-inflammatory state, the cutoffs are slightly higher. A ferritin less than 100, or if it is less than 300 with a transferrin saturation of less than 20%, denotes iron deficiency in heart failure with a sensitivity of 82% and specificity of 72%. A single value of transferrin saturation less than 19.8% alone performed at least as well in detecting true iron deficiency. Now, the chart here shows the various lab tests available for the diagnosis of iron deficiency with their sensitivity and specificity. The bone marrow iron store estimation, as we all know, is the gold standard, but it is not practical to do it in every patient. Hence, among the other parameters that is available, we discuss the ferritin and the TSAT saturation. The transferrin saturation is having a better specificity than ferritin and sensitivity than ferritin. The one marker that is coming in vogue is the soluble transferrin receptor, which is increased in iron deficiency, but the importance of this receptor is that it is not affected by inflammation. But all over the world, the labs doing this marker is very less and it is very expensive, kind of impeding its common use. Now, what is the impact of iron deficiency in heart failure? It is associated with reduced exercise capacity, impaired quality of life, and poor prognosis, independent of anemia or ejection fraction. The peak VO2 was significantly lower in this group, and presence of iron deficiency without or with anemia is significantly associated with increased mortality in observational studies. Now, once we know what the importance of iron deficiency is, how do we go about treating it? Conventionally, what was used was erythropoiesis stimulating agents for the treatment of anemia. Many studies looked into the use of ESAs, the largest among which was RED-HF trial. And when they did a meta-analysis, they found that correcting anemia with erythropoiesis stimulating agent did not improve outcomes, but also increased the risk of thromboembolic events, resulting in a class 3 recommendation for them. Now, the other thing that they used was the role of blood transfusions. Again, studies which looked into it has come into the conclusion that a restrictive red blood cell transfusion strategy with a trigger hemoglobin levels of around 8 to 10 was a better strategy than a liberal threshold of targeting it above 10. Now, the other treatment modality is the use of iron, which is parenteral or oral iron. Parenteral iron scores over oral iron in many aspects. They had fewer GI side effects, they rapidly restored iron stores, compliance was much better, and more importantly, it was much more evidence-based. But it was much more expensive as compared to oral iron therapy. The chart here shows the evidence of parenteral iron in the treatment of heart failure. 2007 and 2008 was the time when the first two studies came, which used iron sucrose as the preparation. But the FAIR HF in 2009, the Confirm HF in 2015, and Effect HF in 2017, which used ferric carboxymaltose, showed consistent benefits. Most of it looked at improvement in 6-minute walk test and improvement in quality of life parameters. But there is one trial, Confirm HF, which showed decreased heart failure hospitalizations, although it was not a predefined endpoint. The parenteral preparation that we use normally is ferric carboxymaltose because it has the highest level of evidence. It can be administered at a large dose of 750 milligrams as it is a stable preparation. It has a high molecular weight polynuclear iron hydroxy carbohydrate complex that makes iron available in a controlled manner after uptake and which is regulated by the export into the reticuloendothelial cells. More importantly, ferric carboxymaltose releases less labile iron, reducing the incidence of iron toxicity. Now, all these trials helped the iron replacement to come or break into the guidelines in the treatment strategy in heart failure. And the ESC in 2016 gave a class 2A recommendation, and ACC gave a class 2B recommendation for the treatment of iron deficiency in heart failure with parenteral iron. Now, this chart shows the various ongoing trials which looks into parenteral iron in various aspects of heart failure, whether it will be heart failure with preserved ejection fraction, heart failure in the acute setup, and heart failure in the chronic setup. The FAIR HF2, the AFFIRM HF, HEART FID, and the Ironman trial. AFFIRM AHF was reported recently, and it showed a 26% reduction in heart failure hospital admissions with parenteral iron therapy in the setting of acute heart failure. The missing links that should be addressed in future should be the safety data on adverse effects of iron overload during long-term administration. The more research should go into finding out newer parameters which best reflects iron stores to guide iron supplementation and its utility in HFpEF subgroup. One ongoing FAIR HFpEF study is on, and the result of which will be keenly awaited, and the use of IV iron in acute heart failure. So in a nutshell, the take-home message is, as physicians or cardiologists managing heart failure patients, all efforts should go on to identify iron deficiency in this subgroup of patients and treating it with parenteral iron therapy in order to improve the quality of life parameters and to an extent reduce further heart failure hospitalizations. Thank you very much.
Yeah.
Excuse me, chairpersons. Excuse me, chairperson. Dr. Andrew Goetz is on the line.
Okay.
Yeah. So would you invite him for his presentation?
Okay, we can discuss it later on, and let's Dr. Coates talk should begin.
Hello, would you like me to share my screen and give my presentation live?
You can share a screen and
welcome everyone. It's my great pleasure to be here. I'm sorry I can't be there in person, obviously during this very difficult year. I'll be talking about decoding new heart failure science. Where and how do I put dapagliflozin in the treatment regimen? My name's Andrew Coates, and here are my declarations. We know that in heart failure with reduced ejection fraction, we have very many treatments that have worked. Here I outlined some of the major treatment trials over the last 3 to 4 decades, and you'll see I've grouped them based on the mode of action. So initially we had some vasodilator trials, VHEFT and AHEFT. Then we had other vasodilators, but of the ACE inhibitor group. consensus VF2, solve treatment, solve prevention. And of course, we realized soon after these trials were done that it probably wasn't the vasodilator element that was most beneficial. It was the fact that they were neurohormonal inhibitors. That led to the development of beta blockers and then mineralocorticoid receptor antagonists, and then subsequently ARBs. Then there was quite some gap before, we had about 10 years before there was a major step forward. And then we had the Paradigm HF trial of sacubitril/valsartan, which of course is a neurohormonal modulator. There was a period of perhaps a decade and a half where there were very few drug trials, but we had a lot of device trials, some other treatment management trials, some surgical trials. But then in the last few years, we've had another dramatic explosion of pharmacological treatment with different agents, vericiguat, with omecamtiv mecarbil, with IV iron, which we've just heard about, but also the class of SGLT2 inhibitors. And that probably is the biggest advance we've had for some decade or two. Now, why these treatments are important is that we know that they can reduce mortality. Each of these incremental treatments has reduced mortality somewhere between 15 and 25 or 30%. But you need to have the patients on treatment. Multiple registries, and here's results from European long-term registry, have showed that the majority of patients are not on full-dose guideline-directed medical therapy. Here we see ACE inhibition, where on target is only seen in under 30%, beta blockers under 20%, MRAs under 30%. Some patients are on partial dose and they're still up titrating because it takes some time. Some patients are not actually on treatment. So we know that there's still some work to do to get the full benefit. We also know that we require these multiple treatments to reduce mortality. Here's an analysis from Greg Follero, but similar work's been done in Europe, showing that the 2-year mortality rate is progressively reduced the more and more of the effective treatments we have on board. So these treatments are only worthwhile if our patients are actually taking them. And you see the odds ratio for reducing mortality is really very substantial, provided, of course, we are taking these multiple treatments that now numbers some 5, 6, or 7 therapies if we include devices as well as pharmacological treatment. When we turn to our guidelines, however, we realize that the guidelines are very careful and they recommend we start treatments in the way we did the trials. So we start with ACE inhibitors and beta blockers. And of course, we all are used to the mantra of starting low and going slow. Particularly of beta blockade. So it may take some weeks or even months to fully up inhibitors and beta blockers. We then ask patients to be re-reviewed and check that they're still symptomatic and their ejection fraction is still below 35% before we recommend further incremental treatment with MR antagonists. You see now that the other options such as sacubitril/valsartan or ivabradine for patients with sinus tachycardia come somewhat down the treatment algorithm. Now, what is new? Well, what is new is in the last few years, we've seen a new drug class initially developed for the treatment of diabetes, type 2 diabetes, the SGLT2 inhibitors or gliflozins that reduce heart failure hospitalization, cardiovascular death, and renal outcomes in diabetic patients. Here we see a meta-analysis showing that these trials all basically show similar results, some slightly better, some not so good. But there's a very consistent effect on heart failure hospitalizations or cardiovascular death and renal outcomes such as renal worsening, end-stage renal disease, or renal death. And that led to the subsequent evaluation of this drug class in a number of different conditions. Within type 2 diabetes, in the preclinical stage of cardiovascular disease, in the clinical stage of the disease where there may be myocardial infarction, and more recently in established heart failure with the DAPA-HF and EMPEROR-reduced trials being reported. There are other trials in HFpEF still to come. We are so excited because these drugs, which were relatively modest hypoglycemics in type 2 diabetes, seem to have substantial benefits in preventing heart failure, and even, as we will see, in patients with established heart failure. And we believe that multiple modes of action are responsible. You can easily see that the renal effect can explain glycosuria and some sodium excretion and water excretion, which can lead to diuresis and reduction in serum glucose. But there are also effects on the heart and blood vessels that could modify some other benefits independent of those of renal function. So that led to the fundamental trial that's now only some 14 or 15 months ago, the DAPA-HF trial of 4,744 patients. It was a randomized comparison of placebo or dapagliflozin, 10 milligrams once a day, with 800 an event-driven trial aiming for 844 primary endpoints, which is a composite of CV death, heart failure hospitalization, or a heart failure hospitalization equivalent, that of an urgent visit for the management of heart failure. The primary endpoint, as shown here, was highly significantly benefited with P equals 0.00001. The hazard ratio of 0.74 showed a huge benefit of 26%, and the number needed to treat was only 21 patients to prevent one primary outcome. You see a substantial 4 absolute patients protected per 100 per year. The two components of the primary endpoint were also both significantly reduced: first, heart failure hospitalization by 30% and cardiovascular mortality by 18%, both statistically significant independently. Furthermore, this trial included almost equal numbers of patients with type 2 diabetes as without diabetes, and you see the hazard ratio was virtually identical, and in both cases it was statistically significant. So this drug, which started life as a treatment for diabetes, actually reduced the composite endpoint in patients even without diabetes when given to patients with heart failure. In addition to improving clinical outcomes, the patients felt better, and probably what's now accepted as the most accurate measure of quality of life we have, the Kansas City Cardiomyopathy Questionnaire, looking at the total symptom score, the number of patients with a greater than 5-point improvement in quality of life was significantly higher on dapagliflozin, and the number of patients who showed a greater than 5-point decrease in quality of life was significantly less likely in dapagliflozin in both patients with diabetes and without diabetes. So we really had a substantial treatment advance. It reduced mortality, it reduced heart failure hospitalization, and it improved quality of life statistically, very importantly. Secondary endpoints are also important. So the composite of CV death or true heart failure hospitalizations significantly reduced by 25%. The total number of heart failure hospitalizations, looking at first and repeat events combined with CV death, also significantly reduced by 25%. And all-cause mortality reduced by 17%. That was also statistically significant. We also had evidence that this drug was improving the kidney and protecting the kidney. So there was a 44% reduction in the incidence of acute kidney injury, defined as a doubling in serum creatinine since the last core lab value. You see there the hazard ratio of 0.56, P equals 0.003, a progressive protection from this adverse renal outcome. That wasn't the only trial. It was followed a year later by the Emperor Reduced trial, which was somewhat similar, but slightly different, slightly smaller, also HFrEF patients, but now with high levels of N-terminal proBNP, but a shorter duration of follow-up and smaller patient numbers. Primary endpoint was a composite of CV death or heart failure hospitalization. That was the same. However, slightly different primary and secondary endpoints. That was a total first and recurrent heart failure hospitalization, and then a lot of statistical power put into the evaluation of renal function by looking at a secondary endpoint, a more accurate measure of renal function, the slope of decline in GFR over time. We see here that the primary and secondary endpoints of Emperor Reduced with the drug empagliflozin were also significantly benefited. Similar size effect, 25%, highly statistically significant, both in terms of the composite endpoint and total heart failure hospitalization, which was a 30% reduction. Also, this renal endpoint was slightly different, was a significant benefit where the reduction in GFR over time went from minus 4.2 mils per minute per 1.73 meters squared on placebo to minus 0.9, so about a 75% reduction in the rate of decline. An interesting feature is that there was an initial decline in apparent GFR, but then a flattening of the slope. What isn't reported here, but is in the paper, is that when the drugs were stopped, there was an immediate bounce back of GFR. So this initial decline is not a true measure of worsening renal function. It's rather a hemodynamic effect of the agent, and actually the renal function is preserved. What that means, and this trial included patients with GFRs down to 20, is that you should not react badly to the initial reduction. It's a sign the drug is working, and you should maintain the treatment to protect renal function. Both DAPA-HF and EMPEROR-reduced had some patients on sacubitril valsartan, because a common question is whether their benefits are alternatives to those of sacubitril valsartan or whether they're additive. And the number of patients on treatment went from about 1 in 10 in DAPA-HF to about 1 in 5 on EMPEROR-reduced. But in both trials, the benefit is seen both in patients on sacubitril valsartan and not on sacubitril valsartan, with very similar benefits, showing that the benefits of the SGLT2 inhibitors and sacubitril valsartan were not alternatives, they were additive. And the benefits are there irrespective of treatment with sacubitril valsartan. Now, we've subsequently had more trials. We've had trials specifically in kidney disease without heart failure. The DAPA-CKD trial looked at dapagliflozin in patients with chronic kidney disease, and its primary endpoint was significantly reduced. That was a sustained reduction in GFR, end-stage kidney disease, or renal or cardiovascular death, and that showed a nearly 40% reduction of high statistical significance. It also was associated with a reduction in cardiovascular mortality and heart failure hospitalization. One question that was left unanswered is whether patients with an acute admission could also be safely commenced on these drug classes. And another trial was presented recently, and that was Soloist, and this was different because this was a different SGLT2 inhibitor, sotagliflozin, commenced in patients still in hospital with worsening heart failure. The trial did not reach its primary recruitment target because the company ran out of money during the COVID period, and it was stopped quite early with only 1,222 patients randomized. Despite this, 608 versus 614, the effect was statistically significant. So the primary efficacy was total cardiovascular death, heart failure hospitalization, or urgent heart failure visit. And you see there a 33% reduction, highly statistically significant. So although this trial was far smaller than it was planned to be, it also seemed to support the evidence we'd had from DAPA-HF and EMPEROR-reduced that this drug class is highly beneficial. It is too early for us to say in truth that this is a drug class effect, that all agents are the same. We do know, however, that the main one studied, dapagliflozin, empagliflozin, and to a lesser extent, sotagliflozin, do appear to be beneficial, but perhaps we should restrict ourselves to those with the most substantial evidence. It was interesting analysis in this where patients were started during the acute hospital admission. There was a significant benefit even by 1 month. And that's a strong argument that if you have a patient in hospital for worsening heart failure, you have both the safety to start and also a strong argument to start quickly because you get a benefit as early as 1 month. And similar results have been seen with dapagliflozin and empagliflozin. In summary, I would say that dapagliflozin, as the lead agent in this class, has substantial evidence. It reduces the risk of worsening heart failure events and cardiovascular death. It improves symptoms in patients with heart failure with reduced ejection fraction on top of all other standard therapy. The relative and absolute risk reductions in death and hospitalization were substantial, clinically important, and consistent across all looked at subgroups, including patients with and without type 2 diabetes. It's extremely well tolerated. The rate of treatment discontinuation was low. The rate of serious adverse event was below that of placebo. And it's an extremely easy drug to start because it's a single dose, 10 milligrams once a day, that does not need up titration slowly and does not have a significant effect on blood pressure or heart rate. We now recommend, and this is not an official guideline, it's my own personal way of presenting what might be treatment guidelines in the future. We have treatments that are must-dos. To reduce mortality in the majority of patients, we now have 4 major drug classes: ACE inhibitors or ARNIs, beta blockers, MRAs, and the new class of SGLT2 inhibitors, with the 2 lead agents, the most evidence for dapagliflozin and then empagliflozin. Then, of course, we have treatments available for selected patients such as CRT or ICDs in certain patients. We then have treatments that reduce the composite endpoint, such as ivabradine for sinus tachycardia, hydralazine isosorbate dinitrate for those who are Black origin, and CRT for some extended indications, and we have options for advanced heart failure. But this first step of must-do treatments now includes a 4th drug class, that of dapagliflozin, the SGLT2 inhibitor. Thank you very much. I will stop there.
Thank you, sir. Thank you for the wonderful talk. May I ask you a doubt?
Yes.
Sir, in patients with type 2 diabetes mellitus with established atherosclerotic cardiovascular disease, which will you prefer, empagliflozin or dapagliflozin?
To be honest, I think in terms of type 2 diabetes, the results are relatively similar. These 2 drugs are more alike than they are different. And I would personally use the drug that looks more like the patient you treated. So for the exact patient, you'd say empagliflozin in the EMPA-REG reduced trial, EMPA-REG trial is very good. But if you're more familiar with dapagliflozin, I think that that also has substantial benefit. So it's probably better to get more familiar with a drug rather than necessarily use the different drugs in slightly different indications, because we now see benefit both in preventing heart failure and in treating heart failure.
Okay, sir. Thank you.
So one point,
Dr.
Sadish.
Are we supposed to stop dapagliflozin before routine coronary angiogram, just as we do with the metformin?
No, I don't think so, honestly. I mean, they're slightly different if you have a diabetic patient with very fluctuant blood sugar levels. Maybe you might take advice on that. But for the majority of cases, these agents are very mild glucose lowering agents. There is no need to do that. The risk of diabetic ketoacidosis, any metabolic effects is extremely low, and I see no need to stop that for surgery or during other illnesses.
Yeah, my concern is it may induce mild intravascular volume reduction, and pre-renal renal injury may be there. That is what my concern.
You do need careful management of fluid status. They're not powerful diuretics, far less than loop diuretics. And when you start them in a person on a high dose loop diuretic, it's appropriate to reduce that. So I think I would just use clinical judgment in terms of managing fluid status rather than having a routine stop. Clearly, if you stop for a day or 2, you're not going to lose the benefit. The danger would be if someone stops routinely and then people forget to restart.
Thank you, sir.
So I would like to acknowledge that the FDA has approved dapagliflozin for the treatment of heart failure with reduced ejection fraction in adults with or without type 2 diabetes mellitus. I think this topic is open for discussion, and the panelist, Dr. Sadish Kumar, you can also make your comments on the topic. Yeah.
Yeah, I have a query from Dr. Chopra about use of metalazone on top of furosemide or torsemide. Should we start or add higher doses and then go down, or should we start with lower doses like 2.5 milligram of Zytenix and build up the dose for optimum diuretic therapy?
Well, hello to Vijay, first of all. But certainly, I mean, it's one of the skills of heart failure. We don't have major trials of diuretic dosages, but the combination of frusemide with the addition of metolazone can be a very powerful antidiuretic combination. So when you first try it, you should be fairly careful and only use 2.5 milligrams. Keep a careful eye on electrolytes. If you have a patient that's chronically, regularly taking that, then I think you get a lot more comfortable with what dose of diuretic they need. But yet again, when you're starting dapagliflozin, you may well want to back off probably the frusemide dose just to make sure you're not overhydrating. So it really is the art of medicine, documenting the exact diuretic regime you need for a patient. It's very difficult to come up with a standard recipe when you're using powerful drugs like these in combination.
Sir, do you routinely look for bone mineral density or osteoporosis before starting these drugs?
I don't. There was a concern about fractures, but the big trials don't suggest that shows up statistically significant. Inevitably, when you're looking at an individual patient, you take into account all the factors, and if there's a high risk for osteopenia or osteoporosis, that's appropriate. They may well be thing, but it's not a reason to be cautious about the use of SGLT2 inhibitors. The benefits are substantial, and the risk of worsening osteopenia is really very modest.
Thank you, sir.
Sir, will it be an overstatement that after somebody has been properly revascularized and we give optimum doses of pharmacotherapy in form of beta blockers, RAS blockade, including ARNI, of course, diuretics, SGLT2 inhibitors, and prevention of iron deficiency and infections, can we abolish interventions like CRT or cardiac transplants in times to come?
Yeah, it's a really tricky one. The question is, we have so many treatments now for heart disease. Each one reduces mortality maybe 15, 20, 25%, but we never abolish that. So there is a slow progression of the disease. We saw the result of using 5 or 6 treatments, a 75% reduction in the adverse outcome, but that still leads a progressive worsening that's greater than someone without cardiovascular disorders. So the opportunity and the tragedy is our success still means we have patients left with some residual burden of disease. We have not abolished the disease. There's no such thing in chronic disease management as complete reversion to normality. I think we can't expect that.
Regarding SGLT2 blocker, what is the role of sodium hydrogen exchange blockade by SGLT? Is it specific to one of the agent or is it common for all the SGLT2 blockers?
It is common. There is interest in the SGLT2 and 1 inhibitor, sotagliflozin. Maybe it's got effects that are outside of the kidney and particularly the gut. The sodium hydrogen exchanger is probably an explanation for the benefit, part of the benefit, and that has a benefit in the cardiac muscle. But I believe that applies to the SGLT2 inhibitors as well as the non-selective SGLT2 and 1 inhibitors. To be honest, we don't know the precise mode of action, and we rarely ever do. Even for beta blockers, MRAs, we still don't know exactly how they work. It's only by theory and by looking at different drugs with slightly different profiles we get a suggestion. We know these drugs are profoundly important. We know they have multiple beneficial effects, but still as yet we don't know what the critical element of the benefits are. And perhaps we never will know that absolutely accurately.
Possibly calcium overload is less due to this NHE blocker? Calcium
yes.
overload?
Yeah, I think so. You'll certainly get improved sodium balance, water balance. You will get metabolic effects. You'll get intracellular electrolyte differences. There could be theoretically be interaction with digoxin, but it's very hard to know, and we have to depend on the major treatment trials and then fine-tune ideas and test them again in subsequent treatment trials. But as I said earlier, unfortunately, we never do get the precise mode of action nailed down, or we often don't. I hope we will eventually.
Can we say, sir, that it is hypothesized that osmotic diuresis induced by SGLT2 inhibition, a distinctly different diuretic mechanism than that of other diuretic classes, results in a greater electrolyte free water clearance and ultimately in greater fluid clearance from interstitial fluid space. What we see other than just a different way of diuretic action, what we do not see in the normal diuretic class. Is it applicable to dapagliflozin or SGLT2 inhibitors by which we achieve the goal in the heart failure treatment? Could it be that?
Yes. Yeah.
One hypothesis.
Yeah, you're absolutely right. There is an element of osmotic diuresis, and they are sodium glucose tow transport inhibitors, and they have particularly effect in the proximal convoluted tubule. So if the glucose level is elevated, then the blockade of the sodium glucose co-transporter will lead to increased glucose load in the tubules that will spill over to glycosuria, and that will take with it water balance. So you will increase free water clearance. And that's an element of the diuretic effect, but it's not the sole element because sodium also comes out, and that's a diuretic effect. If you now turn to its role in patients without diabetes, without elevated blood glucose levels, then you get virtually no glycosuria. So you're not getting the osmotic diuretic effect, but you're still getting the natriuretic effect and aquaretic effect. So it does have two different diuretic modes of action, one that's more prominent in patients with high glucose levels and one that's more prominent in patients with normal glucose levels. So it is a very smart diuretic agent, and we do have now diuretic agents that work in different parts of the nephron, and we need to be a little bit more sophisticated how we put them together to control fluid retention in all our patients.
Thank you. Thank you. Any other questions from the panelists, Dr. Sadish Kumar, Dr. Rajesh?
Sir, you told that is useful in heart failure with chronic kidney disease. I want to ask a question. Is it particularly useful in albuminuric chronic kidney disease? That is where the urine albumin creatinine ratio is more than 300, especially?
Yes, yeah. Well, the trials, we've only really got 3 trials of this drug class, Credence, DAPA-CKD, and the most recent SCORED trial. And they've slightly recruited patients with different types of CKD. It does appear DAPA-CKD had patients both with low renal function, but also with albuminuria, and it was profoundly beneficial. In the SCORED trial, we didn't have as much albuminuria, but it was also beneficial. So I think it works in both types of CKD. In patients with poor renal function as well as albuminuria, you don't require one or other to get the benefit. It seems to be beneficial regardless of which type of predominant renal disease you are. And this really is quite profound. If you look at DAPA-CKD and EMPA-REDUCE, they're going down to GFRs of 20, and then they're getting that acute reduction. So we're really pushing right into the pre-dialysis phase. Previously in heart failure, we had no treatment trials that ever recruited someone below 30. We're now pushing that barrier and seeing further benefit and further protection from the kidney. So really, kidney disease and heart failure are now coming in with this drug class into being able to be treated with the same agents. And we need to be more ambitious and hold our line and more aggressive about treating very poor renal function. And the difficult bit is GFR will fall initially. You have a patient who starts with a GFR of 20 and it drops to 15 or 12. People are going to worry. And yet you probably should try and maintain that because it actually protects the kidney long term.
Yeah, to the organizers, the time scheduled is over. Can we go further with the discussion or should we close the session? To the organizers. Because it is scheduled up to 2:15 and we are now over, it's almost 2:20.
Yes,
and,
sir, you can continue the discussion till 2:30, sir.
Okay. Now, so to the panelists, any more questions?
I just had a question to Dr. Andrew Coates.
Yeah, Dr. Anup George, please ask the question. Dr. Anup George.
In the pharmacological armamentarium that we have for heart failure, there was a flurry of activity in the towards the end of the last decade with ARNIs and SGLT2 inhibitors, maybe after 1.5 decades. So looking ahead, which agents holds promise according to you, sir?
Well, we have two other agents that have positive trials whose role in clinical practice has not been established. That is the soluble guanylate cyclase stimulator vericiguat and the direct myosin activator omecamtiv mecarbil. They both reduce the composite endpoint of cardiovascular mortality and heart failure hospitalization. But the effect was much more modest than we saw in DAPA-HF or EMPA-reduced. So we don't quite know how they will work. Now, they're an interesting contrast because they both had approximately a 10% reduction in the composite endpoint. But in the Victoria trial, the benefit was least evident in the sickest patients. So those with the worst end-terminal proBNP and the lowest GFRs didn't seem to get as much benefit. So it appeared that the sicker patients were probably not the ideal patients. Whereas for omecamtiv galactic HF, we actually had the opposite. The sickest patients are the ones that had the biggest benefit, the lowest ejection fraction, the highest end-terminal proBNP, the patients with the highest NYHA class. So if you're asking my personal opinion, because none of these have been considered by a guidelines group, I think omecamtiv may well have a niche for patients with severe heart failure, because that's a group where we're really short of drugs that work. And it's a drug that does not reduce blood pressure, which is an advantage because many of these patients have low blood pressure. So I would like to see it approved because I could see a role for it. The other interesting feature is it did not appear to be beneficial in patients with atrial fibrillation, which meant in those with sinus rhythm, which are about 60%, the benefits were more marked. So I think for omecamtiv, the patients with sinus rhythm and very poor left ventricular function who've had a recent admission due to worsening heart failure despite being optimal treatment, I can see a role for omecamtiv in the future. For vericiguat, I could see that I would like to have it available because I might use it, but its role is not quite so clear. Looking on the horizon, other things that may be coming, I think the big advances will be in HFpEF in the future, SGLT2 inhibitors. There are other drugs. I think we're seeing an extension of the use of IV iron we've heard about. There are other drugs, nitroxyl donors, but I think they're still some while away. We also have a non-steroidal mineralocorticoid receptor antagonist, finerenone, that's got trials underway. So there's still some interesting stuff on the horizon, but we still haven't cemented the precise place in treatment for either vericiguat or omecamtiv mecarbil.
Now, can I ask you a different topic, sir? Now, the influenza vaccination is an effective measure to reduce all-cause mortality during seasonal influenza epidemic. The high-risk population, especially the most elderly with significant comorbidities, and it has been shown that by giving yearly flu shots, I think which is being given in US, it is going to substantially reduce the incidence of patients who are going for a very bad heart failure. Is it going to help not only the influenza, but also the pneumococcal vaccination? Is it going to be more prevalent? How efficacious these vaccinations are, or how important, especially also in the scenario of COVID. Now, we are worried about the vaccinations very much. Now, it has been given earlier times in US, to my knowledge, if I am right, flu shots are given in September, October time regularly to attenuate the incidence of influenza, which may be lethal in elderly people. Can you highlight that topic?
Yes, no, it is important. I mean, I think it's very important we realize a trend we have seen over the last 10 to 20 years. The heart failure specialist is no longer a specialist in how to treat heart failure. They have become a specialist in how to treat patients with heart failure. And that's a very important differentiation because patients with heart failure are elderly on average age of onset 76 years. They have multiple comorbidities, multiple other features going on, multiple other drug treatments, and they are at increased risk of lots of other conditions causing morbidity and mortality. We know in the COVID epidemic that the heart failure population was at very dramatically increased risk of hospitalization, intensive care stay, and mortality, so they needed to be protected. And you're absolutely right, there is evidence. It's not something that the heart failure specialist often reviews, but there is evidence of the beneficial effect on a population level of routine vaccination for seasonal flu. The choice in the individual patient, however, you have to take into account many circumstances, how severe their illness is, what the social circumstances is, their exposure, their contacts. So I'm hesitant to give a blanket recommendation that every heart failure patient must be given the treatment. However, I think it is a useful way of protecting our heart failure patients, and we should probably do it more than we routinely do.
Thank you, sir. Any more questions from the panelists?
I think we have
please.
4 more minutes.
Yeah.
One question
please,
to
Rajesh.
Dr. Anup.
Go ahead,
Anup is here.
Rajesh.
Anup, can you hear me?
I can hear you, Dr. Rajesh.
You told ferric carboxymaltose is the preferred iron for treatment of anemia and heart failure.
Yeah.
But this is, of course, a costly molecule, isn't it? So can we give other molecules like iron sucrose or iron dextran or iron isomaltose? Are they useful because they are cheaper? Is there any data in favor of them?
Yeah, thanks for the question, Dr. Rajesh. I think I addressed that in my talk. If you look at the trials that has come in, the first 2 trials used ferric sucrose as the agent. The subsequent trials used ferric carboxymaltose. Now, ferric carboxymaltose is preferred mainly due to 2 reasons. One, the maximum evidence favors ferric carboxymaltose. Second, it releases less labile iron, which is thought to have reduced side effect profile with regard to the toxicity of iron overload. So these are the 2 reasons. One, it has got maximum evidence because most of the trials of, which use maximum number of people have used ferric carboxymaltose. It is a much more stable preparation. You can give it a very high dose, that is around 750 milligrams in one shot, and it produces less labile iron, which translate to reduced side effects over a long term. So these are the reasons why we prefer ferric carboxymaltose.
Thank you,
Chairpersons and
Dr.
speakers.
Anup.
Time is up.
Are we going to close or one more remark?
Yes, sir. We are going to close the session, sir.
We are going to close.
Yes.
Okay. So now, excellent exposition, talks of all the speakers, Dr. V.K. Chopra, Dr. Vidit Jain, Dr. Anup George, and Dr. Andrew Krootz, and the panelists, Dr. Professor Rajesh and Dr. Sadish Kumar. It was excellently done. All the speakers did a great job. It was lucid presentations, and I think we could cover the scenario of heart failure very nicely. Thank you all profusely. Thank you so much.
Okay. Thank you, sir.
Thank you very much, everyone.
We
Next
close the session
Dr.
79.
Goyal PK will be the chairperson. And Dr. Jayagopal will be a chairperson for the session. Over to you, sirs.
Good afternoon, everybody. Let me welcome Dr. Pillai, Dr. Goyal, Dr. Shivaprasad, and the expert panel, Dr. John, Dr. Charan, and Dr. Rajiv. We have some interesting cases. What we have mentioned as the desperate measures. We start off with Dr. Srinivasa Kumar on a post-MI VSR closure. Over to you, Dr. Srinivas.
Yeah, thank you, sir. Thanks, CSI, for the opportunity. As we are introduced, we are dealing with some tough situations. And all of us know that post-MI VSD closure is one of the difficult problems we have to tackle in some of the sicker patients. And let us see how to do it. Greetings from Apollo Group of Hospitals. Proud to present my FACS Professional Services colleagues. 25 cardiologists work in hub and spoke model in multiple hospitals. Very useful in these tough times of COVID. Coming to the general introduction statistics, we had VSDs happening about 1 to 3% before the reperfusion, and after the reperfusion fibrinolysis started, it decreased to 0.2 to 0.3%, and with primary PCI advent, it has further decreased. And we did notice some slight increase in these COVID times because of delayed presentations and some on and off mechanical complications not seen, we could see in some patients. But when the patient presents in cardiac shock, he has more incidence up to 4%. And there is some data to show that females are preponderant, but in this particular thing, it was 3:2 with males to females. And single vessel disease predominance is more. And bimodal peaks immediately within 24 hours, and then something to 3 to 5 days later, when they go into gradually cardiac shock, we could detect these patients of VSD. And chronic VSD, some nature selects these patients, and they could present late after a month or so. The clinical features, shortness of breath and chest pain, and gradually go into hypotension. On examination, you find harsh systolic murmur, systolic thrill, and third heart sound, and the patient gradually go into pulmonary edema and cardiac shock. ECG, we know that there are persisting ST elevations, like you suspect ventricular aneurysm. Similar thing could happen in here. And if you see the echo is diagnostic modality. As you see here, you could see VSD's septum being ruptured, and depending upon the types of VSDs, there could be anterior or posterior location, and then the echo clinches the diagnosis. And before, we used to do right heart caths more commonly, but now with the advent of better quality echo, we do see this LV angios less commonly. But this is one of the patients in which a device closure was planned, and you see that mid-muscular VSD, which is seen here. Angiogram, there was a controversy whether to do it or directly to send the patients for surgery. Level evidence of B is basically when anyway patient is going for surgery, you could do stabilize the patient with IABP and take them to cath lab and do an angiogram. This is one of the patients where LAD was occluded from the before, and then patient had anterior MI. As I said, inferior MI sometimes could be leading to serpiginous VSD tracks. Post-MI VSR classifications, immediately it said less than 24 hours, you find just abrupt slit-like tear, that's a type 1. Type 2 is subacute presentations, gradual erosion of the infarcted myocardium happens. And type 3, rupture with concomitant aneurysm, which generally happens in older infarcts presenting a month or later. This is the anatomy types. It's important for us when you're planning for device closure, especially the simple ones with through and through defect like this, you can handle it percutaneously. But the complex serpiginous tracks, which you see, the entry points on the RV side and the LV side are different, where the VSD running through the septum, then that becomes quite challenging for percutaneous closure. Probably surgical closure could be advantages there. Coming to which patients would go into VSD, the advanced age, anterior location, female sex, CKD, and delayed thrombolysis is another risk factor for getting into VSD. Some of the protective things are chronic angina and diabetes, hypertension, history of smoking is seen in Gusto. And Gusto analysis showed the 30-day mortality will be very high, up to 75% in these patients. And of late, the primary PCI series, it showed that some of these complications could be tackled and the survival rates could improve up to 20% even in this, and frequency of VSD decreased significantly in this primary PCI series. Coming to the treatment modalities, what is the discussion of point is basically initial medical therapy will help us to stabilize and then plan the procedure depending upon the type of VSD, whether you could go for device closure or surgical treatment. Medical therapy initially, as we put an IABP support, and it depends on the pressures. If the patient can tolerate, you can stabilize little with IV nitroglycerin vasodilators, and you also use inotropes if patient's blood pressure is going down. And once the patient slightly stabilizes, then you decide whether you're trying to take up these patients for device closure. But generally, it becomes very high risk, and now it is done often being recommended only for patients who have severe coronary artery disease, hemodynamic instability, added comorbidities like renal failure and diabetes, where surgeons are not willing to operate. But residual VSDs after the surgical repair, actually, that could be closed with device. Coming to the devices, various types of devices, what are available, to name it, I have provided there, but most commonly we've used ASD occluders in this, and some of these muscular type of device closures also have come. We have done some ASD closures. Then probably all the precautions which need to be followed for any percutaneous closure, like ASD, you need to follow it and heparinize them, antiplatelet therapy, and echo guidance is important. Generally, we take 2 to 8 larger device compared to at least what appears on echo, because it tends to give up way. The friable tissue again tends to give way, and the balloon sizing is not recommended because the defect could increase on it. The people have used various sizes of defects, 15, 24, and some data of 35 usage also. But what we need to realize is that the device size becomes bigger, there's more chance of embolization. In this one of the series with Amplatzer, the large meta-analysis showed that the mortality could decrease, and the survival could improve up to 34% in 30 days, but residual shunts as high as about 40% could persist in this patient. This is a recent publication which was presented in Neurointervention in 2016, where 13 studies were again significantly seen with device closures, and then 89% was the technical success using device closures. 1 month mortality was still high, about 32%. And then embolizations, arrhythmias could happen. Shortcomings when you try to analyze why is it happening, because the friable nature of the tissue, the rigid sheets, and in fact the supporting wires also could cut through the myocardium and increasing the device sizes. And that's how there could be large defects produced and more of embolization happening. And sizes of devices are also limited. There could be device migration, complete heart block, and this going through mitral tricuspid cardae also could be a problem. So as of now, surgery still holds good for because the gold standard. Basically, they also treat an infarcted myocardium and also patch up the ventricular defect. The two types of techniques are described, Daggett procedure and David procedure. This classical approach where the infarctectomy is done along with the closure of the defect with a Dacron and patch. And if it's inferior posterior, it is done resected like this, as shown in the picture. Then double patch repair of the VSD is also done sometimes without touching much of the infarcted muscle. Then exclusion technique is quite popular among surgeons now because we know that RV, if it is disturbed, the mortality would improve. So basically what is done is LV, infarcted muscle is excluded by bovine pericardial patch. And then that's how healthy tissue to healthy tissue is being sutured with a pericardial patch. Surgical data, large database showed that immediately if it is operated, mortality is high. That's how we try to stabilize the patient where the mortality could decrease. For the sake of time, I'm not going to details. These are not non-randomized studies, all retrospective studies shown that if the patient can stabilize a little, the mortality could decrease. Our group, in the earlier group of hospitals, we had done for about 12 cases surgery, about 10 of them were all right, and then 2 devices, unfortunately, we lost them. Of late, 12 cases, surgical techniques have improved and all of them are doing well. Another sister hospitals here, about 5 cases of device closure did all right out of the 7. This is personal communication. This is incidentally one patient came for follow-up. This is a device closure was done, and that sort of thing, patching is still working and patient is doing fine. One of these residual defects could lead to hemolysis. Of this, we need to take care of the patient's post-procedure also. As of now, the class 1 indication is a closure by surgery, and the CABG with the graft also is recommended. It's a level of evidence is B. Then appropriate insertion of IABP and a prompt surgical heart team decision to treat these patients along with grafting is what recommended. Just before I close, I would like to present this management protocol. Basically, acute MI with ventricular septal rupture. If it's hemodynamically unstable, then probably you plan them for immediate surgery. If surgery cannot fit up suitable, then percutaneous closure if possible. Hemodynamical stable, large VSD, you tend to buy some time with IABP or ECMO. And probably if a patient can be stabilized for a week, then he could have little better outcomes. But if it's a small VSD, then nature selects themselves, and the probably conservative management initially followed by elective surgery later, or a device closure could be the treatment of choice. Thank you for that. I think to conclude, this is what as post-MI VSD bears high mortality, and in spite of all the advances, transcatheter device closure is still evolving, and as of now, it is recommended for surgically unsuitable patients, and we need to further study and develop more technical expertise to treat these patients and to make them all right in the acute stage. Thank you very much.
Thank you, Dr. Srinivas, for an elegant review of the post-MI VSR situation. I think we'll have the questions towards the end of the session. Without wasting much time, I think we'll go into the second presentation by Dr. Vijay Bang. Is Dr. Bang here?
No, sir. No, sir.
Free wall rupture. So if he's not there, I think we'll go.
I can take on. I'm next.
Yeah.
Dr. Ravi
Covered stents for arterial access injuries, Dr. Ravi Kalra. Dr. Goel, you have joined. Yeah. Nice to see you. Hello.
Can you see my screen?
Yeah. Very, very clear. Loud and
okay. Thank you. So I'm speaking on covered stents, how they can be a lifesaver in femoral arterial access injuries. My claim to fame is nothing much. I've served for many years in the Indian Navy, and today I have retired from the Navy and I'm head of the Department of Cardiology in Bharati Vidyapith in Pune. I think I'll present a case which probably says it all. This can be a condition which can really, really ruffle your feathers, and I think everyone should be familiar with how to tackle it. This is a 56-year-old male who came to us about 3 months ago during the lockdown, farmer by profession, brother of a doctor. Anterior STEMI in the morning, ejection fraction of only about 20%, blood pressure in the 90s, failed thrombolysis, and presented to us 11 hours after the onset of pain. And we took him up for a rescue PCI. As expected, the LAD was gone right in the beginning. RCA was non-dominant. So you can imagine that that LAD was a very big one. That's why the very poor ejection fraction. Ballooned the vessel, some flow restored, but a lot of clot and plaque. So stented the LAD, took all precautions to prevent no reflow. However, this was the state. So at this stage, we gave him tyrofibin, we gave him everything that is there in the book for battling no reflow, and the flow was restored to some extent. This is how he left the cath lab. In the ward, in ICU, after about 2 hours, I was told he's hypotensive, he's pale, confused. There's a small hematoma in the groin, nothing much to write home about. Ultrasound done in the ward did not show anything remarkable other than a groin hematoma. However, my suspicion was very strong of a large bleed. And we did a CT. It showed a large peritoneal collection, more on the right side. And subsequently, we discovered that his platelets have dropped from a pre-operative count of 186,000 to 10,000 only. This was, of course, this report came in much later. So we took him back to the cath lab. Of course, whenever you have severe hypertension in the patient, you've done a proximal LAD, you first look at the vessels. The vessel was flowing well. Checked both the LAD and the left main. Everything was fine up there. Tried to look for a bleed locally. The sheath was still in place. My technician had not yet reached, and this table is all being maneuvered by us. Finally, the technician came, he gave me a DSA, and there it is. Can you see this bleed from the puncture site? Actually, what had happened is the patient had moved also, and there was probably a tear in that artery. It is a large bleed. And by this time, things were really bad. The patient was severely hypotensive. And when I did the puncture on the left femoral, there was no pulse palpable. He was crashing. Later on, we discovered that his hemoglobin had fallen from about 14 pre-op to 4 or 5 after the procedure. So I did a puncture on the left side, put a wire across the aortic bifurcation, and placed it in the right femoral. Took a balloon, a peripheral angioplasty balloon, 4 into 40 millimeters, and inflated it at the site of the bleed after having removed the right-sided sheath. And this is what you can do. All of us can do this. It is, but you must get the left femoral in time. So with this, the bleeding was arrested. We could make out, we could remove the hand from the groin and see that there is no more bleeding. Give us time, and now we placed a Fluency Plus covered stent, a PTFE covered stent at the site of the rent. This part I generally call the interventional radiologist for help because they are more familiar with the road map and all. Did a check shot, repeated it after about 10 minutes, no bleeding. And then we sent the patient back to the ward. He did fine. Now, what is the magnitude of this arterial injury, arterial access injury? Well, there are various trials. Fruworth have studied more than 15,000 patients and got an incidence of pseudoaneurysms in 65. All of us have seen pseudoaneurysms. Occlusion, profuse bleeding is not very common, but when it happens, it really shakes you up. An AV fistula in the odd patient. Above this is a study by Sedagat, who had studied TAVRs and found bleeding in 110 of them, a much higher incidence. That is probably because of the large French sizes used. In fact, in this surgeon study, the vascular surgery study, they have recommended that if bleeding cannot be controlled and if stent graft is feasible, use a stent graft. What are the risk factors? We generally know that calcium, a recent procedure, stenosis at the site of the puncture, They are all risk factors. Procedure-related oversized sheaths, a high puncture, a blind puncture as compared to an ultrasound-guided or a fluoro-guided puncture. Patient-related factors like diabetes, steroids, female. If the patient is confused for any reason, he will move. Hypertension. In this trial, a lot of other factors have been studied. It's a long list to read, but you can go through subsequently. How do we manage? Because generally these patients don't give you time, especially if the blood has tracked into the retroperitoneal space. If there is a groin hematoma only, you can control it with local pressure. But if local pressure fails, then one of the options is surgery, but more and more non-surgical methods are being used because of the high morbidity of surgery. As I showed, you can create a balloon tamponade at the site of perforation. You can use coils, stent grafts, vascular plugs, thrombin and thrombus injection. Thrombus injection. This I have never tried, but I've just read about it. So talking about covered stents, today we have self-expanding stents and balloon expandable. I have experience only with Viaban, which is made by Gore, and of late with Fluency, which is made by, I think, by another company, which is very user-friendly. I'll just, now this is a trial by Kufner et al., who showed that the risk of major bleeding is much more, significantly higher in above groin punctures, risk of death, and also it is more in an urgent situation than in an elective situation. So this is just to show you the way a fluent stent, a covered stent graft looks like. If you can see, it is not fully covered with the material, with the that PTFE material. It's only partially covered. But when you say 40 millimeters, we mean that the entire length, other than the tantalum markers at the end. Unfortunately, my pointer is not coming on, but you can make out there are tantalum markers. So within the tantalum markers, that is the length of the stent. You should know how much of it is covered. Less than the full length is covered. About 2 millimeters on each side is a gap. So once you use it, you can salvage many a case. I've used it in a number of cases. Over my thousands of interventions, I must have treated 5-6 cases like this. So to conclude, cover stents are a safe and effective means of addressing arterial access injuries. But of course, the best course is to prevent an arterial access injury. For that, I would recommend follow a meticulous technique, which is freely available to all of us. We've got a lot of experience. And I thank you for your attention.
Dr. Goel, Dr. Shiva Prasad, I think we can have the discussion right now.
Yeah, because the topics are all different. So, yeah, we can.
Yeah, the third speaker is not there, so I think we can have the discussion right now. Dr. Shiva Prasad, you please unmute yourself. Dr. Goel also, please unmute.
Good afternoon, Dr. Goel, sir. Back again.
Good afternoon.
Hi, everybody.
So, good presentations. So we had two of them, both difficult situations.
Excuse me,
so
sir.
I will. Yeah.
Sorry for the interrupt. Dr. Vijay is there, sir.
Dr. Vijay Bang has joined?
Yes, sir.
Oh, sorry. Dr. Vijay Bang, I think because we didn't find you, they're extremely sorry for that. So
No, sir.
I
Now
think,
only he joined, sir.
okay, by the time he's there, maybe a couple of questions by then. Yeah.
I think VSD rupture, Dr. Srinivas, post MI VSD. I believe majority, as per your talk, it seems that we are doing surgery more than device closure. I agree on it. Because I think the device closure is, I think Dr. Bang has come.
Not yet. It's ready, we can take the questions.
Yeah, you please take this question. I think by then, after that, we can.
So what is device closure? I think is more now given up. What do you say on that? Because the mortality after device closure is very high. We also did few cases initially, but the final survival is not there.
Not there.
And in surgery, my only difference of thought was waiting sometimes creates bigger problem. If the patient has a rupture and he is stable enough to be taken for surgery, go ahead and do the surgery. If you will wait or delay the surgery, then things only worsen and finally you're not able to. So what would you like to say? That's what my experience is.
Yeah, generally it is said like that. So the large operative series which I quoted also showed, but only thing is nature is selecting some cases. If the patient has survived for some time, then the risk will be less. But in the acute stage, as you said, hemodynamic and unstable, you have no choice but for sending the patients for early surgery. But in the large series also, mortality is 50%, even if the patient is taken up for immediate surgery. There is no choice. At least 50% of patients could be saved.
Correct.
If you wait longer, they will go into multi-organ failure and then die.
Because natural selection, there are some people have come to us 3 weeks post MI. So they are naturally selected. We feel they will do well. But I can tell you, they in the waiting period, because we have a lot of waiting period for surgery in our setup. In the waiting period, even those natural selectors also worsen and die. So the final end result that 80% will die is correct. You made a statement at some place, 80% will die. So that's a very bad situation.
Can we now go to Dr. Bang's talk, please? Dr. Bang, Vijay Bang.
Yeah, I'm
Good
here,
afternoon,
but
sir.
I don't see how to. I don't see a place where I can, open the video and talk.
Your share screen. Anand, can you help us from the?
In the bottom of the Zoom,
There is no share screen. That all I know, but there is no share screen
Sir,
here.
yes, sir, Anand here. Sir, are you on Zoom or have you opened up your PowerPoint?
No. How can I open up a PowerPoint? It doesn't share this screen. It doesn't say. So I cannot open the PowerPoint.
No? Sir, no, sir. What I want to know is, have you opened up your PowerPoint, sir?
Shall I open?
On the desktop, open it, sir, and then come back. Now minimize the Zoom. Open your PowerPoint.
Just wait. Now
Sure,
this
sir.
is now my the PPT is open.
Right, sir. Can you go back to the Zoom? Can you again go back to the Zoom?
Yes, I am on the Zoom. Okay.
Now you will have share button at the bottom.
I don't have. That's what I'm saying.
Sir, it must be hidden, sir. Probably move it up a bit. The whole.
I have checked everything. There is nothing there. There's a small screen there, and it's asking for sign in. I don't know. I can hear you. You can hear me, and it's saying sign in.
Sir, shall we take the next speaker, Dr. Balagopal, and I will help sir on the phone?
Yeah, please. I think we'll take one more question to.
Sir, I'll call you on the phone, sir.
Dr. Shivaprasad, are you still there, or I can't see you on the computer screen? Dr. Shivaprasad, Dr. Goyal? I think
I am there.
Dr. Shivaprasad, I think we can go to one more question. Dr. Shivaprasad, hi.
Hello.
Shivaprasad and.
Hello.
Yeah. Shivaprasad, carry on. You're not audible, Dr. Shivaprasad. I think meanwhile...
Sir, I am with Dr. Shivaprasad trying to get the presentation up on the phone.
No, Dr. Shivaprasad. Can we talk right now, or you want us to hold on? Anand?
Sir, you people carry on, sir. I am with sir on the phone.
Okay, fine. Excellent. Dr. Shivakar Srinivas Kumar, one more question to you. Basically, when you have I think mostly, as was pointed out by Dr. Goyal, it's mostly the surgical results are better. But the location of the infarct is also very important. In infra-posterior sometimes has much more problems than the anterior infarct. And if you're lucky, you get a rent somewhere in the mid portion, I think you probably can do a procedure better. So that actually also has an impact on the outcome of the kind of procedure that you would choose, whether it's a percutaneous or a surgery.
Yeah, yes, sir. That's what I've covered up in the talk. If it's a mid-muscular thing where you just get it in anterior wall MI, sometimes you can get away by device closure, if at all, if you're lucky. But inferior posterior with serpinous tracts and all that, it's very challenging. You can't do that with the device closure at all.
Actually, the majority of the holes that we have seen, I think I'll just share, it is more at the apex. The apex is ballooned and it is right at the apex, and at that place to place a device also sometimes becomes very difficult.
Yeah,
it's right at the apex.
Dr. Shivaprasad, you can. Are you able to?
Yeah, I can hear
Please go ahead.
Can you hear me? Yeah. What is the chance, Srinivas? What is the chance of getting entrapment of the tricuspid apparatus and getting the device improperly placed?
Yeah, we did. In one of the cases we did, we had a lot of struggle, and that's how we couldn't. We took a lot of time. We couldn't do it properly. So we need to take care about device wires getting entangled in the trabeculations of the valve, the tricuspid valve, and because the entire thing is forming arteriovenous loop formation. That's why in another case we wanted to try just a retrograde positioning, like what we described of late in VSD retrograde, but that was also quite challenging. It was slipping off because, as Dr. Goel mentioned, most of it is too apical. By the time you direct that sheath there and try to keep it there, it's quite challenging. So what we started evolving in between is we passed because we are coronary interventionists basically, we passed the coronary guide wires, and we always used to leave it as an anchor till the device sat there. And not only the support wire will remove later because to take the device in, but the coronary 014 wire, we left it 300 centimeters one just to avoid such slipping offs. But it did work sometime. But again, there are a lot of challenges. We need to learn more about it. And basically, the anatomy is friable there. That's the problem, not about the technique also. Because once you put a device, then it gives up because of friable nature of the tissue there. So that's why it is recommended to keep at least 4 to 8 mm bigger size defect than what you see an echo. But still, we need to have better, more softer devices. Other thing is this device gets endothelialized later. We want the shunt also to be closed immediately with clotting. So those are some of the issues I think we need to develop further. I think we need to have some discussion on this vessel rupture, sir, because of late with the tower, that has become very relevant. I am worried that time will not be sufficient.
Actually, we can. You want Dr. Bang to speak?
Yeah,
or,
let him finish it.
No, I think it is not still ready. I think maybe Dr. Kalra can take a question. Can take a question.
Can I just get into this rupture of the vessel?
Yes.
Actually, the case that Dr. Kalra presented, well, I had a few observations. One, that the leak that you showed looked very small to me. I wasn't very sure where the leak is, but the hemodynamic status that you presented was certainly bad. I'm sure maybe we could not see it.
Believe me, he must have lost 2.5 to 3 liters of blood.
So correct. I agree, but the leak was not so well visible. That's the only point I wanted.
Contained by the hematoma all around.
But I think sometimes an oblique view brings it out.
I'm sure you must have got
I have
ultrasound and the retroperitoneal bleed.
Somehow the ultrasound initially, which was done very early, missed it, but the CT pictures are revealing. And he had a massive bleed. There is no, I mean, I've never seen a bleed like this. And let me tell you.
No, by the time he came, he was already in hypotension and shock, sir. That's why.
And also, Dr. Goel, sometimes you get fooled by one view. I think maybe an oblique view will bring it out.
In fact, I had missed that small tiny leak on the normal angio that we are used to. Then the technician says, let's do a DSA. And I said, okay, then do a DSA and magnify it.
Always take an oblique view. I think it'll give you a much better delineation.
In fact, I request everyone, if you suspect a leak, really look for it. Only then you will pick it up, because it is already being tamponaded by a lot of blood all around.
Thank you, Dr. Kalra. Is Dr. Vijay Bang ready?
Sir, no, sir. We are taking him on TeamViewer and we are trying to do it, sir.
Then shall we have Dr. Raghuram's presentations before shortage of time? Can we have it, Dr. Goel?
Can we just have one? I wanted to make one comment on this.
Okay, Dr. Goel, please go ahead.
Yeah, I just wanted to say, so that is okay. Now, the other thing is, with this tower thing coming up, the incidences of these leakages have increased quite a lot. Oh, sorry. It has changed?
No, don't. Go ahead. He's just getting the slide.
This has increased quite a lot, and I'm sure some people might have witnessed a case that I used to show about 3 years back, where the entire segment of the artery was torn and came out when we were using the 24 French with the Mahi valve. This was initial days, 2016, when we just started, that time, 16 or 17. So for that, a covered stent is very important, and you really get a blast of blood coming out, And I had one more case that I witnessed. Again, there was a good amount of blood coming out. You really see it well enough. So that's why I made that comment. It was seen very faint.
One more point, if I may make, or 2 more points. One is, be careful of tirofiban. It can cause severe thrombocytopenia. Second, the incidence of bleeding is much less if you have used any kind of closure device, any kind which is suitable for your case.
But
In fact,
I think mostly it's a high puncture which is responsible. Is it more of a
I think it
technical
is
problem?
largely
In
it is
this
a
case, it was not a
mechanical
high
thing.
puncture.
Yeah, it's a more of a technical problem and a puncture
It is
problem
more.
which,
It is
yeah,
largely a mechanical
the
thing.
problem. Yeah,
The
I agree.
devices that are going in and the size of the artery, you have to be very careful to size the artery, the minimum between in the iliacs and the femoral, and then only put the device that you are
In
using.
our case, it
Thank
was
you,
not
thank you,
obvious.
thank you, Dr.
Well,
Goel. I
your
think
case
for
was coronary work, so that was very small. So I just wondered,
Yeah.
why did the leak happen?
I'm sorry. I'm sorry. We have to go to the next stage. I mean,
Yeah, okay, we
wonderful
can go to
discussion, Dr. Bhagirath. I think if you are ready, we can go ahead and then have Dr. Bang's presentation if it's ready by then.
Can you see my slides?
Not yet. It
Sir,
came back.
share your screen again, sir.
Share your screen, please. I think you
Okay.
had shown it earlier.
Okay, I'll.
Yeah, it's fine.
Yeah, fine.
Please go ahead.
You can see it now?
Yes, yes. Please go ahead.
Okay. Good afternoon, everybody. Thanks to Dr. Mohanan for this wonderful opportunity.
Now it is there. Now it is there. But there is some pulmonary. No, I am not ready. Intervention in pulmonary embolism is done. Hello, I am Dr. Bang here. Can I share the screen?
I'll stop and come back later. No problem. Is that okay? Or shall I continue?
I think you can continue. Dr. Bang can do the at the end. Is that okay? I don't know. Let the organizers decide.
Dr. Shiv, you are not audible.
Dr. Bhagirath, please go ahead.
Shall I go ahead? Okay, thanks.
Yeah, please.
Good afternoon, everybody. Thanks to Dr. Mohanan for this great opportunity to present at the CSI, respected chairpersons, speakers, and friends. I'm here to speak about the interventions in a very important topic, pulmonary embolism. First off, let me introduce you to a few interventions in acute pulmonary embolism. Here, what's important is we need to classify how severe the pulmonary embolism is. So you have the pyramid of pulmonary embolism that was published by Dudzinski et al. In Circ Cardiovascular Interventions in 2017. In summary, you classify acute pulmonary embolism into high-risk pulmonary embolism, intermediate risk pulmonary embolism, intermediate low-risk pulmonary embolism, and low-risk pulmonary embolism. Suffice to say that the target population that we are looking for is the high-risk pulmonary embolism. Now, how do you identify this target? One, they will usually have a systolic blood pressure of less than 90 millimeters of mercury. They are usually cardiac arrest survivors. The troponins as well as the BNP will be elevated. Most importantly, you will find RV dysfunction on echo. The moment you see this in a patient who's very sick with dropping saturations, this is your patient whom you need to identify for an intervention in pulmonary embolism. Now, oftentimes we use lytics in patients, but high-risk pulmonary embolism, acute pulmonary embolism patients give you a very narrow window in which you can make any difference. More importantly, the perfusion in such patients is very low because of cardiogenic shock. So your window time to actually get your act together is very minimal. So you have to act quickly to salvage the life of this patient. We have various scores for assessing acute pulmonary embolism. This is for the patients who are not very sick, because if they are very sick, obviously you will have to take that decision immediately and go ahead. Way back, we had the Miller score that was published in 1971, which characterized the number of segments. Total number of segments were 34, and the score on 34 determined how soon you needed to act. But now we have very refined scores that are available. These are CT-based scores. We have the Canadley score as well as the Mastora score. The Canadley score, maximum obstruction index on CT was top value of 40. And the Mastora score, the top value is 155. So based on these scores, the interventional radiologist in your team can help you to assess how severe the pulmonary embolism is. I've given you a snapshot of what are the various devices that are available for management of acute pulmonary embolism. Starting up, you can even have in those institutes where you don't have these devices, you can just put in a catheter and use tenecteplase for lysis. But where there is access to devices, this is the snapshot of the various devices. you have suction-based device, you have hydrolytic jet-based device, you have ultrasound-based device. So the Echosonic is the one that I've highlighted in this particular slide, and this is FDA approved, and this is the one that is most popularly used and has the best safety result. The video animation that I've shown in the top end of the slide is the angiojet device. So basically, it hydrolyzes the clot and it aspirates it out. Now, let me move to interventions, which is the important topic of today, that is balloon pulmonary angioplasty in CTEPH. Mine is a case-based discussion. So let me present to you two cases and then go up to the discussion next. So my first case is a 52-year-old gentleman, history of severe breathlessness, which was progressive since the last 1 year. He couldn't even walk 10 steps, not a known diabetic, hypertensive. He was being treated all along as a case of bronchial asthma, non-smoker, no alcohol consumption. Chest X-ray shows enlarged dilated pulmonary arteries. Hematological workup was negative for any parameters of increased coagulation. Venous Doppler, no clot in both the legs. This is the cath report that I furnished here. He qualifies for severe PAH. I've highlighted the PA pressure and the pulmonary vascular resistance. The saturation was 93, and when he walked, the saturation dropped down to 71. And after walking 10 steps, he had to be on oxygen. In fact, the family brought him on a wheelchair with a portable oxygen cylinder. This is the pulmonary angio of this patient. This shows level 3, level 4 pulmonary artery obstruction. This is the panel on the left pulmonary artery. This is the panel on the right. This shows middle pulmonary artery total occlusion. You'll see that in a minute. This is the middle zone obstruction. As a protocol, we look for collaterals. This is the Lima-Rima, and then you can see there is a collateral from Lima. Some surgeons don't want it, some want it because it can be ligated during surgery to prevent post-op hemoptysis. Team decision was balloon pulmonary angioplasty. This is a panel showing dilation of the the right upper lobe pulmonary artery. The balloon that I've used here is a cross-pander balloon, 2x20. You can see the dilatation. Oops, I lost the screen. So can you see now? Yes. Yeah. Visible. So the same patient also had an occlusion of the middle low pulmonary artery, and then this is I used a Fielder XT guide wire to cross the lesion, changed it with a soft guide wire, and then a coronary balloon, initially 210 balloon followed by a dilatation. You can see the middle pulmonary artery lobe, the artery slowly getting visualized, and upgraded the balloon seriously to a 210 crosspander followed by a 420 crosspander balloon, and you can see the entire middle lobe pulmonary artery opens up. Next is a second case, 47-year-old gentleman, history of severe breathlessness on exertion, progressive. He was an African, so he was again being treated for bronchial asthma in Africa, not a known diabetic, hypertensive, no non-smoker, no alcohol. Chest X-ray shows the dilated right atrial chambers, right atrium. Hematological workup as well as venous Doppler were negative. He had severe PAH on the CAT study. PVR was 14 Wood units. Saturation was 92. Again, required oxygen support. This is the pulmonary artery angiogram that you're seeing. Right pulmonary artery shows again the middle lobe obstruction. Left side shows level 3 and level 4 distal artery disease. We do a coronary artery workup as well because we are going to do a thoracotomy anyway. If there's any coronary artery disease that can be fixed at the same time. This is a Lima-Rima cannulation to look for collaterals. You can see, you just saw that there was a collateral from the Rima. We also have the CT pulmonary angio that I have furnished here in the spin images, and I'll come to that in a little bit. So the team decision again was balloon pulmonary angioplasty. This is the middle lobe artery, again crossed with this time I could get through a BPAM wire, which is a soft wire, and then used serial balloon dilatations. You can see that 220, and then the entire artery opens up. This is a web that you're seeing in the right upper panel. And then you can see that in the right side panel, I used a 210 balloon to break and crack the web. And then you can see that the entire middle lobe artery again opens up. So this changed dramatically the fortunes of this gentleman. He was off oxygen and could do his day-to-day activities. So let me briefly discuss the topic of interest today, that is balloon pulmonary angioplasty. If you see a patient of CTEPH, let me first tell you that we are the largest center in the country to do pulmonary endarterectomy surgery. So only the leftovers come to me wherein the surgeon feels that these are inoperable. So this is the flow chart that we follow. Suffice to say that level 3 and level 4 arteries where the surgeon is not really confident of reaching this despite using long forceps, that's what comes to me for balloon pulmonary angioplasty. So at the outset, disclaimer, the definite choice for balloon for CTEPH is surgery, class 1 level of evidence C as per the ESC guidelines. And mine is balloon pulmonary angioplasty, class 2B level of evidence C. That is the patients who are not operable for various reasons. So I put in here an unusual slide, definition of CTEPH. Why? Because we have to have a 3-month timeline. Many times I have acute pulmonary embolism patients refer to me for an intervention, balloon pulmonary angioplasty. To qualify to be called CTEPH, it is 3 months. There should be a mean arterial pressure more than 25. They should have normal pulmonary wedge pressure, and there should be segmental perfusion defects like a VQ scan or a lung scintigraphy showing perfusion defects, or a multi-detector computed CT showing defects, or a pulmonary angio showing defects. So the indications are inoperable CTEPH due to various comorbidities or advanced age, peripheral lesion, symptomatic patient, class 3 or 4, multi-organ failure, or allergy to iodine. Surprisingly, I had one patient with iodine allergy. Those who give voluntarily consent. So sometimes patients tell me, look, doctor, I don't want surgery. Can you do something else? So if a patient knows the benefits and gives us the consent, then we can do that as well. All patients theoretically who have lesions, if they give us informed consent, we can take them. And in central pulmonary arteries, not recommended, but yes, if the patient gives an informed consent, we can go take them as well. The basic workup is you look at echo, VQ scan, right heart cath, PA-gram, hemodynamics, and also look at comorbidities. A surgeon must be there in the team to make your decision. This is the echo, RARV dilatation with severe PAH. This is a RV function assessment. We have a complex algorithm. We have the echo team that's in full swing that will assess the RV. Why is it important? Because this determines the survival of the patient. The RV function is the one major determinant of the patient's survival. This is the VQ scan, the panel on the left showing ventilation, the right perfusion, and then we match up both and get a VQ scan, and then we map it up here. And this is our team's result, which shows how many segments are involved, how severe the obstruction is, and how soon we need to act. This is the CT pulmonary angiogram. We have both a 2 planar image as well as a 3D rotational image. This is to see the various bronchopulmonary segments and see how exactly to target this. Next is a 3D reconstruction. This is also extremely useful because we get a 3D view. We can see how exactly to approach the various lesions, which are the bronchopulmonary segments, and how many of them you need to target when you intervene. MR pulmonary angio, again, for that, whatever the CT may have missed out, you get a reinforcement here. And the good thing is you also get, you can correspond that with the MR perfusion scan, and this will help us completely to understand the dynamics of this patient. Of course, a cath study is done. We need the pulmonary artery pressure and the vascular resistance, because in surgery, especially coming off bypass, these are major determining factors. And of course, in the panels below, I've shown a pulmonary angio, which I've already dealt with. An important toy that is now available, a tool, is the MR flow assessment. This has just come into our department. And this helps to see how exactly the flow is and where is the turbulence in the right ventricular outflow tract and pulmonary arteries. So this helps us to understand, number one, which are the segments we need to target, and number two, what is the success of the procedure after doing a balloon pulmonary angioplasty. This is a snapshot of the bronchopulmonary segments. Very important to understand the anatomy, because you need to know what to target, what to touch, and what to leave. This knowledge comes from here. This is a cartoon showing how exactly the balloon pulmonary angioplasty is done. CTEPH lesion classification, you have various ways in which you can classify. The cone beam computed CT. Important is we use a fan beam, but cone beam says There is the classification is webs and slits and narrowing. There is also an OCT classification, which is septal type, the multi-hole with thin wall, multi-hole with thick wall, and a monohole type. This is the 3D assessment. So it is a reconstruction. We have the software available. This actually shows you how, as if you are traveling into the pulmonary artery, and you can see where the webs are and where the slits are. This is the angioscopy. We don't have an angioscopy, but for those who have it, again, can be classified into mesh, slit, flap, and mask-like thrombus. And this is the panel showing IVUS as well as the angioscopy. The panel on the right shows a beautiful web that you can see here. And this is how a web looks. I've been to the OT and confirmed that this is how it is. And this has to be dissected and cracked when you're doing a balloon pulmonary angioplasty. Of course, the PA angiography is this is what we are all familiar with. The first type is the localized ring type, easiest to tackle. Next is a web, which is a slit, hazy, or abrupt narrowing opacity of the vessel. Next is a longitudinal defect. These are difficult to deal with because you need serial dilatations. The type B, subtype 2 is a complex mesh. Again, difficult to deal with, and chance of perf and complications are very high. Abrupt narrowing, tricky lesion because balloon sizing becomes very difficult. The proximal part is a bigger balloon. The lower one is smaller. Which size balloon? When these are difficult questions. Subtotal, you're seeing a whiff of contrast, difficult to deal with, better to keep away from these lesions, at least in the beginning of the program. A pouch lesion or a chronic total occlusion, very, very tricky lesion. The chance of perforation is very high in such lesions. And of course, lastly, the tortuous lesions. These are better left alone and better left for the surgeon or medical management because the chance of complications are very high. Now, why did I even mention such a big complex classification? That is because if you have the total occlusions and if you have tortuous lesions, I have furnished two studies which say that the complication rates are very, very high. Success rate is about 50 to 60% in the best of centers, and the complication rates are almost half. That means half of them will have a tear or a rupture and chance of patient dying on the table. Interestingly, 6% is the complication rate for total occlusion. That's because almost all of them were abandoned early. How to approach, which lesion you look at. Look at the ones with the porous perfusion, prefer the right side, prefer inferior lobe, and choose anatomically favorable lesion. In summary, you have to choose a right lung over the left because of ease of approach. Inferior lobe is always easier than superior and middle lobes, and choose webs or bands because the success rate is close to 100%, whereas tortuous lesions is just 50%. This is the principle: pass in a wire, tear the vessel inside, you have to crack the web, the intima grows again, re-endothelialized, and then this is the success. So you're basically, what you're doing in balloon pulmonary angioplasty is dissection of the webs and you're compressing the thrombus. This is how it is done. This is the hardware that we use: long femoral sheath, guiding sheath, B-palm wire, cross-pander balloon. Most important is gelatin sponge particles in case you have perforated. This is how it is done: right femoral vein axis, serial balloon dilatation. Do not do more than 5 to 6 lesions in one day. Never exceed 6 because the chance of reperfusion pulmonary edema is very high. When to stop? If you have an angiographically good diameter, nearly the size of the target vessel, you have a grade 3 angiographic flow, there is good dilatation on IVUS or OCT, and the distal to proximal pressure in the target lesion is more than 0.8. So ideally, we choose to stop in about an hour's time, never exceed more than 2,000 million gallon years of X-ray exposure, 60-minute fluoro time, and 300 ml of contrast. Complications, to start with, it can be grotesque and disastrous. You can have tears, you can have perforations, and quickly the patient can decompensate. Vascular dissection, allergic reaction, and also local anesthesia problems. You can have renal dysfunction, access site issues. Important nightmare is reperfusion pulmonary edema if you overdo it. So there is a good Pepsi score that has been enumerated by Inami et al. In JAC 2013, who said that there are ways to avoid it by calculating the PVR and change in angiographic flow. This is a snapshot of what you can see. Always remember, angiographically, these don't look so bad. In a CT scan, it's a 3-dimensional view and can be a nightmare. This is our experience: 18 cases, 105 lesions. We've had a fair degree of success. You can see mean PA artery pressure is down. SPOT has dramatically improved. 6-minute walk test has improved, and all of them have improved in functional class. My last slide: rotational angiography using Dyna CT. This is what we hope that we will get this. because there will be minimum usage of contrast. We also have a Singo Eye Pilot software, which is excellent for giving you a 3D roadmap. Once you just acquire one image and then you're done. Lastly, the pressure wire from St. Jude Medical, you can maneuver it by twisting the rotor in the hand, and also you can measure the pressure difference between proximal and distal, and this will help you to quantify the success of your procedure. Thanks, everybody. This is me signing off with what is level 1, 2, 3, 4. This is our specimens from the pulmonary endarterectomy surgery. Thank you, everybody.
Dr. Bang, we are eager to hear you.
Yeah, absolutely.
Can you just go ahead?
Shall I share my screen?
Please.
Oh my God, what has happened? Entirely everything is gone. Hello, can you hear me?
Yes, sir. Yes, sir. Yes, sir.
But I don't have the share the screen. I don't have. I know the taskbar is down below. I'm in a cursor. I'm moving it on the bottom, but I don't see share the screen here. There's nothing there. Can somebody get me the share the screen?
Can someone help him? I think you said it was ready earlier.
Yeah, earlier it was ready. Moment he disconnected, I got also disconnected.
Sorry for that. I think we're just working on that. By then, a quick question, Dr. Goyal, Dr. Shiva Prasad, would you like to address a question to Dr. Bhagirath by the time he's ready?
Yeah, Bhagirath, I think that was a very good presentation.
Thank you, sir.
I just had a few questions.
Yes, sir.
What about acute embolism? You told me about, you told us about CT, chronic.
So this hydrolyzer is one equipment that is manufactured in Chandigarh. Surprising, the cost is just 55,000, but it's a single use. We have contacted the company and we are in the process of acquiring it. Now,
so you can use it, you can do it through angiojet type of a system.
We can use angiojet, sir, but only thing is in massive pulmonary embolism, it's always a challenge. So right now we are doing catheter-based lysis. We use tenecteplase for such patients as well. And surprisingly, even though contrary to literature, we've had a fair share of good result. We also use ECMO for such patients to support them till their bailout time.
And any vessel which is totally occluded, how do you lead your wire?
Yes, sir.
If it's a total occlusion,
so
because
we've had this challenge couple of times. So what I do is I use JR right, Judkins right. The catheters that are recommended for tackling these total occlusions are a Judkins right or a left Amplatz catheter or a multi-purpose catheter. Somehow I feel that the JR right is the most comfortable. After I use an 8 French JR, and in that we use a smaller multi-purpose catheter. I use a Teramo wire to cross the lesion. Invariably, we are able to cross it with a Teramo wire and slowly thread the multi-purpose wire, which is a longer one, 160 centimeter. We get the multi-purpose, put it through that. And through that, I give tenecteplase, and I've had very good results in this total occlusion, but only in acute cases, sir. Chronic cases, straight goes for surgery. As I told you, it's always a team decision.
Yeah,
we have excellent endarterectomy surgeons that are available.
Dr. Bang, are you ready? We are running short of time. You're muted, Dr. Bang.
Sir, just a minute, sir. We are getting ready his presentation.
Okay. Yeah, just
unmute. Dr. Bang has to unmute himself first.
Dr. Bang, please unmute. Your presentation is getting ready. Dr. Shiva Prasad, any comment you wanted to make?
Yeah. Unmuted.
Your audio is not clear, Dr. Shiva Prasad.
How often do you intervene in acute pulmonary embolism?
That is, we go by this pyramid that I showed you, Dudzinski et al. So if you have high-risk pulmonary embolism patients, we have to intervene because many times a patient come in with a cardiac arrest. They come
Shall I
in.
use share screen?
The first thing is, as per protocol, we put them on ECMO. We first put them on ECMO and then look at whatever needs to be done.
Dr. Bang, you are there. I think you go on to the slideshow, please. Dr. Bang. Yeah,
can
great.
you see me my slides?
Yes, clear.
You can see my slides and you can see me.
Yeah, please go ahead.
And you can hear me?
Yes, please go ahead.
Okay. So good afternoon, Chairman and the faculty members. Hello to everybody. And good afternoon, ladies and gentlemen. This is a very dire emergency called free wall rupture. This can occur in RV free wall, it can occur in LV free wall. In both the places, it is known to occur. And you will be surprised to note that in as early as 1647, William Harvey, made the first diagnosis of free wall rupture, followed by Mogagni presented 11 cases in 1769. And then, of course, so many reporting has been done on this particular topic. And finally, there was a patch closure and the suture closure and sutureless closure. And all those techniques have come in to repair the broken heart or mend the broken heart. Incidence is 2%. I'm unable to move my slides. Can somebody escape and then try again? I'm not able to escape.
Arrow down.
Sir, lower left side of your screen, there will be an arrow, sir. First slide, you need to click that arrow. After that, it will move with the cursor.
Which side of the screen?
Left lower.
I don't see any arrow here.
You're not able to move the
Try
screen.
arrow down on the keyboard.
Tell him to click by down arrow.
Keyboard arrow down.
Arrow down, I'm pressing that arrow down or arrow up, nothing is moving.
So first slide, you need to click that arrow which comes on the left lower part of your screen. Only then the arrow down will work.
But I don't have any arrow here.
So best is to use the down key on the keypad.
I'm using on the keypad down one, but that's not moving at all. My slides are stuck.
Forward arrow.
Sir, click on down arrow button, sir.
Click on?
Down arrow button, sir.
I'm clicking on down arrow button.
So stop and restart, sir.
Stop
screen share and restart. It will come.
But
sir, click. Just move your cursor and click on the person.
So okay, now restart.
Again, share screen.
Share screen. Okay, it's here.
Desktop, sir.
Yeah.
Now start again.
Go to slideshow. Go to slideshow.
Don't do that. Go to the slideshow button at the bottom.
Okay.
At the bottom, sir.
There is no
PowerPoint slideshow button.
You have a box at the bottom. You have 4 boxes.
I don't have any box here.
Sir, on the PowerPoint.
So we are seeing it, sir.
We are seeing it, Dr. Bang, Vijay.
So right lower, sir.
PowerPoint.
Kindly accept the request, sir.
I can see here.
Right lower.
So which one you said?
Right lower. The last one. I mean,
the last one before that scale, sir.
Now my slides are approved.
No, sir, you're still on. Sir, if not, all you got to do is go up.
I'm able to change my slides.
Yeah, no, sir, it's not happening for us.
It's not happening for you.
Yes, sir. Can you go back to on the top, you have something called slideshow.
On the top, slideshow.
Near animations.
See, I have some animations here, but there is no slideshow written here.
On the left-hand side, you go up.
On the
Anand sir, he has to click.
Dr. Vijay.
Anand sir, you have to click on the resume slideshow. That's why it's not working. Resume slideshow.
Resume slideshow. See, there it is showing you resume slideshow.
But I don't have resume slideshow here.
So it's in a small box on the left-hand side near the slide sorter.
Please go to the left-hand side of the screen, sir.
I went to left-hand side of the screen.
On top side, there is a resume slideshow. Just click on it. You'll be back into the.
I don't have resume slideshow. Can you see?
Press escape.
We are seeing it, sir.
But I don't see it here.
Okay, so press escape.
So left side, you're seeing the slides, all the slides, one below the other.
Yeah, I can see all the slides, one below the other.
Okay. So just to the right of it on the top, you have a red box. It's written resume slideshow. You just click that, sir.
I don't have that option, resume slideshow. I'm trying to see that. I know that we have done so many times the Zoom meetings, but never faced a problem so many times.
Dinesh, you want to share sir's thing and
There is
No, I'll take a remote control. He's not permitting me.
I have now I found the resume slideshow.
Click on it, sir. Click on it, sir.
Clicked on it. Okay, can you see my slides?
we can, sir.
Yes.
You can see.
That's okay. You can even run it on the shorter view, sir. That's not an issue.
Okay, but we can use the longer view, no? We can do that.
Yes.
Okay.
Come on, the slides have come.
Okay, so can you see my slides now?
Yes, sir. Yes, sir.
Okay. Okay. And now the commonest cause of pre-wall rupture, either RV or the LV, is acute myocardial infarction. And other causes could be there, that is blunt trauma, penetrating trauma, cardiac surgery, particularly MVR and AVR surgery, and cardiac tumor and infection per se can cause pre-wall rupture. The pathophysiology is very clear. When there is a transmural MI, it is followed by expansion and thinning of the infarcted wall until the elastic strength of the free wall is exceeded by the forces generated of the left ventricular systole. So there are three types of the ruptures which can occur, which is first is the acute one, which is a blowout type. It's a very dire emergency and patient can be saved only if patient is in the hospital, otherwise patient will die either of the cardiac arrest or cardiac tamponade. Then subacute rupture is a oozing type where we have a small oozing and which gives you time to tap the do a pericardiocentesis, tap the pericardial effusion and even consider surgery. In that there is a small clot with adhesion developed along the free wall and the pericardium. Then there is a chronic left ventricular wall rupture is present as a pseudoaneurysm. We know the difference between pseudoaneurysm and true aneurysm. True aneurysm is an aneurysm where all three walls are intact and neck is wide. And pseudoaneurysm is a narrow neck, but all three walls of the myocardium we can't see. We can see either the epicardial wall and that's all. So again, this classification by Baker and Manting is said the same thing. The acute is type 1, subacute is type 2, and type 3 is pseudoaneurysm. Now, most of these patients present with severe hemodynamic instability and shock state. They can present in cardiac arrest also due to electromechanical dissociation or ventricular fibrillation. And the pseudoaneurysm may present with congestive heart failure. There could be predisposing causes like hypertension, age more than 70, female gender, and the diabetes. These are very common predisposing factor in a patient who's going to have a free wall rupture. Diagnosis is usually by 2D echocardiography or pericardiocentesis or contrast ventriculography, CT and MRI. CMR is said to be the best method, that is MRI is the best method to diagnose the free wall rupture. Now clinical presentation, as I said, there is sudden death, hemopericardium, tamponade and death, or incomplete or subacute rupture where we have a time to think of doing a surgical closure. Even in acute, we can have a time to do an acute closure because it occurs at the 3rd or 5th day of the acute myocardial infarction, or it can occur as late as at 2nd or 3rd week of the myocardial infarction. So in both these types, if first type, patient may be in the hospital. If he develops sudden hemodynamic instability, we have to suspect the possibility of free wall rupture and consider the treatment option of giving a hemodynamic support, inotropic support, hemodynamic support either by ECMO, IABP, or even Impella can be considered. If the cardiac arrest is there, of course, we have a CPR and advanced support. And ESCH guideline also says that use the support, which is very good, the circulatory support, mechanical circulatory support, ECMO, IABP, or then sutures can be either sutureless surgery or suture surgery. And various material that are used are Teflon, Gore-Tex, Dacron, pericardium, collagen sponges, and biological glues are also available, so that sutureless closing of the can be done. Now there are three ways of sutureless closing. One is a linear closure. Second is a closure with a defect with a patch, and patch covering the technique. So these are the various ways that surgeon can use this one of these technique. And sutureless technique is possible only when there is no oozing. Blood is not oozing. Obviously, if the blood is oozing, the glue will not stick there. Glue will not stick the patch. So in those patients where there is no oozing, and it's possible to close with sutureless technique. Now, post-operative, once the patient is operated successfully, post-operatively, most important thing to manage is control BP, control heart rate, maintain inotropic and IVP support, and manage and prevent infection if there is any chance. The early mortality with even surgical repair is 17.1% to 34%. Increase in percutaneous mechanical circulatory support cases, suggesting that the complicated LVPR cases might benefit from this approach. Now, there is series of 140 patients evaluated during the period of 18 years, 2001 to 2018 in 15 different centers. The mean age was 70 years. Oozing type of was observed almost in 56.4% and blowout in 43.64%. And suture repair was used in almost 61% cases. The overall operative mortality is also very high, 36%, and preoperative LVEF, cardiac arrest, ECMO support were independent predictors for early mortality. No significant difference was observed with respect to surgical sutureless or suture technique in terms of myocardial rupture success rate. Use of mechanical circulatory support was not associated with lowering mortality. Myocardial re-rupture can occur in a patient who are already treated successfully. And 7.1% can have a re-rupture. No beneficial effect of the short-term outcome. And thank you very much for your kind attention. So it's a very dire emergency where patient can be saved, provided we are very aware of what should be done, or aware of free ventricular wall rupture, either RV or LV rupture, depending on the type of acute myocardial infarction we have. Whether it's the anterior wall, it can give rise to LV free wall rupture. If it is inferior wall, it can give to the RV free wall rupture. And both these cases, and of course, pacemaker is these days a very common cause. Pacemaker wire per se can cause a free wall rupture. So it's all known to cause all these things. Any questions? I will be very more than happy to answer them.
I think I'll request the chair to just restrict to one question because we are really running short of time. And thank you, Dr. Bang, and then sorry for the inconvenience caused. The chairperson's one final question, please, and we could wind up the session.
Can I actually, do you have any idea on or any reports on non-surgical closure of rupture? You see, firstly, rupture will make the patient die. But if he is saved because it becomes a contained rupture,
you mean the conservative
can we do it non-surgically intervention?
So you either conservative management or device closure of the, you mean device closure of
device
the
closure. Any reports that we know of?
At least there is, except for the septum, there is no device closure report that I could see in the literature. I tried to search for it. I don't see any device closure report in free wall rupture.
Actually, when there is a contained free wall rupture, I think you can, if the patient becomes contained and it's basically becomes a pseudoaneurysm, and then you can do it with coils or I think there are reports of a ASD type device being put there or something.
Yeah, I think Dr. Srinivas, once BC Srinivas presented not really a free wall rupture during a PTMC. He had a LA rupture and then used an ASG amplatzer to seal it off. Remarkably well. So
but not in infarct setting.
Yeah. It's a totally different scenario. Thank you so much, sir. Really appreciate
Here, most of the patients are infarct related. That's why device closure is very difficult to do it.
Thank you, sir. Thank you once again. Thank all the chairpersons for the wonderful discussion. Dr. Bhagirath and Dr. Kalra and Dr. Srinivas Kumar for the excellent presentation. Thank you all. I think we have no time left. We have to go to the next session. Thank you.
Thank you.
Hello, Ravi.
Hello, hi.
Jayaprakash.
Hi, Jayagopal here. Yeah, hi.
Jayagopal. Hi.
I
Hi,
think
Anil.
yes, nice
Hi.
to see you.
Joy, how are you?
Good, good. Joy, long time no see. Yeah. So
until Corona do us part.
yeah, let's hope everything will come to back to normalcy again. Dr. Anil Saxena, pleasure to see you.
Yeah, hi.
Hi.
Good afternoon.
Good afternoon. What about our friends at Kochi studio?
Hi.
Mahi studio, Dr. Aparna, nice to see you.
Dr. Aparna is there, yes.
I think we.
In one, sir, sorry to interrupt, sir. In 1 minute, Dr. Sethi will join, sir.
What about the Mahi studio? Are they taking over or Cochin studio? Can you just? They're there actually.
So Dr. Sathe is there, and my co-chairs.
Yes.
Yeah, Dr. Sathe and Dr. Reddy. So maybe I can introduce the first speaker, and then second speaker can be introduced by Dr. Reddy, and third by Dr. Sathe. Is that okay?
Aparna, how are you?
I'm absolutely fine, sir. I'm absolutely fine. Thank you so much. How are you doing, sir?
Good.
Very nice.
Today being
CSI?
CSI meeting, I thought I'll take the day off and attend it fully rather than being in the hospital. You can never attend
That is good.
really in the hospital.
And I'm written now. Okay, fine. So I have to press here.
Good evening, sir.
Here
Good
or
afternoon, everyone from Kochi studio. We'll be going on to the chronicles of atrial fibrillation. We invite the chairpersons, Dr. Anil Saxena, Dr. Vijay Chandra Reddy, Dr. Shirish Pisate, and the experts, Dr. Aparna Jaiswal, Dr. Santosh Kumar Dora, and Dr. Joy Thomas. We request the chairpersons to please initiate the proceedings. We hope to have an interesting discussion on AF.
Yeah, good afternoon, friends. It's indeed a pleasure to welcome you all to this session on atrial fibrillation. And I welcome my co-chairs, Dr. Reddy and Dr. Sathe, and I also welcome our expert panelists, Dr. Santosh Dora, Dr. Aparna Jaiswal, and Dr. Joy Thomas. So we have a very eminent panel of speakers, and without wasting much time, I would request the first speaker, Dr. K.K. Sethi, to deliver his talk. He'll speak on what drives recurrent atrial fibrillation in patients. Dr. Sethi, please.
Can you hear me, Anil?
Yes, sir. Yes, sir.
Yes, sir, we can hear you.
You
can share your screen.
Yes, thank you. That should be okay, I think. Thank you very much. Yes, can you see me? Can you see?
Yes.
Yes, sir.
Yes.
One more.
Please go on, sir. And on behalf of everyone, we congratulate you on your lifetime achievement award, sir.
Thank you so
That's
much.
a wonderful achievement.
I appreciate your feelings. Thank you. Now we are going to talk about what drives recurrent atrial fibrillation. And as you all know, atrial fibrillation is a disease of aging, and also it's a recurrent disease. Now, once we talk of recurrence, it implies that the patient has been in sinus rhythm for some point in time, and recurrence can happen after spontaneous conversion to sinus rhythm, after pharmacologic conversion, electrical conversion, or after catheter ablation. Now, we all know what are the risk factors for occurrence of atrial fibrillation. Most importantly is the age, but other comorbidities like hypertension, obesity, sleep apnea, heart failure, coronary disease, valve disease, cardiomyopathy, hyperthyroidism, and diabetes have all been implicated. And singly or in combination, they produce electrical or structural remodeling of the atria. Now, there is not too much of data in the literature to tell as to how often recurrence of atrial fibrillation actually takes place in the population. One of the first studies came from Dr. Carlo Paponi in 2008, And there he looked at 106 patients. They had their first documented episode of atrial fibrillation. 54 out of these were lone AF and 52 were with comorbidities. Follow-up was done with the help of electrocardiograms as and when patient came for follow-up or at the time of symptoms. 48 hours Holter was done at 1, 3 and 6 months and then yearly thereafter. And 5-year follow-up study showed that out of the 106, there was no recurrence at all in 50 patients after the first episode of a paroxysmal AF. And 61% of these 50 in whom there was no recurrence were lone fibrillators. AF became persistent in 24 out of 45 and permanent in 16. So here is the graphic representation of the same thing. As you can see here, overall, almost 50% of the patients do not have a recurrence after the first episode on a 5-year follow-up, but lone fibrillators are less likely to have a recurrence. Similarly here, the lone fibrillators, much less incidence of persistent atrial fibrillation as compared to those who are with comorbidities. And in this particular study, age, diabetes, and heart failure predicted progression of atrial fibrillation. More recently, there is a very interesting study, again, although it's a small study of about 30 patients, where they looked at recurrence of atrial fibrillation after first clinical episode, and this was a prospective evaluation by implanted loop recorders. 30 patients and follow-up of 3 years, the mean CHA2DS2-VASc score was 2.83. 7 out of these 30 were on antiarrhythmic drugs. And 3 patients, which is 10%, had no recurrence. 13% had only 1 episode of recurrence. 46% had low recurrence rate, which was defined as less than 5 episodes per year. And majority of these recurrences, which is 63%, the maximum duration of atrial fibrillation was less than 24 hours. Now, this is data from the SPAF1 and SPAF2 studies, which was published in early 90s, at the time when the treatment with aspirin or oral anticoagulants or placebo was being compared. And the atrial fibrillation was called intermittent atrial fibrillation at that time. This is a follow-up of about 341 patients, mean follow-up of 26 months. And again, patients were serially followed with the help of surface electrocardiograms only, 8 plus and minus 5 ECGs per patient. And then they saw that there were patients who remained in sinus rhythm all the time whenever ECGs were taken, 173 out of the 341, and 168 patients showed atrial fibrillation, which is group B, and a combination of sinus plus AF was seen in 127 out of these 168, which means they continued as paroxysmal AFs, and 41 had persistent or permanent atrial fibrillation. The predictors of recurrence in this SPAF study was age, previous infarction, and presence of heart failure. And on the echocardiogram, a left atrial size of more than 6 centimeters, moderate to severe left ventricular dysfunction was also predicted. Subsequently, there is a lot of data available on echo and Doppler prediction of recurrent atrial fibrillation. And one of the important things to remember is that once we do cardioversion, no matter by what method, the highest incidence of recurrence is in the first 30 days. Now, this study is with 100 patients within 4 weeks following cardioversion. Serial echo, left atrial size, and Doppler mitral peak A wave velocities were done at days 1, 2, 3, and 28 after cardioversion. 23.9% of the patients had a recurrence if AF duration before cardioversion was less than 6 weeks, and almost half of them had a recurrence if AF duration was more than 6 weeks. So that becomes an important cutoff point. And also those who had peak E wave velocity of less than 52 centimeters per second on day 1 after cardioversion, the odds ratio for recurrence became 5.0. Another study which looked at internal cardioversion in recurrence in long-standing atrial fibrillation. Again, about 100 patients, and the duration of atrial fibrillation here was 52 months on an average. These are the comorbidities. The cardioversion was successful, 93%, 82% of the patients were kept on amiodarone, and early recurrence within the first week occurred in 13%, but the median time to recurrence was 21 days. Now, at 1 year of follow-up, only half the patients remained in sinus rhythm, and predictors of recurrence on multivariate analysis again were the left atrial diameter of 44 millimeters, and again the mitral A wave velocity of less than 51.9 millimeters per second. Then we had some electrophysiologic data as well, and this is electrophysiologic predictors of recurrence of AF within 30 days of cardioversion. And you notice here again 38 patients, small study, but it was a very elaborate study. The time course of recurrence, you can see almost 45% of the patients had their recurrence within the first 30 days after the cardioversion was performed. Now, these authors have actually looked at electrophysiologic data in terms of measurement of ERPs at different sites in the right atrium between 10 minutes after cardioversion and 1 hour after cardioversion. 2 readings have been taken. And you notice here that those who had recurrence of atrial fibrillation, the change in ERP, actually there was an increase in the ERP of the lateral right atrium much more often as compared to those who remained in sinus rhythm, both at a drive cycle length of 400 as well as at 550 milliseconds. And they also looked at the signal averaged P wave duration. And those patients who had signal average P duration less than 135 milliseconds had a very less chance of recurrence compared to those who had a P duration more than 135, again suggesting that slow conduction in the atria, reverse remodeling, and presence of APCs actually predicted recurrence. Prolonged signal average P wave duration has also been studied in these 6 studies that I have listed here, and it has been shown to be associated in patients with AF versus controls, AF induced by pacing, AF after open heart surgery, AF with acute MI, AF with CHF, and conversion from paroxysmal to persistent AF. So this gives very significant information as far as chances of recurrence in a patient are concerned. Now the question that has been asked is what actually drives atrial fibrillation? Well, there is a mechanical remodeling of the atria and an electrical remodeling. And mechanical remodeling means we have left atrial enlargement, stretch, oxidative stress, fibrosis, hypertrophy, apoptosis, etc., etc. Electrical remodeling mainly means there's a shortening of action potential duration with homogeneous refractory periods, slow conduction, and APCs with short coupling intervals that generally start the atrial fibrillation. Initially, atrial fibrillation is a disease of triggers, which is the APC with short coupling intervals and a vulnerable atrial substrate. But as progression takes place, the disease progresses from a trigger-driven to a persistent and more substrate-driven arrhythmia. Then we have an entity called subclinical atrial fibrillation, and I've just picked up a small little data, silent or subclinical atrial fibrillation, and most of this has actually been studied in patients who have had devices implanted. This is data from the ASSERT study, which came a few years ago, and these patients did not have atrial fibrillation when pacemakers or devices were implanted, and this follow-up starts 30 days after the device implant. It was seen that almost 13% of the patients had already had an atrial high rate episode within the first 3 months after the device was implanted, and the risk of clinical atrial tachyarrhythmia was significantly higher in those in whom subclinical atrial tachyarrhythmia was present than in which subclinical atrial tachyarrhythmia was absent. And this study also suggested that those who had subclinical atrial tachyarrhythmias have a higher chance of developing stroke or systemic embolism as compared to those who did not have subclinical atrial arrhythmia. However, the same authors then subsequently conducted another study published a couple of years ago in which they looked at subclinical AF more than 5 minutes in older patients. See, they assert 256 patients, they were all in sinus rhythm. And then subcutaneous ECG monitors were implanted like the ILRs. This is the St. Jude device. CHADS VESPA more than 2 in all. They had to have either OSA or BMI more than 30, along with a left atrial size of more than 4.4 centimeters or an anti-pro BNP of more than 290. And then you notice here that there was a significant chance of detecting subclinical AF in patients who had no devices, who were in sinus rhythm, but had this size of left atrium. And different durations of subclinical AF are shown here. more than 5 minutes in duration, quite significant, more than 30 minutes, some had more than 6 hours, and even more than 24 hours. But when you look at patients who had previous stroke in this population vis-a-vis those who did not have a previous stroke, there was no significant difference in terms of incidence of subclinical atrial fibrillation. So it is concluded that the clinical significance of subclinical AF at best at this time is unclear and more data is being worked out. Now, we also have AF recurrence after catheter ablation, and the chances of recurrence, as you all know very well, are 30 to 40% after pulmonary vein ablation within 6 months to 1 year, and it depends upon the type of atrial fibrillation. Most of the time, it is because of pulmonary venous reconnection or other regions of atrial remodeling outside the pulmonary veins. Late recurrence is also possible, say after about 36 months, and there is some data on that, and that is primarily because of progressive atrial fibrosis and non-pulmonary venous triggers. So, ladies and gentlemen, in summary and conclusion, I would say that aging and other cardiovascular risk factors result in electrical and structural remodeling of atria, perpetuating recurrent atrial fibrillation. Initially a trigger-based disease, atrial fibrillation may evolve into a substrate-based arrhythmia later on. Recurrence of atrial fibrillation can be silent or symptomatic or both. In fact, silent recurrences are very, very common, almost half of them. And cardiovascular risk factors facilitating atrial remodeling should be aggressively addressed to prevent atrial fibrillation or atrial fibrillation recurrences, because it has certainly been shown in some patients, especially after ablation, that if you take care of their obesity, their sleep apnea and other comorbidities, take care of the left ventricular hypertrophy if they are hypertensive, then certainly the chances of recurrences can be reduced. So thank you very much for your kind attention, and I would like to stop here.
Thank you, Dr. Sethi. It's a wonderful presentation. Dr. Y.V.C. Reddy here. I think Dr. Natarajan is going to talk on the AF burden. Does it really matter? I think we can have discussion at the end of the 3 talks.
Are you able to see my slides?
Yes, Natarajan, yeah.
Okay. So let us now, in the next 10 minutes or so, answer the question, atrial fibrillation burden, does it really matter? So AF can be classified into clinical AF, and as Professor Sethi in his previous talk said, can also be classified as subclinical or asymptomatic atrial fibrillation when the episodes are not very clear. The patient may not be aware of it. We may be taking ECGs and the AF may never be documented, so on and so forth. So we can classify it into subclinical or asymptomatic atrial fibrillation. If you look at this, clinical atrial fibrillation can be detected by 12-lead ECG, and symptoms may be apparent in the patient. And what is the clinical significance of clinical atrial fibrillation? Symptom management is important. Anticoagulation, of course, is essential if risk factors are present, for example, a very high CHADS2 VASC score. To the contrary, if you look at subclinical or asymptomatic atrial fibrillation, they are often subclinical, as the term itself tells. It can be an incidental finding on implantable or wearable devices. It can be an incidental finding during monitoring for some other cause. It can be detecting during the evaluation of embolic stroke of unknown source. So it can be a chance finding. High false positive rates for device detected AF. When I say device detected AF, if somebody has a dual chamber pacemaker or a dual chamber implantable defibrillator, these devices record what is called high atrial rate episodes. Atrial high rate episodes, AHRE in short. So they can be sometimes false positive. They have uncertain impact on clinical status. The burden is not very clear. The duration is not very clear. Concomitant risk factors are not very clear. And the most important thing is there a need for anticoagulation is a very important pertinent question that we need to answer when we are dealing with subclinical atrial fibrillation. So we will focus our entire discussion in the next few minutes on this particular entity of subclinical or asymptomatic atrial fibrillation, particularly with regards to its burden. And to answer the question, if the burden is high, do they become candidates for anticoagulation, like patients with symptomatic, evident, apparent atrial fibrillation? We will go through the following headings: the current guidelines, what is the definition for AF burden, how to assess AF burden, what is the significance between AF burden and the risk of stroke, what is the importance of atrial high rate episodes. I will concentrate a few minutes extra on this term AHRE, otherwise called atrial high rate episodes, which are recorded on dual chamber devices like pacemakers and defibrillators. That comes under the category of subclinical atrial fibrillation. A lot of us during our device follow-up see that atrial high rate episodes are recorded by our devices. And of course, a few words on future perspective. If you look at the way we treat atrial fibrillation, the minute we know a patient is having non-valvular atrial fibrillation, you immediately go into the CHARTS-2 score to decide whether the patient needs anticoagulation or not. So it's clearly a binary question. Does the patient have atrial fibrillation? Yes or no. It's a binary question, and that binary question has its own limitations. So now we will define what is called AF burden. Quantitatively, AF burden can be defined by longest duration, the number of AF episodes, and the proportion of time an individual is in atrial fibrillation during a continuous ECG monitor or a device, expressed as a percentage. So that is what is called burden of atrial fibrillation. I again re-emphasize that this is not for clinical atrial fibrillation. This is for hidden atrial fibrillation, where the diagnosis is not very certain. How to assess this AF burden? We can do it by Holter monitoring. We can do it by prolonged continuous ECG monitoring for 14 days, 30 days. All of us are aware of prolonged ECG monitoring in today's time. External loop recorders, which are symptom-driven loop recorders. Of course, implantable cardiac loop recorders, where you implant a device like a chip under the skin and it records the rhythm over a period of, let's say, 2 years. So episodes of AF can be picked up by these implantable loop recorders. And the most important thing is, when you implant a cardiac device like a permanent dual chamber pacemaker or a dual chamber ICD or a CRT device, these devices record what is called atrial high rate episodes, AHRE in short. And that will be the focus of the later part of my discussion. And of course, not to forget smartphones like Apple Watch, for instance, and other gadgets of day-to-day use. They also have their sensors which can pick up atrial rhythm abnormalities. This is the Holter monitoring, the prolonged ECG monitoring, which is much more simpler in today's time, all of us are aware of. This is the external loop recorder, which is triggered by the patient when he has a symptom, which has its limitations because it is patient-driven. These are some of the ECG records of atrial fibrillation in some of these continuous ECG monitoring devices. And when you come to implantable monitoring devices, we have made a significant progress right from 1990. From 1990, if you look at the evolution of implantable defibrillators, we have come a long way. In 2014, that is 6 years back, we have something what is called an injectable implantable defibrillator done in the outpatient clinic by making a small nick. You can inject a device under the skin. It has become so small. That is called a Reveal Link by Medtronic. That was introduced in 2014. So these are some of the implantable devices. These detect atrial fibrillation based mainly on the irregularities of the RR interval on far field electrocardiogram. They're implanted under the skin. So it picks up far field activity. And that's how it picks up irregular RR intervals. And it is supposed to correlate well with external Holter monitoring. And this is how these devices are done by local anesthesia, by just plunging the device inside. And that is how the X-ray looks like. And these are some of the recordings made by these implantable implantable devices under the skin. This is how you get during follow-up. And also not to forget that dual chamber devices like pacemakers and ICD, they give you the unique opportunity to look at the atrial rhythm, which are recorded by what is called high atrial rate episodes, AHRE in short. These are some of the electrograms that you see during follow-up. This is from a dual chamber ICD. This is the atrial rhythm that you see on top. This is the ventricular rhythm that you see below. You can see the chaotic atrial fibrillation going on in the atrial chamber and an irregular RR interval, which is very typical of an atrial fibrillation. This is how a device like a dual chamber ICD or a pacemaker stores the information. You also have data on the AF burden. If you look at this, these are all the AF burden that you see here. On the y-axis, you see the number of hours a patient was in AF in February 2016, for instance, 2017, for instance. So all these histograms give you an idea about the AF burden that is going on. And smartphones also have this ability in today's time. The evidence for correlation between AF burden recorded on prolonged external ECG monitoring and the risk of stroke was addressed by this study called the KP Rhythm Study, which was done on about 2,000 adult patients with paroxysmal AF who were members of Kaizen Permanent Healthcare Delivery System catering to a large population in Northern and Southern California. The mean AF burden was 4.4% in this particular study. This is not by implantable devices, it is by an external monitoring system. The they found that an AF burden of 11.4% or higher was associated with more than threefold increase in the risk of stroke or thromboembolic event after adjusting for either CHADS-VASc score or other scoring systems independent of known stroke risk factors. So this study was an elegant study with prolonged external monitoring. If you have a AF burden of 11% or more, the risk of stroke is much higher, as was shown in this particular trial. And these patients were, and the association was stronger in those patients who were not on anticoagulation. And this was the device used in this particular trial. And this they classified into various tertiles. Tertile 1 with less AF, tertile 2 with more AF that you can see here. Time in AF was maximum in the tertile 3, and the tertile 3 had the highest stroke risk in this particular trial. You can see an exponential increase in the risk of stroke as the AF burden increases in this particular trial. Coming to permanent pacemakers and defibrillators, I've already told you about the high atrial rate episodes, subclinical atrial fibrillation. This is some of the device which shows you the burden of atrial fibrillation in hours, in days, when these patients come for follow-up. And studies have shown correlation between these device-monitored rhythms and stroke or embolism. 30 to 70% patients have some degree of atrial high rate episodes. Very short episodes are clinically irrelevant. Longer episodes, longer than 6 minutes, increases the risk of clinical AF, ischemic stroke, etc. Absolute risk of stroke with AHRE is of course less than clinical atrial fibrillation. In one of the trials called the ASSERT trial, which looked at about 2,000 odd patients, it's clear that patients who have a higher duration of atrial fibrillation, this curve is for those patients who had more than 24 hours of atrial fibrillation or high rate atrial episodes shown on dual chamber pacemakers or dual chamber ICDs have the highest incidence of thromboembolic events. So I have 1 more minute. This is just to show that various trials have shown this, that higher incidence of atrial high rate episodes have higher incidence of stroke. There is a lot of the AHRE is not a static thing. As you see over a period of time, what starts as 5 minutes can actually become more than 24 hours. So it's worth following up of these patients to look for progression in the duration of atrial fibrillation by these devices. As you can see here, more the time, more is the duration. There is a lot of interplay between the CHADS-VASc score and the duration of atrial fibrillation. If somebody has more than 24 hours of atrial fibrillation, and even if they have a CHADS score of 2, they have an high incidence of stroke, as you can see here. Even with the CHADS-VASc score, if they have a high rate episode of more than 24 hours, they have a high incidence of stroke. This is just to tell you that there is a lot of interplay between the duration of atrial fibrillation and the CHADS-2-VASc score. I'll conclude by saying the following points. With improvements in wearable and implantable monitoring systems, improved detection of subclinical AF is a reality. I'm done. In patients without overt clinical atrial fibrillation, the threshold of AF burden that warrants anticoagulation is not very clear. Prolonged durations in some clinical AF, particularly with a high risk score, appear to be an independent risk marker for stroke. So we started with the question, does AF burden matter in patients with subclinical atrial fibrillation? The answer is, there is emerging data to believe that it does matter. Arriving at the threshold of subclinical AF burden that merits anticoagulation is a work in progress. Thank you very much for your kind attention.
Thank you. Thank you, Dr. Natarajan. I think we move on to the next talk. And it's a very interesting talk, really. It's on anticoagulation in patients without A, but with high CHAD score by Dr. Lawrence J. Shiralspeech.
Hope my slides are visible.
Yes, sir. Yes, sir.
Good afternoon, all. I think It's a very interesting topic to talk on. Anticoagulation in patients without AF, but with a high chat score. So we know we have a chat score for a period of time. Chat score started with the chats, congestive heart failure, hypertension, age, diabetes, stroke, and TAA. This is how we were doing chat scoring earlier. We were categorizing according into low, intermediate, and high risk. The problem with this scoring risk pattern was some of the risk factors were not recognized and stroke risk was underestimated. Age was not a binary risk factor in this scoring system, and a lot of patients in this scoring system were scored as intermediate risk. So then came the CHADWAS score with the introduction of two age groups, age more than 75 years and age 65 to 74 with two risk factor numbering, and a category of female has been added. So this reliably identifies patient risk. Only a small portion of the patients with this stroke system were categorized as intermediate risk. It simplified the way you select the anticoagulation. So this also introduced a lot of new risk factors like myocardial infarction, chronic stable coronary artery disease, and peripheral vascular disease into stroke prevention or stroke predicting algorithms. So we know a lot about patients with AF and the scoring systems. So we know also that a lot of risk factors what we see for stroke prediction in atrial fibrillation on their own have a higher incidence of stroke. So what we are going to look at now for next few minutes is, does this scoring system has any effect on patients who does not have a baseline atrial fibrillation also? This was assessed by ARIC study. They looked at the relation of CHADWAS score, thrombotic and embolic stroke in patients without a atrial fibrillation. It are around 12,000 population, close to 988 explored earlier because of stroke and AF, and around 10,000 patients were followed up, and out of that 760 developed atrial fibrillation, so they were excluded. They had around 9,900 participants ultimately who have been followed up. 9,600 were without any stroke and 280 were with stroke. Out of that, 146 were thrombotic strokes, 57 were embolics, and 77 were unclassified. So the baseline characteristics were reasonably matching within these groups. And if you look at the incidence of stroke among these groups were reasonably matching. When they looked at CHADWAS score, you can clearly see here there was a significant relation between the CHADWAS score and embolic stroke particularly. If you look at three forms of stroke, compared with ischemic and thrombotic stroke, embolic stroke had a significant relation between CHADWAS. If you look at according to the CHADWAS score and year of follow-up in patients with stroke, there was a significant correlation when the patient had a higher CHADWAS scores. So if you look at absolute ischemic stroke risk, looking at CHADWAS scores during a follow-up period of 1 year, 5 years, and 10 years follow, when you account for a risk of death, then there was nearly a straight line risk according to your CHADWAS score. So what we understood by this study was CHADWAS score may be used to assess the risk of stroke, including both thrombotic and embolic subtypes in community dwelling people. It was just looking at the community in patients without atrial fibrillation also. The mechanism by which this CHADWAS scores risk factors contribute to pathogenesis of thromboembolism without AF is not clearly known, but we know very well that these are the risk factors. Whatever the risk factors we look at in patients with atrial fibrillation for a stroke, they are anyway high risk factors for any patient without atrial fibrillation also. By looking at the CHADWAS score, it can give a subgroup of patients whom you may be able to identify for a high risk of stroke irrespective of an AF status. This may be the reason why the patient has a atrial fibrillation, you follow a rhythm control, rate control strategy, still patients have a higher incidence of stroke if the patient's CHADWAS score is high. You have selected a rhythm control strategy for atrial fibrillation, but still if a patient's CHADWAS score is 4, and if you are not putting the patient on anticoagulation, thinking that you have controlled atrial fibrillation, you will ultimately end up in a stroke because contribution of other risk factors for stroke. So like Narajan sir already told that the patients who had a subclinical atrial fibrillation, which were directed by pacemakers and defibrillators, irrespective of your CHADVAS score, you don't have a straight line correlation between risk of stroke and duration of atrial fibrillation, or you don't know exactly how you are going to look at what you pick up in a device for an atrial fibrillation. So there are some studies which have shown that patients with the supraventricular tachycardias also had associated with stroke. There's a possibility that the patients who had stroke with supraventricular tachycardias who had a CHADVAS score, the reason why they had a stroke is not a supraventricular tachycardia on its own, but the presence of a high CHADVAS score. We know very well that ECG-defined left atrial abnormalities and left atrial enlargement on their own have been shown to increase incidence of stroke, irrespective of you have an atrial fibrillation or not. So if you look at the COMPASS study, I will just go to the COMPASS study's stroke risk arm only. We know COMPASS study was mainly on cardiovascular risk factors. So if you look at ischemic stroke area of how COMPASS study looked at, you look at overall stroke in an overall COMPASS population. When the patient was already on antiplatelets and when they only on NOVAC, or when the combination of an aspirin and NOVAC, there is a significant drop in stroke risk in the patients who have been included in the COMPASS study. It's a very interesting point. You see the patients who are on antiplatelets, when they have added dual pathway inhibition with rivaroxaban, NOVAC, they had a decreased incidence of stroke. So they have a significant drop in both ischemic and hemorrhagic stroke. Both were statistically significant. The selected predictor of stroke, previous MI, and there are some racial differences existed, but also age, hypertension, and diabetes, which are all part of CHADVAS scoring system, were predictors of stroke. So if you look at overall COMPASS study and stroke prevention or prediction, the patients who have a CHADVAS score definitely, when they added both aspirin and rivaroxaban, did well. This obviously shows patients who have a highest CHADVAS score on their own have a higher risk of stroke. The reason why rivaroxaban was able to do better in reducing stroke was these are all another risk factors which are already prevalent in these patients, although they don't have an AF. Because we have caused a dual pathway inhibition with combination of an antiplatelet with a NOVAC, we're able to reduce incidence of stroke in this group of population. You look at, according to the CHADVAS score, how this combination fared. Definitely the higher the CHADVAS score, the better was the result. So rivaroxaban plus aspirin, if you look at CHADVAS score, as the CHADVAS score increases, the benefit of this combination was better. So to summarize, the CHADVAS score is a simple and reliable method to cardiovascular risk stratification to select to patients for definitive management, including your anticoagulation. Present evidence suggests that there is definitely an increased incidence of bleeding when you add NOVAC to antiplatelets in patients who have a high risk of stroke. But still, the benefit provided by this combination may be much better. So CHADVAS scores and CHAD score may be used in patients with chronic coronary artery disease and peripheral artery disease. The subgroup of patients you can identify whom the CHADVAS score is high, you can consider going for a dual pathway inhibition rather than going only with the antiplatelets. So definitely, to looking at all these together, CHADVAS score on its own has definite predictive value in identifying patients with higher risk of stroke. I think if these patients have being targeted, then we can achieve a significant reduction in the stroke risk. Thank you for a wonderful hearing. Thank you.
Thank you, Dr. Lawrence. I think that was an excellent presentation. So we can now have some discussion. And may I begin by asking Dr. Lawrence, so what do you suggest in these patients high CHADVAS? Obviously, we cannot put everybody on anticoagulation. So obviously, they should be subjected to intensive monitoring to detect asymptomatic atrial fibrillation. And what do you think is the ideal way to monitor these patients?
See, right now, with the data available, what I would suggest is this CHADVAS score can give us a option to look at the need for an anticoagulation. Particularly now, we are getting more and more data in patients with ischemic heart disease patients who may be benefited by addition of a NOVAC, low-dose rivaroxaban. So we can identify a group of ischemic heart disease patients with a high CHA2DS score, then we can consider going for a dual pathway inhibition rather than going for a patients with a low CHA2DS score and ischemic heart disease. This may give a good idea. There are a group of patients with a recurrent stroke. We know our neurology friends a lot of time come to us with the patients with recurrent stroke. We look at a lot of monitoring. We would have done 2 weeks, 3 weeks of loop recording. In spite of that, you may not be able to pick up any atrial fibrillation episode. But still, these group of patients, if they have a high CHA2DS score, I think you can consider putting them on anticoagulation. I think looking at all these data, it gives us some confidence in starting anticoagulation in these group of patients.
But that applies only to coronary disease patients and also low dose anticoagulation. We are talking of anticoagulation, full dose anticoagulation for the prevention of stroke in all patients who have high CHA2DS, because that applies to a very narrow population. CD patient. And as you know, in the COMPASS trial, although COMPASS is supposed to be for cardiac, for the coronary disease, but the positivity of the COMPASS trial was because of contribution of stroke reduction. It was not because of reduction in the MI. That was non-significant.
Yeah, that's the reason it's more useful for us, because we are talking about stroke here. So the COMPASS study has clearly shown that dual pathway inhibition in patients with CHA2DS, high CHA2DS score will be useful once.
Yeah, it needs to be studied.
Dr.
Stifel, do you have, Dr. Stifel has joined us. We can ask him, what is his opinion about this aspect?
Thank you very much. It's a great pleasure to be here with you. Unfortunately, I was only able to see half of Dr. Lauren's presentation. But as you know, I have also been involved in the COMPASS trial. And we have looked at this effect, especially the effect of the net clinical benefit, because we're always weighing these two things, right? The severe ischemic events and then the bleeding events. But we should really weigh the severest type of bleeding events. And in our analysis of the net clinical outcome, it's exactly like you all discussed. The ones with the highest vascular risk, cardiovascular risk, those are the ones that benefit most from this. Absolutely. And, you know, and like Dr. Anil was mentioning, you know, one of the primary drivers of this is the reduction in stroke and the reduction in cardiovascular death. That was also significant, right, from the primary endpoint. So we don't really know, to be honest with you, what the exact mechanism is. If this is really subclinical atrial fibrillation, we don't know. It was about 100 or so patients who during the COMPASS trial developed clinical atrial fibrillation. The rest just remained asymptomatic. So we don't know. It works. It's 27,000 patients, so it works, but we still need to figure out why exactly. But we certainly know that in the highest risk patients, it seems to work best.
Can I ask a question, Dr. Anil? Can I ask a question?
Yeah, hi.
Dr. Natarajan here. Can I ask a question? Hello?
Yes, go ahead.
Yes, please.
This is to Dr. Steffel. If somebody has had a stroke and he is a hypertensive, he is a diabetic, he has age more than 75, so he has a very high CHA2DS score, already 4 plus. All his electrocardiograms recorded or sinus rhythm. He has never been known to have a clinically evident atrial fibrillation. So I think a trial did address by randomizing these patients to implantable loop recorder versus no recorder and straight away starting them on anticoagulation. What is your comment on that particular strategy? Very high CHA2DS score in a patient who has already had a stroke without atrial fibrillation documented. What would be the current approach based on guidelines?
I think that's a very good question, and we are still trying to figure out what the best strategy is. The Crystal AF trial has randomized these types of patients, cryptogenic stroke patients, towards loop recorder versus standard of care. But the endpoint of the Crystal AF trial ultimately was detection of atrial fibrillation. It wasn't stroke. Right, so this was a stroke and anticoagulation were secondary endpoints, and they were also in favor of the loop recorder, but the trial was not powered for that. On the other hand, we have to say that usually these patients, if they're not fully anticoagulated, they will receive aspirin. And so we can extrapolate a bit from the trials that we have, especially the Averroes trial, which was the only trial that randomized a NOAC, apixaban, against aspirin. And it didn't really find an increase, especially in the severe bleeding events. So for all practical purposes, what I usually do is I do insert a loop recorder, but I start treating with a NOAC at the same time. So as to provide the optimal type of protection for the patient, but still look. And then really, if after 2 years, the patient has not had any atrial fibrillation on his loop recorder, then it becomes a more difficult decision. But a majority of these patients will have atrial fibrillation, and then I will only expose that patient to an off-label NOAC treatment for a certain period of time until I have the diagnosis fixed.
But the way you're treating them with NOAC while you're putting them on implantable loop recorder itself is currently an off-label indication, if I am right, isn't it?
Well, the NOAC is an off-label indication in that situation because we don't have atrial fibrillation, right? And if you take a look at the new ESC guidelines, the CC to ABC, right? The first C stands for confirm AFib. If you want to treat them, and we don't have AFib confirmed. That's why formally it is an off-label situation if you put them on NOAC straight away. We tried that in the past, right? And if you take a look at the Navigate trial, for example, with apixaban or, with rivaroxaban, or the Respect ESIS trial with the Bigatran, randomizing these patients to either NOAC or independent of atrial fibrillation, to randomize them into NOAC versus standard of care did not provide a benefit for the overall study population, right? These trials were negative in the sense, neutral in the sense that they didn't help. So I think it still makes sense to look for atrial fibrillation, but I do feel that while we do so, it is reasonable, especially those high-risk patients that you just mentioned, to monitor them better and to treat them and to protect them in a good way. And there, I think we have good evidence that with, for apixaban, we know it from the Averroes trial, that we do not expose these patients to a significant increased risk for severe bleedings, but we protect them much better for stroke. So that's why I'm trying to sneak through in a way there for my patients.
Do you give full dose NOAC in that?
Yes.
I would like to.
5 mg twice daily of apixaban or 2.5, half-hearted dose?
5 full dose.
No, it has to be 5 milligram. So I would like to involve our expert panel at this stage, and I would request Dr. Aparna Jaswal to see if she has any comment or any question to any of the speakers.
So I think that was wonderful lectures by all. My only thing to Dr. Natarajan would be that I think he gave a very nice lecture. Today in 2020, while we are awaiting more data, what are you going to do with the AHRE when you see on a device and you have known that it is not false and you've checked it with a Holter? Now the patient has AF. What is your threshold for beginning NOAC? Number of hours that you would want to see coupled with the CHA2DS2-VASc score. How will you take it forward?
To answer your question, higher the duration of AHRE and higher the CHA2DS2-VASc score, higher is the risk of stroke, and that merits anticoagulation. In a very blunt way, I'm saying that. Now coming to specifics, what should be the duration, etc. One thing, as you very correctly said, is you're supposed to confirm it and make sure it is indeed atrial fibrillation. A lot of these can be false alarms. So if you have a corroborative Holter and that also shows atrial fibrillation, things become very easy for us. Currently, as Professor Sethi also said in his talk, more than 24 hours seems to be the real cutoff, which you can probably reduce it by the earlier discussion we had with Dr. Steffel to 12 hours or so, provided the number of CHA2DS2 risk factors become more. Let's say somebody has a CHA2DS2 risk factor of 4. Maybe you don't have to wait for 24 hours. Maybe 12 hours will be a reasonable time to say. I don't know what Professor Sethi will add to this particular discussion.
I don't have the answer to this question really, because we don't have sufficient information to stratify them, in a binary way or, in a graduated way. And also the interesting thing is that a direct correlation between the actual episodes of atrial fibrillation on devices and the timing of occurrence of stroke is not there. When stroke happens, patients are not necessarily in atrial fibrillation at that time. So one of the other things that I was thinking was that this low dose rivaroxaban, might be preventing thrombotic events rather than cardioembolic events, because 2.5 milligram dose is really a small dose. And whenever in the past for ACS patients, we have used a higher dose of the NOAC coupled with aspirin or clopidogrel, the incidence of bleeding has really been very, very high. So that's my contention. I don't know whether I am correct, but this is what I can, get out of this, because standard way of saying that stroke prevention dose is full dose rivaroxaban, 20 milligrams or 10 milligrams of apixaban or 300 milligrams of dabigatran per day.
Correct. What do you do, Aparna, in your practice? I'm sure you'll be as confused as all of us are in terms of AHRE, correct?
Absolutely. So I think, as you rightly said, if they're true episodes, I think the threshold has been for 24 hours coupled with high CHA2DS2-VASc, and that's where the data is taking us. But as we will have more data emerging, it's on its way. Maybe at lesser threshold of hours, we would like to initiate NOAC, given the safety of these molecules, as we are more and more convinced about.
To add a point to this lack of temporal association between the device recorded atrial arrhythmia and the stroke, which was well alluded by Professor Sethi, I would say that the AF may not be temporally associated, but a couple of days later, the patient may be in sinus rhythm. That is the time the patient may throw a embolus, which is well known, stunning, etc., post-atrial fibrillation. But as he correctly said, there is very clearly a dichotomy between what is recorded and the timing of stroke. They have not actually matched. There is no temporal association, as very correctly pointed out by Sir.
And if I may add,
paradoxically, there is a temporal association when you cardiovert atrial fibrillation. And we all know it has been there in the literature that when you cardiovert atrial fibrillation and we don't anticoagulate, historically, it has been associated with a 2% incidence of stroke at that time, within 2-3 days.
Yes,
here's a very interesting aspect, if I may add, because what Dr. Sethi said and Dr. Natarajan as well, it's not only temporally not correlated, there's also a question how much of it is causally related, because atrial fibrillation may as well also be a marker of a more diseased individuum, right? And very interestingly, also to your point, Dr. Anil, that there was a very interesting sub-analysis the other day, I think a year ago or so, on cardioversion in one of the larger, in the active trials. And what they found out that if you correct the events that happen for stroke, for the baseline characteristics of the patients that were cardioverted versus those that are not cardioverted, the cardioversion itself is no longer a significant risk factor for stroke. So this is something that we have been teaching for ages, but we are not entirely sure if it's really true, or if that incidence of stroke that is increased after cardioversion might just reflect the baseline stroke risk in these patients who are at a higher risk who are just sicker, and which as a result of that require cardioversion. It's very interesting, and there's still a lot to learn in that regard.
Thank you. And now I turn to Dr. Santosh Dora. Dr. Santosh Dora, do you have any comment or any question to any of the panelists, any of the speakers? Is Dr. Santosh there?
Doesn't seem to be.
If not, Dr. Joy Thomas. Dr. Joy, do you have any comment or question to any of the speakers?
This is regarding the case scenario that Dr. Natarajan mentioned. A 77-year-old hypertensive diabetic who develops a stroke. I don't think I will break my head over whether he has atrial fibrillation or not. The very fact that he's had a stroke at 77 mandates anticoagulation, and I'll go ahead with that. Of course, if we find that he has atrial fibrillation, that is an added information we have, and that is mainly for primary prevention. When somebody, you find an AF, he has not had a stroke at all, and whether to anticoagulate that. So it is there that the identification of atrial fibrillation is important. But in the case scenario in question, I think anticoagulation clearly has a role there.
Maybe the discussion will vary if the patient is younger. Maybe a 50-year-old man with a diabetes, hypertension having a stroke, maybe have a second thought.
Certainly. Because that anybody more than 75, you add 2 score, whereas less than 65 is only 1. So that's how the weightage is given to each.
Dr. Sathe, any question to any of the speakers or Dr.
Yeah,
Stifel?
I mean, is it fair to say today that CHAT-SWAG score is inadequate, and we should definitely add, somehow we should add AF burden to that and AF type to it? Because it is obviously also dependent on those two factors. So what we do in everyday practice is probably just based on CHAT-SWAG and it is inadequate.
Yeah, when it was introduced, we also felt that maybe some echocardiographic parameters could have also been included, like the presence of spontaneous contrast or the size of LA appendage or size of left atrium as such. So it is definitely inadequate. I think some parameters can certainly be included.
Comment? Anil?
Yes, sir. Yes, sir.
Yes. You see, we've been having this discussion on anticoagulating elderly people who have had a stroke without atrial fibrillation. Now, do we have data that for secondary prophylaxis of stroke, anticoagulation is more effective vis-a-vis single or dual antiplatelet therapy? Because if you see the guidelines on stroke, they don't even recommend dual antiplatelet therapy. They recommend only single antiplatelet.
Yes.
Single, yes.
So for cryptogenic stroke, probably now it's a practical choice to start anticoagulation and put an implant a loop recorder, which will record for 2 or 3 years. And by that time, one would be sure that patient has or does not have atrial fibrillation. And then one can discontinue anticoagulant, especially in those patients who don't have much bleeding risk.
See, even there
So
have
it's a very practical, it's an off-label but very practical choice.
studies with the biotronic devices of implantable recorders where intermittent anticoagulation has been used. You know, when patients have atrial fibrillation, they had a signal coming to the investigator, okay, this has happened, and patients are put on anticoagulation for a period of 1 month, 2 months, or 3 months. And then when the patient, after that, the anticoagulation was discontinued. And this strategy also did not work.
Yeah.
Mayo Clinic did an artificial intelligence based machine learning, and they picked up sinus rhythm ECG patients. You just feed the data of sinus rhythm ECG on thousands of patients. They found that they can identify those who would be having atrial fibrillation, which matched that of implantable loop recorders.
Thank you. I think we had a very good session and discussion. So we move on to the next presentation by Dr. Stifel. Dr. Stifel is a longtime friend of all of us, and we all know him so well. He'll be speaking on stroke prophylaxis in high-risk patients with atrial fibrillation. Dr. Stifel, please.
Well, thank you very much, Dr. Anil. It's always a great pleasure to see everyone like this and to be discussing these very important and interesting subjects with you. And I cannot tell you how much I'm looking forward to being back in your beautiful country and to seeing you all back face to face. I have the topic today, I have the task I was asked to talk about, as you said, stroke prevention in high-risk patients with atrial fibrillation. This is the company's disclosure. This is supported by Pfizer. These are my personal disclosures. And whenever we talk about stroke risk prevention in high-risk patients, I think it is very important to realize where we come from, because we frequently feel that we don't have the evidence available for these high-risk patients. We need to be aware this was the evidence base that we have had for warfarin for stroke prevention and atrial fibrillation until the NOACs came. There were 6 trials that compared warfarin to placebo. This is where the 2/3 risk reduction comes from that we tell our students, our residents, and our patients. What we frequently forget to say is that it was based on not even 3,000 participants, and actually only half of them received warfarin, the other half received placebo. So the evidence base overall for warfarin was very, very slim. Yet it is a very good drug, and until the NOACs came, it was the only drug that led to a reduction in mortality in patients with atrial fibrillation. And then along came the NOACs. And again, I realize this has been for over 11 years since we've had the first trial published, and we've come to take these results for granted by now. but they're everything but for granted. Keep in mind, when before the RELY trial came out with the dabigatran back in 2009, I don't think any one of us would have anticipated that overall NOACs are not only as efficacious as warfarin, they're actually more efficacious. If you take a look at this in this meta-analysis, you can see that there's an additional 19% increase in efficacy for stroke and systemic embolism prevention. This was statistically homogeneous, though you can make an argument that 150 milligrams of dabigatran is pretty far on the effective side here. And then the flip side was just as important and just as surprising, because usually when we reduce these bad events, usually we buy it at an increased risk of bleeding, and that was not the case. None of the NOACs had at least no statistically significant increased risk of bleeding. We did see some heterogeneity though here amongst the trials. We saw a similar risk of bleeding for high dose of dabigatran and for rivaroxaban, and we saw an even reduced risk for apixaban and edoxaban compared to vitamin K antagonists. Now, of course, it's always difficult to cross-compare these amongst the trials. We need to be very careful with that. But this is how these trials came out, and the trials included from 14 to 21,000 patients each. So it is a huge evidence base that we are basing these decisions on. Importantly, we always want to know, how does this translate into our daily clinical practice? And there are millions of patients that have been included in, sometimes I feel, what is like millions of real world observational studies. There's a lot of them out there. I'm showing one from the Mayo Clinic, which was independent, which is not industry sponsored, where they took a look at various patients, a lot of patients from claims databases, and perform propensity score matching. Now, the one thing that's important, of course, even if you match for as many as the factors that were included in this analysis here, you always have to realize that there is a risk of residual confounding here. This is not the same as a randomized clinical trial. This is why we can talk about associations when we see this, but not about causality. We cannot infer causality from an observational study like this. The important thing is, does this come out similar to what we have seen in the trials? Well, let's see then how it came out for dabigatran. For dabigatran, you can see that there was a similar incidence for stroke and systemic embolism compared to warfarin, each over 14,000 patients, similar incidence of ischemic stroke, and a trend towards less hemorrhagic stroke. There was less major bleeding, there was clearly less intracranial hemorrhage, and there was no difference in gastrointestinal bleeding. So in essence, what this shows is a very similar result as compared to the low dose regimen arm of the RELY trial, the 110 milligrams of RELY. If you take a look at the event rates with rivaroxaban, you see similar incidence of stroke and systemic embolism, similar incidence of ischemic stroke, a trend towards fewer hemorrhagic strokes, similar incidence of major bleeding, clearly less intracranial hemorrhage, and more GI bleeding. Overall, very consistent with what we have seen in the ROCKET-AF trial. And then finally, for apixaban, we see less stroke and systemic embolism, similar incidence of ischemic stroke, less hemorrhagic stroke, and then less major bleeding, intracranial bleeding, and less GI bleeding. So overall, also here, very similar incidence or very similar pattern as we have seen it in the Aristotle trial. And if you want me to summarize all of the observational studies that are out there, it's impossible. But the main message, and I think from a practical point of view also, the main message is there is no study that goes completely in the opposite direction, really, of what we have seen in the randomized trials. And I think that's important, because that is ultimately what's important for us when we take care of these patients. We can rely on the trial data that we have seen in the randomized trials. As a result of all of this, the new ESC guidelines, and I'm sure these have been mentioned before during the meeting, have given a class 1 recommendation with a level of evidence A for NOACs to be the preferred therapy for stroke prevention and atrial fibrillation. And now you note that in contrast to the 2016 guidelines, these guidelines no longer mention in patients newly initiated on anticoagulation, because that's what the 2016 guidelines still said. So essentially, the guidelines now recommend NOACs as the preferred therapy in all NOAC eligible patients. And this is very similar to the American guidelines, which had been updated almost 2 years ago in early 2019. The guidelines also recommend that in patients in whom you cannot get a good time in therapeutic range, and they mention less than 70%, there's a class 1 recommendation to switch these patients over to a NOAC. There's only a class 2A recommendation to try and improve the time in therapeutic range. And that's for 2 reasons. Number 1, because we all know how difficult this can be. And number 2, because even if these patients are in the therapeutic range, they are not protected from events on an absolute basis. And there are various registries that have been able to show this, and this was also nicely shown in the warfarin arm of the Aristotle trial. So this is now independent of apixaban, right? This is just the warfarin arm, and you can see that the last INR value prior to a major bleeding, an intracranial bleeding, or a GI bleeding, they were all in the therapeutic range. This was not that they all had their bleedings when they had an INR of 4 or 5. The majority had it where it was in the therapeutic range. And the same is true, by the way, also in patients with an ischemic stroke. And the time in therapeutic range was actually quite okay, on average 63 in these patients in the Aristotle in a trial, right? Which shows that this is really a value which is difficult to obtain in daily clinical care. Of note of importance here is that intracranial bleeding, in fact, 80% of the patients who had an intracranial bleeding had their bleed while they had an INR of less than 3. And this is not, all these data are not in contradiction to what we always preach, because indeed, yes, the incidence of intracranial bleeding goes up quite dramatically when you go above 3. The incidence of ischemic stroke increases when you go below 2. But if you take a look at the absolute number of events that happen as the denominator, then the majority actually occurs while patients are in the therapeutic range. So we give them relative efficacy and safety, but we do not give these patients absolute efficacy and safety. And this is a perception problem, because we frequently feel that if we can keep them in the therapeutic range, they are at no risk of events, and that's just simply not correct. Now, moving back to the high-risk patients, and one of the patient population that is clearly high risk is the elderly. They're at higher risk for stroke, they're at higher risk for bleeding, and they're especially at a higher risk for undertreatment. And I think this is particularly important because these patients have such a high risk of stroke. Now, when you separate, again, the 4 NOAC trials to the younger patients, less than 75 years, or over 75 years, you can see a nice and consistent efficacy of all of the NOACs, very consistent in the younger patients. And you can equally see a consistent reduction also in the older patients. You can see, though, that the point estimate is even further to the left in the older patients, indicating potentially an even bigger benefit of the older patients from being on a NOAC versus warfarin. That's important to keep in mind, because these patients, we frequently switch them over to warfarin because we somehow don't trust the NOACs. Also keep in mind, and look at this, 24,000 patients were over the age of 75 in these randomized trials. 24,000 patients. Compare this to less than 3,000 patients with warfarin versus placebo across all age groups. So this is a very good evidence base that we are talking about here. Now, if we take a look at the flip side, the bleeding side, we can again see a pretty consistent effect in the younger patient. But in the older patients, we see again heterogeneity. And in fact, the same heterogeneity that we observed earlier for the overall trial population, in that there was no difference for rivaroxaban and the bigatran, although the point estimate now is actually in favor of VKA, but there was no significant difference. Yet there was a reduction for apixaban and for edoxaban, again observed also in these high-risk patients. Another high-risk situation or risk situation, of course, is renal insufficiency. And this is something that has been on our minds ever since NOACs were introduced. The results are actually quite interesting, because for the bigatran, what we saw for low dose of the bigatran was a very consistent effect for stroke and systemic embolism across the renal function categories here. But when you take a look at major bleeding, in fact, the benefit that was seen for low dose the bigatran compared to warfarin was evident in patients with a normal or mildly reduced renal function, but it was lost for patients with moderately reduced renal function. function. For dabigatran, 150 milliliters, 150 milligrams BID. Also here, the benefit for stroke was the same. And for bleeding, there was also no difference seen for 150 milligrams. Same for rivaroxaban, consistent efficacy, consistent safety, rivaroxaban versus VKA, independent of renal function. And also for edoxaban. Now, for apixaban, it was interesting because there was no signal for a difference in ischemic in stroke across renal function, but there was a statistically significant interaction for bleeding with respect to renal function, but in the other direction than what we had expected, because in fact, patients with a reduced renal function had an even bigger benefit from being on apixaban. And that's worthwhile looking at just briefly in a little bit more detail, because what we can see here, in fact, is that when you look at renal function as a continuous variable, you can see that as renal function declines, the risk of stroke goes up, both for warfarin and for apixaban. That's not a big surprise. Renal insufficiency is a risk factor for stroke. However, you can see that the green curve for apixaban remains below that of warfarin across the range, so there's a consistent effect. For major bleeding, on the other hand, you can see that there is a slight increase only, if at all, for apixaban, I'm sorry, as renal function goes down, whereas there is quite a big increase in major bleeding for warfarin. As a result of that, the benefit in terms of major bleeding gets even bigger for apixaban as renal function goes down as compared to warfarin. So from a practical point of view, I feel very comfortable keeping these patients on apixaban. And in fact, they're similar, although not as good data also for edoxaban. If renal function goes down, because in the past, when I used to switch these patients over to warfarin, then when they went to 40, 35 or so, if anything, I would be increasing their risk of bleeding. Another high-risk population is diabetes, and that was quite an interesting finding in the Aristotle trial for apixaban versus warfarin with diabetes, because you could see that if you take a look at diabetics, there are the solid lines here, there's a big reduction in stroke and systemic embolism with apixaban, even bigger than in non-diabetics. So if anything, from an efficacy point of view, being diabetic is a reason to be put on apixaban because your benefit will be even higher in absolute terms as compared to non-diabetics. What was interesting, though, is that for ISTH major bleeding, there was a big benefit of apixaban in non-diabetics, and there was exactly the same type of, the same degree of ISTH major bleeding in diabetics. On warfarin versus apixaban. Now, this is also worthwhile taking a look at in a little bit more detail, because if you take a look at the safety endpoints, this is what we just showed. There is a very similar rate for major bleeding in diabetics versus, as you can see here, a very similar bleeding rate in diabetics on apixaban versus warfarin, whereas there's a big reduction in non-diabetics. However, ISTH major bleeding includes a lot of bleeding complications that clearly do not have the same implication as, for example, a stroke. So when you take a look at the more severe types of bleedings, for example, TIMI major bleeding, there's also a reduction in diabetics, or Gusto severe bleeding, for example, also there is a reduction in also in diabetics with apixaban over warfarin. So I think this is something important to keep in mind. And then especially if we take a look at intracranial hemorrhage, there is absolutely no difference between diabetics and non-diabetics in terms of the benefit of apixaban over warfarin. So I think that's something important to keep in mind. If somebody has diabetes, that patient will definitely benefit from apixaban from an efficacy point of view, as well as from a safety point of view when we talk about the severe type of bleeding that can occur in these patients. Now, in addition to the guidelines, of course, you know that from the European Heart Rhythm Association, we set up this ERA practical guide. The last version was published in 2018. We're in the process of renewing this, where we've just submitted the 2021 version, and that'll come out in April next year, so stay tuned for that. And we're dealing with those topics that the guidelines cannot really make any firm recommendations because we don't have the big trials out, but situations that nevertheless happen in daily clinical practice. And these are amongst the high-risk situations, like bleeding. The good thing about bleeding is that in contrast to 10 years ago when we were really afraid about bleeding in these patients because we didn't know how to handle them, now we are a lot further. First of all, we know that the vast majority of bleeding complications that happen do not require any severe actions on our side. Mild types of bleedings are easily handled. Non-life threatening major bleedings can usually be handled with substitution, endoscopy, possibly surgery, things like that. But these patients usually survive. The moment you go to life-threatening bleedings or bleeding into a critical organ or space, this is when things get dangerous. But these situations are rare, and they're much rarer, especially than on vitamin K antagonists. In these situations, having a directly acting antidote such as iduricizumab or andexanet alpha is certainly of help. If you don't have that, we also now know that using factors, using the same strategies that we did for vitamin K antagonists, will equally work in these patients. The one exemption is intracranial hemorrhage, but for that, unfortunately, also with vitamin K antagonists, our possibilities are very limited. And fortunately, the risk of that is very much reduced by NOACs compared to vitamin K antagonists. For the remainder of the severe bleedings, also factors we now know work. And one word for direct antidotes, because iduricizumab, as we have seen, is specific, as you know, just for the dabigatran, and is probably as close as it gets to a perfect antidote. It takes the dabigatran out of the equation of a bleeding patient immediately, whether this is somebody with a bleed or whether this is somebody with an emergency operation. However, what you can also see is that after 30 days, after 90 days, there's a substantial mortality in these patients. After a month, 12% of these patients are dead. And after 90 days, almost 19% of these patients have died. And this is not because of iduricizumab. It is in spite of iduricizumab. Iduricizumab is a very good drug, probably the best antidote that we have. But even these patients, if they really have a life-threatening bleeding, there is a chance that things will not turn out well. So the bottom line from this is if you have an antidote available, no matter which one it is, it's a good thing. But I would not recommend to choose a NOAC only because I have an antidote available, because there are other aspects that play a role. And once they do have a severe life-threatening bleeding, even with an antidote, things can go wrong. On the other hand, we see from the Aristotle trial, the outcome after a major bleed with apixaban versus warfarin. And this is interesting because this is now not the incidence of major bleed, but the outcome afterwards. And you can see that the risk of dying after a major bleed on warfarin versus apixaban is halved. It's double the risk. With warfarin, you can cut this down to 50% with apixaban. That's in the Aristotle trial, and that's without any antidotes. So I think that also shows us that even if a bleed happens, the case fatality of such a bleed is lower. And then finally, and this brings me back to the beginning, this is my final slide, we can see that today we are better than what we did back in the past. This is from a large Swedish registry. And this is independent of any drugs or treatment strategies. It's just comparing ischemic stroke rates in 2012 and 2017. And you can see that in 2017 in red, we are facing a lower incidence of ischemic stroke for our AFib patients compared to 2012. And that is, I think, terrific. And what you can really see is that this benefit is largest in the high-risk patients, in the elderly. This is where we have the largest reduction. And at the same time, there's no increase in severe bleeding complications, 2012 versus 2017. Of course, that risk goes up as people get older, but there's no difference. Although there's more anticoagulation, there's a lower stroke rate. And the reason for that is twofold. Number one, the drugs we're using today are just simply better than what we had in the past. But the second part is that all of us, we have been investing a lot of time and effort into educating ourselves, into educating our peers, our residents, our students, our patients, and all of this in conjunction, in concert, really plays out. And I think this is something we can also be proud of a little bit. We're not there yet, but we're on a very good track. So in summary, dear friends, dear colleagues, I think we have seen 2020 NOACs are standard therapy for stroke prevention. This is how it is in the guidelines. This is how it was found in the large trials and observational studies. I think it's important to individualize therapy. There is no one size fits all NOAC. It's a difficult topic. It's a complex topic, but it's worthwhile investing time into because as we all know, AFib is a pandemic as well. And this one is not going to go away within the next year or so. This will stay, and this will be an even bigger problem over the next 10 to 20 years as people get older. We need to include patients into the decision process. I think that's also critical because their expectations might be different than ours. And I think we have also seen, specifically focusing a bit on apixaban during this talk, that this is a NOAC with a very good efficacy and safety profile, also and particularly in high-risk situations. With that, I would like to thank you very much for your attention. Very happy to get engaged again into the discussion. Thank you.
Thank you, Dr. Stiefel. Excellent presentation. So I would request my co-chair, Dr. Reddy, to please lead the discussion. If you have any comment or any question for Dr. Stiefel.
Thank you, Nilan. Wonderful lecture by Jan. You just nicely brought out that of the NOACs indicated high-risk population, apixaban is hitting the sweet spot between efficacy safety. Are there any specific scenarios where the other two NOACs as well match up or even slightly superior? Do you have any specific scenarios like that?
I think that's a very good question and a very difficult question because obviously we do not have head-to-head trials. So it's very difficult to say one NOAC is better than the other because we don't have direct comparisons in the trials. And the observational studies that have tried to do that, like I mentioned, they have to be taken with a lot of caution because those direct comparisons are always flawed and we need to be careful. So we need to extrapolate this a little bit from our from the sub-analyses that we have seen. And I think in high-risk patients, of course, we have seen that for apixaban, they have included a large proportion of high-risk patients, and there's a very good efficacy and safety. Per protocol, rivaroxaban has included almost only high-risk patients, right? And that's something we have to keep in mind, right? Because this is this obviously then also is a subpopulation of patients that we're talking about here. And for the majority, the effect was quite consistent in these high-risk subgroups. But the benefit, on the other hand, didn't seem to be as pronounced as it was for apixaban, especially also when we take a look at the bleeding side of things. So this is why, and also taken into consideration that also in the Aristotle trial, a lot of high-risk patients were included. I think we hit a very good sweet spot with this. The same is actually also true, in my opinion, with edoxaban, but from what I understand, I don't think it is available across India at this point. This is also a NOAC that I feel has a very good risk-benefit ratio for the majority of patients. The Dabigatran, high-dose Dabigatran, like I said, is probably the most efficacious drug. So it's the only drug that actually reduced the subgroup of ischemic stroke, the only one that reduced ischemic stroke. So especially in the very high-risk patients, that might be an option. The availability of an antidote is certainly of help, but like I said, it should never be the only reason. The one thing we need to be aware of, though, of course, with the Dabigatran is that it is 80 to 84% renally cleared. So if we feel that we need this drug, and it may well be of value, it's a good drug, then we need to bring in these patients more frequently, especially if they have renal insufficiency. This was in 1 minute or so, really what we could easily discuss about the entire afternoon or evening.
Thank you.
Respected chairpersons, sorry to interrupt. No, we have to cut short because the BC Roy Award is going on. This hall is being closed for the time being. Thank you so much.
Sorry. Thank you very much. Thank you very much
all.
for having me.
Thank
Great
you.
pleasure as always. Take care, everyone.